look forward to explore the ideal technology with focus on Stylet-driven lead and deflectable mapping catheter. In the, in the right light at the right time, everything is extraordinary. Let's bright up this morning by lighting the Kutvelakku. Now I invite Dr. Richard H. Ongo, Cardiac Electrophysiologist, Director, Cardiology Fellowship Program at California Pacific San Francisco. Dr. Tan Boon Yu, Senior Consultant, Department of Cardiology, National Heart Center, Singapore. Dr. Ullas M. Pandurangi, Chief, Cardiac Electrophysiology and Pacing, Triple M. Dr. Ashish Nabar, Senior Consultant, Cardiologist, Jupiter Hospital, Thane. Dr. K. Chandrasekharan, Senior Consultant, Cardiologist, Department of Cardiology, Frama City. Dr. Anil Saxena, Executive Director, Cardiology. It's my pleasure to invite Dr. Ullas M. Pandurangi, Head of Department Cardiac Electrophysiology and Pacing, Arrhythmia Heart Failure Academy, Triple M, onto the stage for the welcome address and to inaugurate this morning. You welcome you, sir.
So a warm welcome from Madras Medical Mission to all of you. It is such a privilege to have the experts from all around the globe. From the West, we have Dr. Richard Ongo, who was there yesterday also with us. Had a wonderful interaction with our fellows. And from the East, the expert of Agilis, he's pro. He's absolutely a pro in this technology. And we are going to be learning lots about the conduction system pacing using this specific tool, which I also have fallen in love with. We have been using several tools now that Medtronic was there, Biotronic came, and recently Boston came. And now that you have Abbott tools also. We really needed something very sturdy, feels good in hands, and maybe it requires a little more strength, but the way it could be used to go to a place where you want to and drill, I think, guided by those electrodes. You know, we have a wonderful tool, and this whole symposium is to really look at what are the newer technologies we should be using. Are there any kind of a patient selection, or you can just be expert in only one of the tools we are going to be discussing. And then when we see Dr. Tan operating, which he is going to be doing it in 1 hour from now, I'm sure we will have huge confidence in using this tool. I had been interacting with him in the last few weeks. It started from the APHRS. I have not seen anyone who is so passionate about the conduction system pacing in general and using this tool specifically. The very interaction actually made me to be a little more confident in using this tool. Over the coming 2 days, we are also going to be discussing about should conduction system pacing for all, and typically, is it sidelining the established CRT therapy, because there's a lot of buzz about conduction system pacing to be as good, if not much better, than the conventional CRT. So there are going to be topics, I'm sure it will open up some serious dialogues and debates. That's what I'm looking forward to. Our lab is open to any one of you who would like to be witnessing Dr. Tan doing the case. Anytime you feel free to go to the lab. So today we have 2 cases definitely. Maybe we can add up another one. If we do not add, definitely there is one more case for tomorrow. So these 3 live cases which are going to be relayed from our EP lab, you are welcome to interact with the operators, and then there's going to be a simultaneous discussion here. And we are going to be starting with an appropriate topic with respect to the conduction system pacing, and that is we need to be knowing more thoroughly the locations of the pacing sites. And we have John Roshan, the brilliant and the professor of electrophysiology from the prestigious Vellore Medical College, CMC Vellore, that is what is popularly called. He leads the electrophysiology department. He's primarily a pediatric electrophysiologist. In addition to pediatric EP, he does a lot of adult work. And he's one of the persons who had done large numbers of the conduction system pacing as well. So I think he probably will give us better insight about the anatomy of the conduction system relevant to the conduction system pacing. So it's my privilege to have you, John, and let's start with your presentation first. Thank you.
Thank you so much, Dr. Ullas, for the very kind words. So we are a bunch of electrophysiologists, and obviously we are all slightly crazy people, and I'm sure every one of you will agree with that. And more so crazy about attending the meetings conducted by Dr. Ullas, because they're in a different level altogether. So yesterday I was supposed to be leaving home at 9 in the night. And as it turns out, the cab doesn't show up, and then finally the cab comes at 10. And then I get into the cab, and it's a unique cab which has no seat belts whatsoever. And any of you who've been from the Vellore to Chennai highway will know it's like doing a dirt road race. So next thing I do is I say, okay, boss, you carry on. I'll drive down for the meeting. Because under no chance do I want to miss what Dr. Ullas has organized, which is a fantastic feast. So I sort of ended up reaching here around 1:30, and I'm a little zoned out compared to my usual self, but I'm sure you'll pardon me for that. So to start off, I'm very grateful for this topic because it actually forced me to go to the anatomy lab and start looking at hearts all over again. And I think I really benefited by doing so. So I'm very grateful to Dr. Ullas for giving me this very stimulating topic. And it's not a comprehensive anatomic talk. So it's not going to be talking about things in anatomy which I think may not be relevant to conduction system pacing. So I'm just going to deal with just that aspect which is related to conduction system pacing. And it's important to keep in mind that anatomy varies from individual to individual. So no 2 people are the same. So you can't use the same rule for all. So historically, this all started way back in 1893, when this gentleman by name William Hiss Jr. actually said that there's something that connects the atria to the ventricles. And that was essentially the origin of what we call the Hiss bundle today. And then way back in 1906, Keith and Flack actually published this in the Lancet, where they described the sinoatrial node. And at the same time, Tavara described the AV node, the bundle of Hiss, the right and left branches. So the SA node, as we know, is located at the SVCRA junction, which is about 14 into 4 mm in size. It's got ramifications to structures adjacent to it, with extensions into the crista terminalis and the interatrial septum and the pectinate muscles. And it is supplied by the SA nodal artery, which is partly from the RCA, partly from the left circumflex. And it's got intraatrial bundles which conduct the impulses from the SA node down to the AV node. Now, there is also interatrial connections that, as we all know, exist to the coronary sinus, through the coronary sinus os, as well as the Bachmann's bundle. But that's not our subject of interest for today. Today, we are essentially looking at the compact AV node and beyond. So the address for the compact AV node, if you were to look at it, is in this region. So here, there's this patient who's, this cadaver where the heart has been opened up. What you're seeing here being held up by the forceps is the septal leaflet of the tricuspid valve. And this is the coronary sinus os. So adjacent to the coronary sinus os, you will see a tendinous-like structure, a ridge kind of thing, which is your tendon of Todaro. So you have the tendon of Todaro over here, and I'm sorry, I didn't realize the pointer wasn't coming up. One sec. Yeah. So you have this CS os over here. This is the septal leaflet of the tricuspid valve, and you have a ridge over here, which is your tendon of Todaro. So essentially, the tendon of Todaro, the septal leaflet of tricuspid valve, and the CS os form the boundaries of a triangle, inside which lies your compact AV node. Now, the compact AV node can be as close to the CS os as possible or further away from the CS os. That's something that we need to be cognizant about. And it has two extensions, a right inferior extension and a left inferior extension. The left inferior extension goes towards the left atrium, which is on the other side, and the right inferior extension goes in this direction. So when we generally do EP procedures, we are essentially looking at the Hiss bundle, which is located in this region. And we get the Hiss signal from the Hiss bundle. But what we need to be cognizant of is that the AV node is located inferior to the Hiss bundle. And we don't really know in patient to patient as to how lower down it hangs, which means when you're doing your ablations, you should always make sure you don't cross the roof of the CS os, because once you cross the roof of the CS os, you're entering dangerous territory where you don't really know how low the AV node is hanging. So the AV node has got transitional cells at both ends, essentially transitional cells that are there between the atria and the AV nodal tissue. And then there's another transition from the AV node down to the Hiss bundle. So if you look at the transitional cells that are located between the atria and the AV nodal tissue, those are the cells which have the highest rate of spontaneous depolarization. And then the AV node per se essentially slows down and delays impulse propagation. And when you move down from the AV node to the Hiss bundle region, you again find cells which transition over there, and those cells start to look like the Purkinje cells. So they are different from the cells in the compact AV node. And the blood supply for the AV node is usually from the AV nodal artery, which is about 90% from the RCA and less often from the circumflex. And the distal AV node also has branches from the LAD which supply it. We then move on to the Hiss bundle, and this is the famous picture by our very own friend, Dr. Shanmugasundaram. And the Hiss bundle has got two parts to it. Each part is about 5 to 10 millimeters. There's the penetrating part and the branching part. So the penetrating part of the Hiss bundle is about 5 to 10 millimeters long, located close to the mitral ring, and it overlies the atrial part of the membranous septum. So if you look at the membranous septum, it's got an atrial part and a ventricular part. The atrioventricular part is what separates the right atrium from the left ventricle, and that is because the tricuspid valve and the mitral valve are not at the same level. So because the tricuspid valve is more apical compared to the mitral valve, you have a region where the right atrium comes in contact with the left ventricle, and that part of the septum that separates the right atrium from the left ventricle, where we have the Gerbeaud defect. That is the part where you have the membranous septum. And the other part of the membranous septum is between the two ventricles, just below the septal leaflet of the tricuspid valve. So this penetrating part of the His bundle is surrounded by the central fibrous body, and I'll come to that with pictures to explain that better. And below that comes the branching part, and the branching part is defined as the place where the branching starts to the place where the branching is complete. So this segment where branching starts to where branching is complete, that is your branching part of the His bundle. And it's important to note, as Dr. Shanmugasundaram points out very clearly, that these fibers separate themselves much earlier. And there is this kind of longitudinal orientation where they are separated by collagenous septae, and it's because of this separation that happens earlier, which is why you may have a lesion over here proximally, but you may be able to pace distally with conduction system pacing and still result in a narrow QRS. So like I just mentioned, the membranous septum has got an atrioventricular part, an intraventricular part, and it's the septal leaflet of the tricuspid valve that divides these two. So the part above the septal leaflet of the tricuspid valve will be the atrioventricular part, and the part below that will be the interventricular part. The membranous septum is essentially the true septum. So this is illustrating the point over there. So you can see here, this is the RV apex, the RV outflow tract. This is the leaflet, septal leaflet of the tricuspid valve. And what is trans-illuminated over here is the atrioventricular part of the membranous septum. So this is your CS os. This is the region where your triangle of Koch will occur. So your AV node will feed into the His bundle over here, and your penetrating part of the His bundle will sort of enter over here. So this is looking at it from the right side. So from the right side, you see the penetrating part of His bundle coming in over here. It penetrates the interventricular septum, and then you come to the other side, that is the left side, where you have the right coronary cusp, the non-coronary cusp. Below that, you have the interventricular part of the membranous septum, where you have the branching part of the His bundle which gives off the left anterior fascicle, the septal fascicle, and the left posterior fascicle. The right bundle will be located on the other side, which you don't see over in this particular picture. So here, what I've actually done is, with this forceps, I'm holding the septal leaflet of the tricuspid valve. And you see another forceps that is coming just above the septal leaflet of tricuspid valve. It's essentially coming in the atrioventricular part of the membranous septum. So this is the right ventricle that has been opened out. The right ventricle has been opened out, and you're seeing the septal leaflet of the tricuspid valve. This portion here is the right atrial side. This is the right ventricular side. Just above the septal leaflet of tricuspid valve is where this particular forceps is poking and coming through. So it's coming through the atrioventricular part of the membranous septum. So where am I poking it in from is the next thing, and I am essentially coming in from the left side. So this is where I'm poking in from. So I'm poking in from just below the right coronary cusp and the non-coronary cusp. So I'm poking in from just below the right and the non-coronary cusp, and I emerge in the atrioventricular part of the membranous septum. So that's exactly on the other side. So this region is membranous septum. The exact other side, which I just showed you earlier, is also membranous septum. Just above the tricuspid valve is your atrioventricular part of the membranous septum. So here you see a heart which is being held with the inferior surface being seen. So the heart, as we all know, sits on the diaphragm. So the surface that is sitting on the diaphragm is the inferior surface. I've sort of turned that over and I'm showing you. So what you're essentially seeing here is, you see the right ventricle on the right side, the left ventricle on the left side, and that's the right atrium and the left atrium, and the IVC. So this is your atrioventricular groove. This is your right coronary artery coming down like this and giving off the posterior descending artery. So what you're seeing here is, you're seeing the two atria overlying the two ventricles. If you were able to remove these atria, you would technically see the tricuspid annulus over here, the mitral annulus over here. And it's important for us to understand that the aorta is like a tube that is shoved down into the heart. So you have the atria and the ventricles, and the aorta sort of shoved right in the middle and sort of squeezes itself between all these chambers. So that's how the aorta is. It's sort of in the center of all these things. So you don't really see the aorta over here, but if I was to remove these two atria, then you would actually start seeing the aorta coming in, which is getting shoved in right in the center. Now, important to note that this right coronary artery which comes down like this, just as it gives the posterior descending artery that's going down, it will give the AV nodal artery which sort of climbs up. And the AV nodal artery will climb up over here, so you will have the tricuspid annulus here, the mitral annulus over here, and in between that, you will have the AV nodal artery that's climbing up towards the address of the AV node, which is in the triangle of Koch. So this is illustrating the same point with the atria removed. So here you can see the right coronary artery coming down over here and giving off this small AV nodal artery, which moves towards the triangle of Koch region. You can see the aorta that has been shoved right in the center. So the aorta is sort of over here. You've got your tricuspid annulus here, your mitral annulus here. You put in a light in the aorta, trans-illuminated, you will see both the tricuspid and mitral annuli getting trans-illuminated, and you will see the atrioventricular part of the interventricular septum, the membranous part, that is also being trans-illuminated. So this bright yellow over here is the atrioventricular part of the membranous septum. So now that we have removed the right atrium, it is over here that you will have your penetrating bundle of His coming through, and it will come over here and you will see the branching His bundle giving off the left bundle branch fibers over here. The right bundle branch will be just on the adjacent side of it. Now the other point to note is that this region, which is sort of darkish in color and not trans-illuminating as much as the atrioventricular part, that is your central fibrous body. So that's sort of like the skeleton on which everything else is attached. It's sort of like the anchor. So this central fibrous body has got the aorta attaching to it. It's got the mitral annulus attaching to it. It's got the tricuspid annulus attaching to it. And the AV nodal artery sort of climbs up through it to supply the AV node and the His bundle. So you can clearly understand that the penetrating bundle of His, which is coming through here, is going to be surrounded by the central fibrous body. And obviously, if there's going to be disease involving the aortic root or the mitral annulus, it is going to affect the conduction system, because the penetrating bundle of His and the branching bundle is all going to be located over here. So we move on from there to what are the pathologies that affect the conduction system. And obviously, if you have disease involving the mitral annulus, so this is a mitral annulus, and this is your interventricular portion of the membranous septum through which your branching part of the His bundle comes, which gives off the right bundle on the other side, left anterior fascicle, septal fascicle, and left posterior fascicle. Now, it's important for you to understand that the fibers destined to form the left posterior fascicle take off very early. So they're sort of separated out already as they're coming down over here. And also good to understand that the left anterior fascicle and the right bundle branch, which you don't see in this section because it's just adjacent to it on the right side, are sort of very close to each other. Which is why when you see bifascicular blocks, you always see right bundle branch block and left anterior fascicular block sort of happening together in patients, because these are very close to each other. And the left posterior fascicle fibers actually take off much earlier, which is why that gets spared. So when you have mitral annular calcification over here, you're going to affect the penetrating His bundle, and you are likely to cause a complete heart block. When you have calcification involving the aortic ring, which is over here, particularly involving the right coronary cusp and that region, you are likely to cause a bifascicular block of the right bundle branch and the left anterior fascicle. The other thing to note, like I said, is anatomy varies from person to person, and so the membranous septum's size can vary. So you can have a large area of membranous septum or a small area of membranous septum. And depending on how large the membranous septum is, will determine the distance of the aortic valve from the penetrating and the branching bundle of His. So if you have a larger membranous septum in a given individual, then the chance of his conduction system being affected during aortic valve surgery is less. Whereas if somebody's membranous septum was small, then the chance of it getting affected during aortic valve surgery is more. So that's again something to keep in mind. So this membranous septum can be much larger, in which case this fibers will take off lower down and which will be further away from the right coronary cusp. So now this is actually a picture which looks at getting to the region of the membranous septum. When you actually look at it and you actually look at the heart and you think of doing His bundle pacing, it's sort of amazing that we're even able to go anywhere near that site, because it's not an area that's easy to access. It's sort of, your catheter sort of comes like this. Either you can just go in the atrioventricular part like this, or you go past the tricuspid valve and then have to bend over to come to the same point. So that would be sort of the membranous septum where the His bundle is located. The same area can technically be accessed even if you came down the aorta and came to the right coronary cusp, non-coronary cusp junction, or came past the aortic valve and then bent upwards to reach the same zone. So there are 4 ways in which technically you can reach that zone where you have the His bundle. But as you know already, the His bundle is surrounded by the central fibrous body, and that is the problem with His bundle pacing, because your thresholds can climb up quite easily. There's fibrous tissue all around it. You need to exactly come in contact with the His bundle to result in good, reasonable thresholds and good capture. So your target zone is very small. The other point I wanted to illustrate was this region where you have the His bundle is at the very crest or the very top part of the interventricular septum. So your interventricular septum, you go to the very crest of it or the crown of it, and that's sort of where you have this His bundle and region of interest. So this is essentially looking at two different individuals and the varying anatomy. So here you can see a triangle of Koch here where you have your CS os, and this is another triangle of Koch again. Here's your CS os, here's your tendon of Todaro, and here's your septal leaflet of the tricuspid valve. Now what you see over here is that your AV node is located further up over here, whereas in this case your AV node hangs much lower down, which is the point I was trying to make earlier, in the sense that when you're doing your ablation for, say, AV nodal reentrant tachycardias, you will essentially be very conscious of your His bundle because you get your His bundle signals, and you want to be away from the His bundle signal. But it's important to note that your AV node is located inferior to the His bundle, and how inferior it hangs is something that varies from person to person, and you don't really have a marker for the AV node. So you have to be very cautious when you ablate anywhere above the roof of the CS os. So once you cross that boundary, you have to be very careful about it. So this is technically sections going through this region, and you see here that this pink thing that is surrounded by the blue is the central fibrous body, which is the fibrous tissue, and here you see the penetrating bundle of His, which is at the level of the septal leaflet of the tricuspid valve in this particular patient. Whereas in this particular patient, where your penetrating bundle of His is happening over here, your septal leaflet of tricuspid valve is distant from it. So it varies from person to person, which is something to be conscious about, which is probably the reason why it is not always easy to get His bundle pacing in different individuals, and it also makes it challenging to do His bundle pacing from the atrioventricular aspect of the membranous septum, because your His bundle may not be there, it may be further deep down in, and secondly, you will also have atrial pacing that can happen when you attempt to do it from the atrioventricular portion. Same way, the His bundle's relationship to the septal leaflet will vary, as you can see here in 3 different cases, A, B, and C. In this particular case, you have the penetrating His bundle located far higher than the septal leaflet of tricuspid valve. Here it is at the level of the septal leaflet of tricuspid valve, and here it is inferior to the level of the septal leaflet of tricuspid valve. So these are some of the challenges which makes His bundle pacing difficult when compared to left bundle pacing. Left bundle, in comparison to the His bundle, is a much larger target. So here you can see the green is the His bundle, and this leash of fibers is technically the fibers that take off from the left bundle branch region. We obviously want to be as proximal as possible so that we can sort of simultaneously activate all these fibers rather than going distally. So the left bundle technically divides into the left anterior and posterior fascicle, each of which goes to the respective papillary muscles. The left anterior fascicle is a thin tendon-like structure, whereas the left posterior fascicle has multiple fiber bands and Purkinje fibers which sort of arborize. So here you see the right coronary cusp and the non-coronary cusp, and just below that comes out the left bundle, which gives off, now you should understand that this heart has sort of been opened up. So the left anterior fascicle actually should be sort of closer if you actually close that flap over it. So this is the left anterior fascicle and this is the left posterior fascicle. And you technically would like to sort of pace in this region. You don't want to go too distally. And all of us are familiar with doing fascicular VT ablations. And it's important for, when you sort of look at the pictures, we sort of get this wrong idea where it shows the left anterior fascicle sort of going off horizontally and the left posterior fascicle going vertically down towards the septum. In truth, it's not like that. The left anterior fascicle also sort of courses downwards. And all of us who've done fascicular VT ablations know that there have been times when we sort of tagging the left anterior fascicle potentials thinking it's the left posterior fascicle because it's sort of coming downwards. It's important to realize that you need to sort of come really septal to get the left posterior fascicle. And the left anterior fascicle is sort of diagonal to it, but is also going downwards. So this is the left anterior fascicle sort of going downwards. And if this flap was sort of closed over the heart, you would see that it's actually going more downwards than horizontally. So this is more for completion about the right bundle branch, which is located on the right side. So technically, it's just on the from the place where the branching bundle of His gives off the right bundle fibers. They sort of course through the interventricular septum, which is a short intermuscular course, and then it emerges from the base of the medial papillary muscle. It travels along this thing, which is called the moderator band, and it travels towards the anterolateral papillary muscle. So this is your anterolateral papillary muscle. This is the moderator band. So it comes through the in the interventricular septum intramuscularly. Then at the base of the medial papillary muscle, it takes off through the moderator band, which goes towards the anterolateral papillary muscle, and here it branches into Purkinje fibers. So this is again showing the same thing. This is a heart where you have the front part of the right ventricle removed, and the moment you remove that, you can see your moderator band over here, and this is your anterolateral papillary muscle. So the right bundle is technically coming this way. So if I tilted the same heart upwards, where I have taken off the front part of the right ventricle, you sort of can see this region, this black region which leads on, and that's technically going towards the RV outflow tract. So there's a small bulge over here, which is the bulge of the aorta, and so essentially when you are doing, want to get to the His bundle region, you sort of come with your catheter down the SVC, and then you sort of want to reach this zone. So you will often find that some people will sort of go into the RV outflow tract, and then they'll pull back with the hope of sort of locking onto this zone. So this probe is actually going through the RV outflow tract. And here you can see the moderator band. This is the anterolateral papillary muscle. And this bulge that you see right at the top is sort of here is essentially where you have the membranous septum, which is right below where the right coronary cusp and the non-coronary cusp lie. So this is with it completely removed. You can see the tricuspid valve septal leaflet is over here. This is sort of where you have the aortic bulge. This is the RV outflow tract. This is the right ventricle. So it's quite remarkable that we are managing to pace patients with conduction system pacing, and credit to the industry for developing these great tools, because otherwise coming down from above like this and sort of trying to lock in over here for His bundle pacing, or even in this region which is just proximal to it for left bundle pacing, is not going to be so simple. And you can also appreciate why it is so easy that our catheter, if we just move it forwards, will move into the RV outflow tract. And in fact, like I said, some operators like to go into the RV outflow tract and then pull back so that they sort of lock into this region. So you don't want to go too apical, because like we just saw, the left bundle fibers fan out. You want to be more proximal in this zone to do your left bundle pacing. So this would technically be the zone where you like to do your left bundle pacing, and that sort of adjoining the tricuspid leaflet where your membranous part of the septum comes, either the atrial or the ventricular aspect will sort of be where you want to do your His bundle pacing. So this is again a forceps that is going just below the septal leaflet of the tricuspid valve. So this is the right ventricle opened up. This is your septal leaflet of tricuspid valve. And immediately below that, if you went, you will be going again to the interventricular aspect of the membranous septum. But if you go a wee bit below that, is sort of where you would want to do your left bundle pacing. So this is essentially coming out on the left side from that zone. And this is technically, as you can see, you will understand, you have the right coronary cusp and the non-coronary cusp. Below that, over here will be technically where your branching part of the His bundle emerges, and then sort of here is where your left bundle fibers take off. So this is technically the area you want to target by doing left bundle pacing. So you're reaching this area from the right side. So you sort of go below the tricuspid valve and then start screwing into the interventricular septum from the right side, and you emerge out. You don't have to emerge all the way out, obviously, but that is sort of the area where you want to pace. So just to give some more concept of the anatomy, this is basically looking at the heart from above. You can see the left atrium over here, the aortic valve, pulmonary valve, SVC, right atrial appendage. So this is the same thing over here. You see the aortic valve and the right atrial appendage over here. So this is sort of going deep in. You can see the left coronary cusp, right coronary cusp, non-coronary cusp, and you see the right atrium around it. And behind is the left atrium. So when you sort of go deeper in here, this is opening up the right atrium and looking down through it. You will see all the way down, inside it comes your tricuspid valve. This will be the septal leaflet of the tricuspid valve. This will be the zone of the AV node. This will be the zone of the penetrating bundle of His. And like I just showed you earlier, this is the aorta, and deep down in the aorta, we did see the coronary cusps. So that will be the exact opposite side of this. So this is just to sort of give you some better concept of the anatomy. So with that, I will finish my talk. Thank you so much for your patient hearing. Technically, important to note that anatomy can vary from person to person, and it is important for us to understand anatomy, which helps us recognize and understand pathology better. Thank you.
Thank you, sir, for giving your valuable insights. Now I call upon Dr. Tan Boon Yu, Senior Consultant, Department of Cardiology, National Heart Center, Singapore, to share the technique on Stylet-driven lead and deflectable mapping catheter in conduction system pacing. And I also invite the moderator, Dr. Anil Saxena, Executive Director, Cardiology, Forts Escorts, Hearts Institute, New Delhi. And Dr. Ashish Nabar, Consultant Cardiologist, Jupiter Hospital, Thane.
Hello, good morning, everybody. Thank you, Dr. Ulhas, for the invitation, giving me this opportunity to talk to everybody about pacing techniques and what I use for the Agilis His Pro. I think that's what we are doing here today, and we're going to go through some of this. I understand that some of you have actually seen my talk before on the Agilis His Pro, so it'd be a bit boring for you. You've gone through this before, but for everybody else who's not, hopefully this will give you a bit more insight into the Agilis His Pro, as well as the lead that we use to deliver our system, or the Abbott system, to the left bundle area, as well as the His area, okay? So we all know this slide before, we published this before, and basically they are all different kind of models, different kind of approach from different companies to how to reach the His position, as well as how to reach the left bundle area. The Medtronic system is by far the most commonly used because it was initially introduced. It was the first to be introduced. They use the C315 sheath. For all those who have used this before, it's a fixed curve sheath, and use a tiny little 3830 lead that is only about 1.4 millimeter with a fixed extended helix to get to the His position, as well as to penetrate the septum to get to the left side. Then came the Biotronic Solia system. Now, they started using they were the first company to start using the Stylet-driven leads with a retractable as well as extendable helix system to deliver a lead to the His position as well as the left bundle area. Now, they use a few approaches to this, and they tried to adapt it to be similar to Medtronic system. And how they did it was actually to deploy the helix. And if you've used the Biotronic system before, is that they deploy the helix first, and they use the Stylet guide to actually try to fix the pin and fix the helix in an extended position and to rotate the lead body so they can actually start drilling through, be in the His position or towards the left bundle area through your septum. The Abbott system is actually quite different, and it's a lot bigger. It's got a deflectable sheath, and I'll show you a picture of that and more details on how I actually use that system, as well as their tendril lead. Again, it's a Stylet-driven lead with the retractable and extendable helix. Now, we'll go through that in a little while, how we actually use this system. Now, again, looking at the His Pro, for those who have used this before, you're very familiar with it. It's a 38 centimeter working length. It's got a connector system at the end, gives you the advantage to connect to your EP system, so you can actually paste as well as map where you want to paste. Now, it was originally designed to get to your His position to give you that kind of support, as well as to map and maintain that position and support at the His position, so you can actually drill through. Now, we saw anatomy-wise, the His position is actually a very tiny area for you to hit. So it was actually originally designed to do that and do that very well. It also has a three-way tab at the end of it, and you can do septograms with that if you so choose to do so. Now, that's the little handle at the end, which is a little blue knob. That knob allows you to actually deflect the tip of the His Pro. It can go all the way up to 180 degrees. Now, if you take a look at it, there's a side port there. That side port has a hemostasis valve where the lead actually goes through, and a little bypass tool. Now, I'll show you how we use that, and it's quite important that you are aware that there is a bypass tool to bypass a hemostasis valve to allow your lead to go through, and that's a top view of the His Pro, where when you slit down through that gap, and there's a light blue as well as a dark blue area for the His Pro. Now, the light blue area serves as a rail for you to keep your slitter in position, so you slit all the way towards the end of the His Pro. Again, this is a close-up view where the bypass tool is taken out and the lead goes through to the hemostasis valve. This is the end of the His Pro. It's got 2 platinum iridium electrodes, and you have a closer look at it, and that electrodes allows you to paste as well as to map where you want to deliver your leads. This is how you do that. By clocking that little knob, the little handle there at your handle, you can actually deflect the tip of your His Pro. Now, this is completely undeflected. At 90 degrees, it gives you the first bend, and at 180 degrees, it makes 2 90 degrees bend, and out with the 180 degrees bend. Now, keep one thing in mind when you initially deflect that, the first 90 degrees is the proximal bend that occurs first. So when you're using the His Pro, and I'll show you a picture of that, when you get to the atrium and you first use the first deflection, the first thing that His Pro is going to do is go septally immediately, and will go straight into the CS. Actually, it tends to go into the CS very, very easily. And this is a big sheath. So please be careful. Often what I do is that when you get into the atrium, connect your His Pro first. So when you deflect and you end up in the CS and you get a CS EGM, stop, get out. You don't want to go in there. We already have very bad experience with that. You can dissect your CS because it wants to go into the CS. Now, the reach. The end of the His Pro makes 2 90 degrees bend. It gives you a 4 centimeter reach, and at the end of it gives you, I don't have that, there you go, give you about a 3 centimeter reach at the end of it. Now, perfect for working in the atrium. 4 centimeter atrium, any size of atrium, you're perfectly well. You're good to go, okay? What they're trying to do is to deliver the tendril lead, and this is just a standard tendril lead. We've used this for conventional pacemaker repeatedly, but we're going to use it very differently now. But before we use it, we also need to understand how the tendril lead behaves. Now, the tendril leads, it's about 10 centimeter between the helix as well as the ring. That helix that has a 10 centimeter sits in a housing, and that housing is very, very stiff. Now, this top view here shows with the helix, with the stylet out, and I'm trying to bend the tip of your tendril lead. When you bend it, you can see it doesn't bend beyond that 1.5 centimeter mark. This entire housing here is a piece of metal. It's fixed from the tip all the way to the ring. Now, if you put the stylet in, it makes an even stiffer lead, and it's almost at the 3 centimeter mark before there's any discernible bend to it where you can actually flex that lead. Now, that's important when you put that lead into His Pro, at which point is it going to give you stiffness and how much maneuverability are you going to get. The second important point when you see this image is that even when the His Pro is in close proximity to your septum or your His, you got that 1 centimeter sticking out of your His Pro, the mouth of your His Pro, that is still stiff. That lead is still stiff. So it can still give you that kind of support with or without stylet in it, that extra 1 centimeter reach at the end of it for you to drill through. Now that's very different from your Biotronic Solia system, as well as the Ingevity system in the Boston Scientific system. So I'll show you a picture of it in a little while, okay? So this is how we do it. 10.5 French sheath, short sheath in the shoulder, run the Agilicis Pro through over the wire technique with the dilator. Once they're in the atrium, we took the dilator and the guide wire out. Connect your Agilicis Pro immediately. Now, some of my colleagues will put the lead in at this point in time without connecting the Agilicis Pro. I like to connect the Agilicis Pro almost immediately when I get to the atrium for one simple fact. When I start to flex, it's going to go to your septum. I don't want you to go anywhere in the septum. I want to know where exactly I am. I'm going to start to map immediately. Now, that's where the Agilicis Pro gives me the advantage. Now, once in the atrium getting to the his, and I won't spend too much time here, it is uniquely designed to get to the his. And what it does is actually it makes that curve. That curve sits at the bottom of the RA, and it has 2 supporting points. One is in the septal part, RA inferiorly, near the tricuspid valve. The second part is actually the posterior lateral part of the atrium. Because of that double curve, it lets it sit there so that the mouth points up towards your his. And that's where we're going to go. Now, in that position, if we counter the Agilicis Pro, it goes away from the septum. And if you clock it, it goes back towards the, counter, it goes towards the septum. And if you clock it, it goes away from the septum. Okay, sorry about that. Okay, so it's a little bit like that. And this is a model heart with Agilicis Pro going through that. If you counter, you see the tip goes towards the septum, but the back end, the initial curve, goes more laterally. But if you clock it, you free it from the septum, more towards tricuspid valve. And this is the position you want as you clock so that you can actually unflex and go towards the RV for you to do left bundle area pace. So basically at the handle, you're just counter and clocking it to free it from the septum or go towards your septum, okay? But that's not the end of it, right? Going to the his, that's the easy part. But we know there are difficulties when we attempt to pace at the his, and we retouched a little bit about it when we talked about the anatomy. At the his position, we have got a lot of problems with it. It's where it is addressed by the left bundle area pace. Going to the left bundle area, when we want to do deep septal and going to the left bundle area, we have certain advantage because the area is a lot bigger, higher success rate compared to the his because we have a bigger area to hit. Typically has a low capture thresholds. We know that already. It's got good sensing parameters. And it does not require backup pacing because we are a bit more distal. So even if there's a block, I don't need a backup RV lead. As well as if you do an AV nodal ablation, I don't have to worry about it affecting where my lead is positioned. Now, how we do it has been described many times already. I won't go into that already. You can actually read Dr. Huang's paper, and he went through the sequential steps and how we actually do a left bundle area pace. I'm sure we'll be demonstrating that when we do the procedure. And basically, you just go to the fluoroscopy. You can go to the his position. Typically, I don't even bother to do that. Once you get to the his position, about 1.5 centimeter lower and towards the apex, you can start pacing. And once you get the W sign in V1, discordant in 2, 3, as well as AVR and AVL, that's where you want to be, and that's where you start to drill through. Now, the evidence for left bundle is accumulating. There are more and more data and more publication on left bundle area pace. But how do we do it? Now, the original way was actually described was using the C315 and the 3830 with the Medtronic system. They were the first people who actually start using the C315 and 3830 to get to the left bundle area. Now, basically, if I'm going to punch through a 1 centimeter septum, what I want to do is to use a rapier, right? Something that is sharp, tiny, fixed helix, stuck out all the way, pointy end at the end of it, and just punch right through my septum, get to where I want to get to. When we first had the Agilicis Pro and they gave me a 1.8 millimeter stylet-driven lead, I thought what they were giving me was a telephone pole. Really, something big, something stiff, trying to punch through a septum that size. Now, it wouldn't be something I want immediately say, hey, look, I'm going to be successful here because it's just so big. There were a few issues I realized that we actually had to deal with. And if you try to use the Agilicis Pro as is out of the box and say, hey, look, this is actually designed for going to the his, get the his position. Now I'm going to use the same design without doing anything to it to get to the left bundle. you're going to be in trouble. Okay, it was never designed to go to the left bundle. We had to repurpose it. Now, the good news is that the Agilisys Pro allows us to actually shape the catheter. Now, there were a few issues we needed to address first. The first was to reach. How can I get to the RV when it was never designed to go to the RV? We could not reach the RV because when you do the double curve, you only get a 4 centimeter mark. You can get to the tricuspid valve annulus, but you will never be able to get through the tricuspid valve annulus towards the RV because it's just not long enough. It's just impossible. Unless you've got a very tiny heart or a very tiny atrium. Okay, but by and large, it's actually a lot of difficulty trying to get through that. And how you overcome that is just to shape it, give you an extra curve, more proximally. And that curve is purely designed to get through the tricuspid valve. That's all you want to do. Now, where you actually make that curve, it varies between different individuals. If you have a big atrium, make a bigger curve. Smaller atrium, make a smaller curve. Now, the whole point of it is that when I do it, I want to get to the tricuspid valve. Often, because Agilisys Pro has a different planes, you make a slight flexion first. Typically, this is what I do. Once I make the slight flexion, I know where the plane is going to curve. Then I make that curve. And this is just a video of me making that curve. And this is as long as it takes for me to make it. Do it with the Stylet in, with the dilator in, make that curve. And that's approximately the kind of curve I want to do. And that's a model heart down there. And what that curve does is allow me to go through the tricuspid valve and end up in the RV. But we still have another problem once we get to the RV. If you look at the mouth of that sheath, the Agilisys Pro sheath, it's pointing straight up. You're never going to go through the septum that way. It's not going to work. I needed another curve. And that was a septal curve, a bit like a Mons curve. And this is time it takes me to actually do it, real time, the videoing myself. And I'm just making that septal curve. Once I get the septal curve, you can see the model of the heart above on the right-hand side. That curve actually maintains quite well, even without the dilator. And now I can get not only to the RV, I can also get to the septum and maintain my position in the septum to allow me to get my lead into position. Now I've reached there. I got a second problem I need to deal with. I've got a 58 centimeter stylet-driven lead with a retractable helix. It was never designed to stick out in the first place, and it's going to retract. How in the world am I going to deliver torque 58 centimeter outside of the body and make 58 centimeter later that lead at the tip start to rotate? I have a problem. On top of that, I'm in a sheath. Now, there were a few points of resistance. The first point was actually at the hemostasis valve, where the valve actually crimps onto the lead to prevent blood from leaking back. But in this situation, it's actually hampering your ability to transmit torque from outside the body towards the tip of the lead to allow you to drill through. Now, how we overcome that is simply to put the bypass tool in to reduce the resistance. And you don't get much of any flow back or blood flowing back that way. Now, this is a video of us using with and without the bypass tool. The video on the left is me turning like crazy with the bypass tool out. And you can see it's moving, but not very smoothly. The video on the right is where I put the bypass tool in, and I'm just rotating it. And it's just going very, very freely. Okay? But that's not the end of it. We've got another problem with regards to transmission of torque. The amount of bends you create in your sheath. Now, we're creating even more bend now with the septal bend and everything. The more bends you create, the more resistance you make. Because each and every bend actually causes a point of contact between your sheath and your lead. But in order to reduce the amount of resistance that you get and allow you to transmit torque, we need to pull the stylet back. Now, why that is that if you have a lead, imagine a stylet-driven lead, with the stylet all the way to the end and the tip of the lead. That stylet was never meant to rotate through two 90-degree bends. How in the world are you going to make a stylet rotate that way, transmit torque from one end to the other end after making so many bends? Okay. Now, what we did was just simply to pull the stylet back. So again, this is a video of us doing this. Now, the first is just with the stylet all the way in. And the video is running. Trust me, I'm just giving a lot of torque, trying to rotate that, and you see the flag is just not moving at all. The second video is me pulling it back just beyond the first curve, the distal curve, just pulling the stylet back about 4 to 5 centimeters. Now it's trying to move. It's trying to, me putting a lot of torque there, but it still can't. And the final video is me pulling it all the way back beyond both that curves. And you can see it's actually moving very, very freely. Okay, we had no problems at all rotating and transmitting that torque. In other words, the more bends you make in your sheath when you deliver it, pull your stylet back as far back as wherever bends you've just created, because that's going to increase resistance and impair your ability to transmit torque distally. Okay. So now I can get there. Now I can transmit torque. Now I can start drilling. I have a third problem. Now this problem does not apply to the Medtronic system because the helix is extended already. This problem applies to all stylet-driven leads because now that helix, not only can it extend, it can also retract. And when you start to clock the body of the lead, the helix starts to retract. Now, I had a lot of trouble trying to understand why would it even do that. I thought if you just clock it, you're going to make that helix extend even more. But that's not the case. No, it doesn't. It does that simply because that lead was designed to not to rotate the body at all. It was designed to put the lead into a septum or wherever you want to deploy your lead. The body does not rotate. You rotate that helix through the pin at the end, and the helix is extended into the myocardium, and that's where it bites into the myocardium and maintain position of your lead. As you start to rotate the body of the lead instead, something else happens. The body will rotate, but the helix doesn't move because it's tacked onto the muscle anyway, and that's going to start to be retracted instead. And the reason why that happens is because this is a coaxial design, and this is by and large how tendril works. You can see there's an outer insulation. Outer conductor coil goes to the ring of the housing, then an inner insulation, and an inner conductor coil that goes towards the helix of that lead. Now, those images, those videos on the left side is me cutting it up. Now I'm grabbing the inner conductor coil, similar to me using the clips in the distal end and rotating just your pin. Now you can see from the top image, I'm rotating the inner conductor coil. The helix comes out. Okay, it's sticking out now. At full extension, if I continue to rotate the pin, the housing starts to clock, and the body will start to clock. In the lower image, it's full extension. Now I'm countering it. Helix starts to rotate back. Housing does not counter until full retraction. Then the body starts to counter. Okay? But what if you rotate only the body? We don't touch the lead. They don't touch the helix at all. And what's going to happen is this. If you take a look at, I'm countering the body now, just countering the body. That means the housing is going to start to counter. You can see the helix being extended now. That's full extension. And when I clock the body, the housing will start to clock, and the helix gets retracted. Okay, so that's something to keep in mind, because this is how that lead is going to behave. In fact, that's how all stylet-driven leads with retractable helix will start to behave. And somehow or other, we've got to overcome this. Now, another way to look at it is just us trying to, use a bigger model to help me understand. Taking a screw, couple of nuts in it. If I counter just the nuts externally with the flag, countering it, you can see the screw is being retracted. At full retraction, if I continue to counter, then that screw will start to counter with the entire body. Okay. But again, this is not a good idea, because if you start to counter, you can imagine there's a piece of muscle stuck at the end of the helix. And basically, you're just really cupping it and dragging muscle tissue, myocardial tissue, into the housing. Now, different companies came up with different ideas to try to overcome this. The Biotronic system, as I mentioned already, they use the Stylet guide. The Stylet guide, and with the Stylet in there, obviously, is somehow or other able to prevent that pin from rotating, and it's able to fix the pin with the body of the lead. So when you rotate the body of the lead, it rotates as a unit. The Boston Scientific system came up with a similar idea. They used a Stylet guide again, but instead they used one of those rubber caps, the lead caps, to cap the lead. They cut the end off. And what they're trying to do is very similar to the Biotronic system. That means you've got a Stylet guide as well as a lead body, but they add on that cap to hold both units together. So when you rotate the body, that helix is not retracted. The helix will move in a clockwise manner, similar to the body of the lead. Now, for this group anyway, how they approach the Abbott system is quite different. And what they did was actually just to clock, and they are going to clock just the pin 20 to 30 times in a clockwise manner and try to drill through the septum by repeatedly just clocking the pin. But there is a problem when you do something like that. And that's the video of me doing it there. Okay, if you can see that, okay, I'm going to let it rotate back, okay, and then I'm going to start all over again. You can see I'm clocking just the pin, and the helix is coming out now. But as it comes out, you realize that the body is also being clocked. At full helix extension, probably about 5 to 8 rotation through the pin, all you're doing is rotating the housing. And because the housing is being rotated at the tip, because you're countering only at the pin, you're building a lot of torque in the body of that lead. And that torque cannot transmit back, because you know what? It's 58 centimeters away, and you got all those sheaths in between that is fighting you. It's giving you resistance. Now, as that goes along, you can see it's building so much torque that at the end of 20 to 30 clockwise rotation, and you take away that clip, it immediately starts to counter. And you can see that, and that's quite scary, because when it counters, that helix is fully extended and is countering at the same time that you are. So please be careful when you give so much torque, and if you take that clip off and it does that counter spin, this is what is happening to the end. It's countering all the way out. And likelihood are, you can only imagine, wherever that position may be, you're going to get dislodgement, for sure, because it's countering itself out, okay? So what we do is that we do it in a stage-wise, in a slow manner. Extend your helix first, then rotate your body. Extend your helix again, rotate your body. And the idea here is that if I extend the helix, I move forward a bit, I rotate your body, let the body and the top, everything catch up towards the end. There will be some retraction. If you see retraction, extend your helix again, then rotate your body, and go in a stepwise, very slow manner. And you keep flooring your way as you go along. Very different from the Medtronic system where they tell you just go very fast initially and just drill right through. But you can't do that with a Stylet-driven lead, especially when the helix can retract when you start to do things like this. So again, basically what we're doing is this. With the video at the top, we put a little tissue paper at the end of it. And as I rotate, the helix is being retracted. And as it retracts, some of the myocardial tissue starts to get into the housing. When I see that being retracted, I stop, extend your helix, it drills in a bit more. Then I rotate the body, and I keep doing that in a stepwise manner. It doesn't take a lot of effort. It just slowly, and we move our way, we can drill right through. But there are also lessons we can learn from the 3830 lead. That means with a fixed extended helix. Again, this is from a Polish group, and what they did was in cadaveric heart, attempt to drill through the septum using the 3830, as well as a sheath, their sheath, the C315 sheath. And they describe a few possible outcomes when the lead doesn't go through. One is the entanglement effect, or the endocardial barrier effect. That means there's a fibrous tissue in the endocardium, and as the lead starts to drill through, it tries to wrap around the lead. As you can see, that 3830 being wrapped around there. And no matter how much torque you apply at that point in time, all you're going to do is just increase torque, crimp the insulation. Now, if you see something like that, forget about the area, just get to somewhere else. Not so easy with a fixed curve because you have to rewire, reposition. But with Agilis Pro, very easy. Just extend it a little bit, move it forward a little bit. You can move very easily. The same thing can happen with the Agilis as well as your tendril lead. You can see that the muscle is actually wrapping around the tendril lead as well with entanglement effect. They also describe a drill effect. That means as you drill using the 3830, it looks a bit like a drill. Right? You drill a hole, the whole lead just falls out with a little bit of myocardial tissue in it. With Stylet-driven leads, this thing happens because we are not paying attention to the helix retraction. You can appreciate that this is a 38, this is the tendril lead. As you start to drill in, it falls out and you make a hole in the myocardium. Now, this is a porcine heart that's doing this. And it actually falls off with a piece of muscle stuck in it. And you probably realize this as well. There's only maybe 1.5, less than 1 helix extended out. And that's because we're not paying attention to it being retracted. And as it starts to retract, you're actually ripping off a piece of muscle, and all you're going to get is a drill effect, and that lead falls off. So fluoro, make sure you know where you position it, make sure the helix, and do it in a stepwise manner. And this is us doing it. Now, first thing to take home is that it was me trying to demonstrate how it drills through. And I didn't give support at all to the tip of my lead. Usually when you do this procedure, that Agilis His Pro is actually right against the septum. But I didn't do that because I wanted to see that helix moving, that lead moving. You know, when I did this, I didn't expect it to go through that easily, but it did. Okay, and this is real-time video, and me just spinning that lead, and it just punches right through. Okay, and it is not even directly opposing. There's hardly any support, and the reason is, as I said before, with the tendril lead, you got that 1 centimeter head start in front of it that is stiff. It can still give you that support. And this is with the stylet all the way back. There's no stylet support at all. Okay? Now, if you get into a position and you don't like that position, be very careful when you want to reposition this. Okay? The typical response would then be, hey, wait a minute, the helix is extended. Let's retract the helix. Okay, this is the worst thing that you can do. Because as you start to retract the helix, I'm going to play you a video. First, okay, you're going to start to drag in tissue into the myocardium. And if you want to reposition, the best way to do it is just to counter the body and the body alone with the helix fully extended. Now, the video at the top shows that as I counter the lead body, the helix, when it's fully extended, will start to counter with your body. That means everything starts to counter itself out without you sucking in any tissue at all towards the end, okay? Now, if you don't do that and you attempt to retract your helix first before countering your body, then you may have a problem. Because if you can see, if think of the tissue like a bit of myocardium, I'm countering your helix to try to retract it. And as I counter, I'm retracting the helix as well as pulling back myocardium into the housing. And you see, if I continue to counter the helix, now the whole body of the lead is going to start to rotate. And you can only imagine that little piece of tissue paper as your myocardial tissue. I'm literally going to rip off a piece of myocardium. Now, that's a lucky bit. If you're lucky, you just rip off a piece of myocardium. If you're not lucky, you don't rip off anything at all, and the whole helix gets stuck because you're not going to be re-extended helix. And if you pull, that's what you're going to get. You get all sorts of weird things happening towards the tip of your helix. Okay? So again, once we get leads like this into the septum, there's always an issue about stress points and reliability. Now, nobody has any long-term data, but now reports are coming out of lead failures. Yeah. Now, I feel that the tendril lead has a certain advantage here. Now, if you look and you study how that design is of that tendril lead, the tip of the housing is actually a piece of metal. It's fixed. About the only weak point it has is actually proximal to the ring. In that position, it's got an outer insulation, conductor towards the ring, inner insulation as well as conductor towards the helix. So that's about the weakest point it has. Now that's very, very different, and this was making its rounds in this case reports of a biotronic solar system, okay, where it ended up with a fracture. Now the solar system has this little gap between the ring as well as the tip, where it's comprised of only insulation and an inner conductor. In this case, when it was actually implanted, it wasn't all the way through the septum. In fact, it's only about 7 to 8 millimeter, exactly where that weak point is. And that point of stress actually caused conductor fracture. Now, I don't have a solar lead, but this is a Boston Scientific Ingevity lead. It's got a very, very similar design. You can see the ring and that tip. That insulation in between is just a conductor and insulation, and me just bending it to demonstrate that weak point. Okay, and you can see it's actually quite scary how flexible it can get. Now, I don't have data, not have any reported cases of ingevity lead fracture, but this is a study where they actually subject the Boston Scientific lead to stresses to see where it breaks when they attempt to extract that lead. Now, basically, they put the lead into a machine where they actually pin wherever you think adhesion will be, and then they start to pull against it and see at which point does that lead fracture. Now, interestingly, you can see as pressure, as pulling forces increase, the first to give up is actually the inner conductor with a coupler. The insulation will break, it snaps. This is followed by the flexible neck. The insulation will snap off from the flexible neck, and you see suddenly it goes down because now everything, all the pressure is taken by that coil, that conductor, towards the tip. As you continue to put pressure on it, this is pulled out, it's straightened out, that conductor coil, before eventually snapping. Now, the interesting point is that when you do something like that, the point of fracture isn't here. The point of fracture is here. That was your weak point, okay? Now, you get a similar picture with the 3830. Now, 3830, with the lead, that the helix is actually extended already, but you can see it's just insulation as well as conductor towards the tip. And this is, you've seen this paper before, where they actually extracted it in a pediatric patient, and they snapped the inner conductor, and when you snap it, it feels like a rubber band. This whole thing just feels like a rubber band because the inner conductor is completely snapped off, and all you have is just an external conductor, which is a coil, and it starts to do like a spring-like motion, okay? So in summary, the Aegis Pro is not a C315 sheath or fixed curve sheath. It is steerable, has the ability to paste and map. The Aegis Pro can be reshaped to allow for lab bundle area paste, okay? Stylet-driven leads, however, do not behave like a fixed helix lead. It's larger in size, and Stylet would influence torque transmission. The helix, there's also helix retraction issue when you use a Stylet-driven lead. Long-term lead performance and attractability remains unknown for all of these leads. Okay, that's it. Thank you very much. Any questions? Thank you.
I've used quite a bit of the biotronic system and the Solia lead, and I can totally relate to what you say about one weak point being there between the steroid collar and the ring. My question is slightly different. This business of helix retraction, for that to happen, it happens with all Stylet-driven leads. As far as I can understand, for that to happen, the tip of the helix has to catch onto the myocardium a little bit.
Yes.
Otherwise, it cannot let the outer housing rotate on it. So
correct.
What I do when I see this helix retraction happening, like you say, I keep looking very closely for the first sign of helix retraction, which means that the view that you work in has to be totally perpendicular to the helix. The view should really show the whole helix. And at the first sign of helix retraction, what I do is I stop and I just rotate the pin again.
Absolutely.
And I find that that's an excellent way of deployment. If it happens by chance, a little bit of helix retraction happens by chance, this I take it as evidence that the tip has caught. And then from then on, it's like deploying a standard lead, just turn the pin. So I think we can use that observation to our advantage.
Absolutely. Okay, that's how we always flow run. That's how I do it. Extend, rotate the body, extend, rotate the body. In fact, when we started to do it, that's how I would deploy a standard Stylet-driven lead anyway. That's how I would deploy a tendril lead in a conventional pacemaker. I was just adapting whatever I was very, very familiar with and seeing whether I can use that same approach to drill through that septum. There's one other point I did not mention though. When you start to use a Stylet-driven leads and whether the helix gets retracted or not during that procedure, it gives you an idea exactly where you are, and you can use that to your advantage. One, if initially, when you get the Aegis Pro to the septum, I would deploy that helix exactly the same way how I would do for a conventional pacemaker. That means deploy the helix, tack it in the position first, then start rotating the body. Now, when you start to deploy the helix, if it's resistance and you see, wait a minute, it's not deploying properly, or when it's deployed already and you rotate the body and there's a lot of resistance, don't fight it. Go somewhere else. When you start to do something like that, you're going to destroy your lead. Okay, with the Aegis Pro, it's just slightly unflexing it a little bit. Ta-da, you're in a new place, start drilling. Often that's all it takes. Just go somewhere else. I'm perfectly okay with that. The second thing I will also say, the subendocardial fibrous tissue as a subendocardial side on the left side behaves the same way. You may not be able to feel it in the 3830, but with a Stylet-driven lead, you most certainly can. And how I look at it, and it's rather naughty, as you start to drill through and you realize, you know, this thing is going through like hot knife through butter, and it's going right through the septum. And up to a point, suddenly realize, there's a bit of resistance here. As I rotate the lead body, that helix is being retracted. Slow down, you're almost there already. Because you're right at the subendocardial surface. There's fibrous tissue there. Slow down, go anymore, you will perforate. So as you go through, it does not retract that much, but eventually you come to a point where there's a bit of resistance to retracting. Slow down, you're almost there. Start testing.
I was surprised that you tend to have, even with the Stylet introducer tool on top of the silicone ring, still you have that issue. Yes, that's another disadvantage about the you targeting the haze bundle area.
The helix retraction. I'll just say that through the mic. The helix retraction, the Stylet-driven lead has almost always happened in the his position rather than in the left bundle position, or in the unwise left bundle deployment where you unwisely go and try to deploy it in already fibrous septum, which I think it should not be tried.
So what I'm trying to tell is among the Stylet-driven leads, the Biotronic, fortunately has that the Stylet introducer which was there, and that happens to ride over the silicone ring, which makes both the helix and the outer body as a single unit, so you can transmit your rotations easy. So I was thinking that Biotronic in general will have a less of a retraction issue. But at the end of the day, when you are going to be removing your Stylet and then you are releasing the Stylet introducer, you got to be careful, because at that time, all that torque which had built may untorque. So just before putting your pin into the generator, one more look we'll have to have at the helix, because any time the helix can get retracted. So just before you introduce that pin into the generator, I think one more time you have to have a look at the helix, and then maybe you can give. And coming with the same tool, I was thinking earlier, but now that after witnessing all your cases, going through all your cases, I realized that it is not really necessary to borrow the Biotronic Stylet introducer and to use it for a tendril. We stopped doing that because you are saying that you need to be going on, doing the turns and things like that. So that is going to be remaining an issue. But those people who are used to the Biotronic system, maybe they can also use their tool for this system. It made us a little more confident using that tool in the beginning, and now of course it is not. We know that it is not necessary.
Yeah, I've not demonstrated that, but was there any concerns with the Biotronic Solia system after the case report where it actually fractured at the point of weakness? I mean, you used quite a bit of it. Does that mean you go for a more oblique approach, a deeper septal approach?
I was going to ask Dr. Ulla's permission whether I had time for that question. So I feel more, even though it is more easy to penetrate if we are horizontal to the septum, it's definitely easier to penetrate. But when we penetrate horizontal to the septum, we have to get in at the point, at the weakest point, meaning we have to make the weakest point the hinge, otherwise you get across. So nowadays I actually prefer to go a little oblique so that a bit of the ring stays in. And I wanted to ask you that going by your description of this lead tip, you probably don't need that with this lead.
I don't need to. I don't need to, because it's unique in the sense that it doesn't have the interim conductor. It's actually, if you play it with the tendril lead, just try to bend it. Just try to bend it. It's actually a piece of metal, how it was designed.
I have not had that issue so far. I now have a median follow-up of 494 days on the Solia lead, and no lead has had that, but every time I see it, I get scared. You see that fluoro, it looks scary.
Yeah, it does, isn't it? I think what Dr. Uha said is also correct. As you rotate, be aware you're actually building torque. Whatever system, whatever sheet you use, as you just rotate the tip or even the body, you're building torque somewhere. That torque may be in the body or maybe at the tip of the helix, and that torque takes time to transmit from one end to the other end. So as you rotate that torque, you got to give it time to transmit that torque. And it depends on how fast you rotate and how much time you give it to transmit that torque all the way in. Keeping in mind that those leads were never designed to have the body rotated. It was never designed to do that. In fact, you think about it, about the only system that was designed to do that was the 3830 that allow you to actually rotate the whole body and drill through. But everything else, they were never designed to do it. So you got to keep that in mind, because that torque, how it's transmitted, how much torque you've actually accrued during that drilling procedure will take time for it to transmit through. That's why I usually do it a lot slower. Just let it drill, let it transmit, watch what it's doing. If it's going to retract, just extend it. Just go step by step. It's actually a lot faster than you think. The second thing I'll add is actually this image, and I didn't have time to show this. And basically, the Agilicis Pro has such huge amount of support. It's actually stiff. It's got such a huge amount of support. And you can see, I call it cupping, interestingly, because that sheath could actually punch part way through your septum. Now, if you use enough of it, you realize that it's got so much support, it does that to the septum. So you can see that already from the RAO and the LAO view. The Agilicis Pro has punched through about 1, maybe 2 millimeters, about 2 millimeters through the septum already. In a situation like that, be careful, because once the lead gets through there and you rotate your leads, it just goes really fast, because all the fibrous tissue, all the septa, everything you've gone through already. The His Pro has done that work for you already. And you actually slap bang in the middle of the myocardium. 1. 2, second thing I would say is that when you see something like that, don't drill too deep. You try to push through because you're already 2 millimeters in already anyway. You try to hit the 1 centimeter mark, you're just going to perf. Okay?
Thank you. Just one thing I want to mention, when I saw that picture, a similar thing holds good with the Selectra system, probably not as stiff as this, that when we inject contrast to see the septum, you must pull it a little back, because just don't let it abut the septum while injecting the contrast. Unlike the C315, when we inject contrast, we make it abut the septum and inject contrast. But if you do it with the Selectra, and I'm sure with this also, which is even stiffer, just that puff of contrast is enough to get it across. So whenever you inject contrast through the Selectra, and I'm sure with this also, please pull it back a couple of millimeters before injecting contrast through it. That puff of contrast may be enough to just push the whole thing through, because the sheath is keeping it stiff.
I see. It doesn't really go through the myocardium, though. It's just really to highlight whether it's opposing the myocardium and how far it's into it.
It has a very stiff apposition to the myocardium.
Yes.
And some pressure occurs when the contrast tries to escape from the tip of the sheath into the blood pool, because this sheath is apposed so tightly onto the myocardium. Unlike the C315, which doesn't oppose so tightly onto the myocardium, you inject contrast through the C315, it just flows out.
Yes, exactly. Because it's so stiff, it doesn't like bounce back a bit and then highlight your septum to see exactly where you are. Sorry, that was a question?
As you slit the sheath, because of the additional curves that you do, you have to deflex the whole thing and then take the stylet behind, then deflex the sheath and then slit the sheath after withdrawing the sheath a bit. So can you tell something more how you compare about the chances of dislodgement and differences in technique?
Hardly had any dislodgement at all. The reason why is that when you actually slit that sheath and how you actually do it, it's very similar to how you would slit your sheath for a CS lead, which is your CRT system. And if you're familiar with that, it's the same maneuver. The only difference, pull your stylet back, push your lead forward, push-pull technique, so that you actually have a little bit of curve and then slit through. So that maneuver is exactly the same. I didn't do anything differently for how I would do a CS sheath, slitting it across. In fact, it's a lot easier. The slitter, you have a look at it in a little while, has that lead retention tongue, the metal tongue that comes out, and it holds that lead in position very, very well, actually.
Yeah, you got to deflex the sheath as well as pull back the sheath, and you have very much less distance on this lead as compared to a Medtronic lead. So there is some kind of a give and take there. You got to get the sheath back also, but leave enough space for the slitter also. So there is a little.
It's a little bit, you're right, but most times you're okay, because a 58 centimeter for Asians hard anyway, you got plenty of room. Actually, for most of my patients, when I do a RV lead, it's a 52 centimeters and a 45 46, 45 centimeter for your RA lead. So with a 58, 56, 58, you got plenty of room for you to actually do it. So it's not an issue. But yes, I do have challenging cases. You're correct, and I can show you an image in a little while if you want to take a look at that. Huge atrium, and actually put everything all the way to the hub. How I overcome that was actually to put your slitter into the hemostasis valve, slit partway through. Run your lead out a little bit and hold it in position where it's actually slitting through your hemostasis valve already. Then once you secure that lead, slit all the way through. Because you can buy yourself maybe 2, maybe 3 more centimeters, more than enough for you to slit through.
Yeah.
Okay? So that's a little trick that we did.
The master, so he considers whatever the remaining length is plenty. But we have a challenge. We need to be having longer length. Dr. Chan, I need to know about the shaping of the sheet. It's quite impressive that when you can make the shapes, it retains even when you take the dilator out. That's the greatness of this particular sheath. You can really retain the shape for a long time. I just was wondering, is there any kind of a curve, the primary curve, how much it has to be, the secondary curve, what should be the length? Is there any representative sheath you think of, whether it should resemble Medtronics or it should resemble Biotronic sheaths? Is there anything which you would like to tell us? How much to make a curve for the primary and how much you should twist for the secondary? What are the kind of geometry values you would like?
I think I've been asked that question many, many times. Even my colleagues ask me that question, how long? Is it 5 centimeters? Is it 10 centimeters? How long are you going to do it? My answer to them is always, no, there's no fixed length or no fixed curve. And often I decide how much of a curve based on the echo prior to procedure. How big is your atrium? What am I dealing with? Is it a normal heart? Is it a big atrium? How much of that curve do I need to get to the RV? For example, now I can show you examples of that. If you see something with a huge right atrium, that curve has to be a lot wider, a lot bigger, so you can get into the RV. With a normal heart, I think a 5 to 6 centimeters away from that first curve is more than sufficient for you to actually do that and get you into position. Now, the whole point there is actually not so much that curve helping you get into the septal. That's where the septal curve is supposed to do that. The whole point of that is just to get through your tricuspid valve. So shape it like any other way. Another way to look at it is that, let's say if I got my RV lead during an EP study, and I need to put my RV into my RV apex, how would you shape it? Another way to look at it is that if you want to do a conventional pacemaker, I want to park it either in the RV septum, RV OT, or my RV apex. How would you shape my stylet? What is the curve you would make your stylet? Because when I thought about using that curve, shaping it that curve, the idea of me shaping that curve was shaping it exactly the same way I would shape that stylet to get my lead into the RV so I can put it in a conventional position, and that was that. It wasn't anything else, it wasn't fancy at all. So where would you shape your curve to get your lead through? How would you shape your stylet if you got a big atrium? Do it exactly the same way. Don't overthink this. You got it. You've been doing it for years. You've been doing it for decades. Shape it the way you would shape it because you know best. Right? And if the atrium is too big, you pull the stylet out, get a new stylet, reshape it, get it in another shape, get your lead in. You can do that very easily. Right?
Just a comment that when we are doing the His bundle pacing and when you are screwing the 3830 lead, you see the His signal before you screw the lead. Whereas when you're doing the left bundle pacing, you don't have any idea as to what will the end point be. So you start drilling the lead in, you're deep in, and you're not able to capture the left bundle.
Yes.
And sometimes I find that the lead is stuck so hard that I can't be bothered to try at multiple places. So in your experience, because you're an expert and you've done lots of cases, is there a time where you were not able to move the lead because it's deep in and it's stuck and you're not able to capture the left bundle? And if you decide to move the lead, how many times would you try before you say, well,
I'm not going to try any further. Just for the sake of our,
Well, it depends on the patient, how tired the patient is, how tired I am, obviously, when we get that.
No, but how
by
many
and large-
times would you try? Because you're going deep in, and obviously, every time you're going in, it's going to be difficult to retract or take the lead back. It's like
Yes.
almost like an extraction you're doing.
Yes.
So how many times would you try before you say,
3 to 4 times easily,
4.
but I've done more than that at the beginning. Truth be told, as we get better and better at it, it really doesn't take much effort at all. You kind of get in a position, and the first position you get through is good, and you go through, you see a left bundle potential most of the time now, and we're just pacing with the left bundle potential when we're out. Really, it really doesn't take that much effort. There are a few times where I will say I will come out and I will not accept that. Okay, the basic parameters, the LVAD, pacing QRS is not wide enough. We're not happy with that, or you end up inadvertently perforating. Obviously, when a threshold you just can't capture, you're gonna have to reposition that. But I don't see them as failure, truth be told. For example, if I get resistance and I can't go through and that lead cannot drill, I realize that position is no good. Go somewhere else. For example, this patient, I was just about to show you an example with left ventricular hypertrophy. I'm coming from the right side, and we have to drill to multiple places. I tried 3 times at least, different position. And the reason why is that it's very fibrous, that position. This hypertrophic cardiomyopathy is almost 2 centimeter thick in the septum. And as you drill, inevitably halfway through, it just can't drill anymore. You just can't transmit torque anymore. Or you see that helix retracting every time you try to drill. And you come out, you just go to another position. Often getting in that position is just really unflexing it, countering it, pushing it forward a bit, slightly more apical, and you're good to go in another position, and just going through that position. Now, this patient had hypertrophic cardiomyopathy. We actually had to drill to almost 2 centimeters to get to where we needed to get to with a left bundle pacing. Okay, so again, 2 to 3 times, however many times it takes. If it perfs, then just come out. I don't think it's an issue. The second thing I would say is that if you feel that the lead is an issue and there's tissue there, and it's still, just change another lead. Just change it. Don't try to just keep using that same lead again, because you're just going to be very frustrated with it. Okay, so if that happens, change another lead, go to another position. It's very easy to do that. Use that information. Now, I showed you another easy. So often, if I perforate, I will still inject contrast. The reason why I inject contrast, it gives me an idea of how deep that septum is. So the next time I drill, I know I'm not going to go that deep anymore. So I don't think it's a loss if I cannot get into position and have to reposition. Get as much information as you can get. Why you fail, where that position you fail. If you're going to go to another position, where are you going to go with that position? How deep are you going to go? So just know where you are. So the next time you try another position, you have a better success rate.
Thank you, Dr. Chan, for the.
Yes.
I think this fantastic lecture, I think, has enabled us to handle this wonderful tool. I think it increased the confidence in us to use this sheet. Maybe you didn't have much time about another greatest advantage of these kind of Stylet-driven tools is to continuously monitor what you have been doing, checking the injury, checking the impedance, where you are going. Maybe for the lack of the time, you did not really. Maybe we have our own cardiac technologist is going to demonstrate how we monitor the injury patterns and the impedance pattern as we start from the endocardiums towards the deep into the septum. A great tool, and now that I request him to accompany me to the lab, my colleague Dr. Anindya is going to be ready for him, and then I will be there, and Saxena sir, Ashish, you people, try to be moderating the session, and we have Karthikeya to take over the dais. You are going to be talking on the electrocardiology of the conduction system pacing. Suchit, and maybe there are other moderators. Richard Hango is also around. You can moderate his session. As I was saying, he's a brilliant electrophysiologist from the country, associate editor of the Indian Pacing and Electrophysiology Journal. Lot of publications, and passion for teaching is fantastic. He reads the ECG best in the country, and that applies to the conduction system pacing as well as reading those ECGs. So it's my privilege, Karthikeya, to have you here. So please.
Nice introduction, and it's always a pleasure to be here. I've been coming here since many years. I don't even remember how many years, and it's always a pleasure to come and learn and teach, and also participate in the cases, live cases. So my task is to talk about ECG in conduction system pacing. So now we know that physiological pacing entails capturing the cardiac conduction system, his bundle or the left bundle branch, in order to prevent or correct pacing-induced dyssynchrony. And physiological pacing may involve capturing the his bundle pacing, left bundle pacing, his bundle pacing along with LV pacing, or left bundle pacing along with LV pacing, as we'll see in cases being performed and shown in the time to come. Now, his bundle lead can capture the his bundle. This is also very important to understand that his bundle lead, due to presence of its location, can not only capture the his bundle, which we are targeting, but can also capture the adjacent RV myocardium and sometimes inadvertently the atrial myocardium. Similarly, the left bundle lead can capture the left bundle trunk or the left fascicles, anterior or posterior more commonly, and left septal myocardium, and in addition, the anode during bipolar pacing may actually capture the RV septal myocardium. Now we know that the idea of doing conduction system pacing is to pace the conduction system, but so confirming that you are capturing the conduction system is very important, and it's very easy actually when we are doing his bundle pacing, but can be sometimes challenging while doing left bundle branch pacing. And the reason why conduction system pacing is important is because capture of the conduction system results in faster and more homogeneous depolarization of the left ventricle than myocardial only capture, and thus prevents electrical and mechanical dyssynchrony. Confirming the capture of target conduction system is important to achieve the goal that we are aim at, that is maintaining or correcting dyssynchrony. And long-term studies will show whether it's actually very important to confirm cardiac conduction system capture, or just deep LV septal pacing is good enough for having good clinical outcomes. Now, the ECG is the primary means of confirming the conduction system capture, and variation in QRS morphology during pacing, however subtle, need to be recognized quickly while you are performing the procedure to understand the clinical outcome better. Now, why is the QRS morphology different in conduction system capture and myocardial capture? We all know that cardiac conduction system has different properties than the myocardium, and most important of which is the conduction velocity, which is quite rapid in the conduction system and slow in the myocardium, and that results in difference in the QRS width as well as the R wave peak time in the distal precordial leads. The other is the capture threshold may be different of the conduction system and myocardium, and so use of differential output pacing can be utilized to ascertain the differences between the two. And finally, and less commonly used a parameter is the refractory period, which may be different in the conduction system and myocardium, and programmed stimulation or burst pacing to see changes in the QRS morphology can be used to ascertain whether cardiac conduction system is being captured or not. Finally, transition of paced QRS morphology from one to another, that is from conduction system to myocardium or vice versa, or from non-selective to selective or non-selective to myocardial only, will confirm the conduction system convincingly and help us in understanding despite not much variation in the QRS width being seen. Now, what are the different methods to confirm conduction system capture? During intrinsic rhythm, one can look at the potential, which is easy. As electrophysiologists, we all know how to recognize the His bundle potential. But even in the left bundle pacing, one can see left bundle potential or left fascicular potential, but that is seen only in minority and may not be essential for confirming the final conduction system capture, and may be absent during, in fact, it is absent when you have antegrade conduction block, and you may have to do retrograde ventricular pacing to see retrograde potential. Finally, stim to QRS during selective conduction system pacing, the delay is akin to HV interval while doing his bundle pacing, and during myocardial capture, there will be only very short or absent stim to QRS. This applies both to non-selective as well as myocardial only capture. Now, the paced QRS morphology, when we capture the His bundle selectively, it will be identical to the baseline, and we'll also look at the QRS duration, and if there is a underlying bundle branch block, we see whether that gets corrected also or not. And one of the mainstays of looking at the QRS morphology is that look at the notches, slurs, and plateaus, which should be absent usually while we are capturing the conduction system, but will always be present when we only capture the myocardium. Now, finally, transition in paced QRS morphology can be utilized by doing differential output pacing, programmed stimulation, or burst pacing. So let's look at this ECG in His bundle pacing. Now, we look at selective versus non-selective capture, and with or without correction of underlying bundle branch block if that is present. So during selective His bundle capture, the stim to V is same as the underlying HV interval, and the stim to QRS end, which is again not a very commonly used method, but it is in fact an easier method to look at whether you are actually capturing the His bundle or not. So stim to QRS end will be same as His to QRS end. This is important because sometimes the QRS onset may not be ascertainable, but the QRS end could be easily seen. Now, the paced QRS duration will be same as the intrinsic if there is no underlying bundle branch block, or if there is underlying bundle branch block but there is no correction, and the morphology is also like intrinsic QRS. When you have non-selective His bundle pacing, that is you are capturing both the His bundle as well as the adjacent myocardium, your stim to V will be shorter than the HV, but your stim to QRS end will be same as His to QRS end as in selective His bundle pacing. So this is an important point again. And the paced QRS duration will be longer than the intrinsic, but morphology will just show that the most of the QRS is identical or similar to the underlying QRS, but there is a pseudo delta in the onset, at the onset of the QRS. Now, if there is myocardial only capture, that we all know how to recognize, the stim to V will be shorter than H to V, and stim to QRS end will be longer than His to QRS end, and the paced QRS duration in fact will be longer, and the morphology will have broad left bundle branch block. So this we all know, when we pace the right ventricle anywhere else also, we get all these criteria. So looking at the paced QRS morphology while we are doing His bundle pacing, again this is again from the group of the multi-collaboration between the Polish group and the Switzerland group. If you look at the His bundle pacing, selective His bundle pacing, and you see that each of these diagrams show two panels. One is when you have capture, and second is when you lose capture. So selective His bundle pacing will have a QRS which is identical to the underlying QRS, and if the output is reduced, there will be loss of capture. So this is simple, but usually the things are not that simple. So in the second, you have non-selective His bundle capture meeting all the criteria that I showed in the previous slide, and when you lower the QRS, the myocardial capture is lost, and so you get selective His bundle capture, and if you further lower the QRS, the output, you don't get any capture at all. In the third panel, you have non-selective capture transitioning to myocardial capture. So non-selective capture, when you lower the output, can either have selective His bundle capture if you lose myocardial capture, or can have myocardial capture if you lose His bundle capture. So this is a transition that we can observe when we do differential output pacing, and that is the way to confirm that you are capturing the conduction system at the first place. Similarly, if you have underlying bundle branch block, you can have selective His bundle pacing with correction, that is narrowing of the QRS, and as you lower the output, you may still have selective conduction, His bundle pacing, but without any correction, and so your QRS will look identical to your baseline bundle branch block. Also, if you have non-selective His bundle pacing with correction, you can have multiple thresholds. That is, once you lower the output, you may have loss of myocardial capture, so you may have selective His bundle capture with correction, and then if you further lower the output, you have the selective His bundle capture without correction. So all these different QRS morphologies and the stim to QRS and the comparison with the His HV interval will help you understand what are the different thresholds during different outputs. Now, so these are the QRS morphology transitions that one can see, and one needs to recognize them quickly and early, promptly while we are doing the procedure, so that to understand whether we are capturing the conduction system or not. So when we reduce the output, and so in the first example, you have selective His bundle capture to loss of capture, but in the second, you have non-selective His bundle capture to selective His bundle capture and then loss of capture. And you can see that in the third panel, when you have non-selective His bundle pacing to myocardial capture, you have some notches or plateaus which are occurring. And so these notches, slurs, and plateaus suggest that there is myocardial capture and loss of conduction system capture. Similar things we can see when there is correction and loss of correction also. You may have development of not only widening of the QRS, but development of plateaus, notches, and slurs. And when we look at the other morphology features, you can look at the R wave peak time, that is from the stim to the peak of R wave in lead V5 or V6, and typically it is shorter than 100 milliseconds when you have the capture of the His bundle, but if you have only myocardial capture, it is usually longer than 100, and this is also a very good differentiating feature to understand whether you are capturing the His bundle or not. Similarly, distinguishing non-selective His bundle capture from myocardial only capture, one can look at the plateau. If you look at lead 1, from non-selective His bundle capture, once the His bundle capture is lost and you have only myocardial capture, there is some development of plateau in lead 1. Similarly, you have development of slurs in lead V4 in the second panel, and notches in lead V1, and the increase in R wave peak time. So these are good things to observe, and one needs to recognize them quickly while you are doing the procedure and ascertain whether you are actually capturing the His bundle or not. Now, R wave peak time was very good parameters to assess whether you have early left ventricular activation, because the lead V5, V6 are depicting the lateral left ventricular wall, and early activation in that area, early peaking of the QRS in that area suggests that you are most likely capturing the conduction system. And it has been found that in R wave peak time in V6 differentiate non-selective His bundle capture from myocardial only capture, and a cutoff of 100 milliseconds has been demonstrated. Now, when we talk about left bundle pacing, this parameter also differentiates non-selective left bundle capture from LV septal only capture, but there is a lot of overlap. And more importantly, the QRS duration is not a useful guide in differentiating whether you have loss of left bundle capture and non-selective left bundle capture. So the R wave peak time may not be a good indicator because of the overlap, and QRS duration is not at all an indicator when we are looking at left bundle branch pacing in ascertaining whether you have capture or not. And this is precisely the point that left ventricular septal only capture, that is sometimes referred to as deep septal pacing, also results in a very narrow QRS, and some investigators believe that it may actually give you the same clinical results as confirmed conduction system capture, but the long-term data is still awaited, and we need to see what the results say. So the Polish group devised this algorithm to look for the confirmation of His bundle capture, that if you have QRS notch, slur, or plateau in lead 1 or V4 to V6, then you have myocardial only capture. If it is not there, look at the R wave peak time in lead V6. If it is more than 100 milliseconds, again you have RV septal capture. And if it is less than 100 milliseconds, that means you have non-selective His bundle capture. So this is a good way to look at His bundle pacing. And this is a slide where sometimes you can see that these subtle variations you need to recognize quickly. So if you look at the first 4 QRS complexes, you see that there is a stim to QRS delay, but though the QRS morphology in the 5th and 6th QRS beats looks identical, there is a slight increase in stim to QRS onset. And this is because there is a loss of His bundle capture, and it's actually capturing only the atria and resulting in native conduction through the native His bundle AV nodal system, resulting in the same QRS, but there is no His bundle capture at all. If you do not recognize this and leave the lead at this place and your His bundle capture threshold is quite high, you will be fooled that there may be loss of capture in clinical scenario and may cause problems. Now coming to the left bundle branch pacing capture, because most of us actually now have moved from His bundle pacing to left bundle branch pacing, and then this is the criteria which was initially devised by Huang and Vijayaraman, wherein successful left bundle branch area pacing is considered when 3 of the following criteria are met: paced morphology of RBBB pattern, presence of left bundle branch potential, left ventricular activation time, again the same thing as the R wave peak time, measured from stim to peak of R wave, which is short and constant at high and low output pacing. Determination of selective and non-selective left bundle pacing by looking at the stim to QRS latency and discrete local EGM separate from the stim artifact. And during non-selective left bundle pacing, when there is no stim to QRS latency and no discrete local EGM separate from the stimulus artifact. So this is how you differentiate between selective and non-selective left bundle capture. And also remember that selective left bundle branch capture is usually not commonly seen, and even if it is seen, it will result in a broad QRS. It's not that just capturing the conduction system itself will result in a narrow QRS. So you understand that if you only capture the left bundle, you will have a typical right bundle branch block pattern of the QRS and a very broad QRS. In fact, one of the widest QRS you get while doing conduction system pacing is when you have selective left bundle branch capture. And finally, evidence for direct left bundle branch capture. Now, as we see in our cases, sometimes we do left bundle branch pacing very proximally and we capture the trunk of the left bundle, but more commonly than we believe, we actually capture the fascicles and mostly the left posterior fascicles. And so this was a study done again from China, wherein they looked at the different ECG patterns and clinical outcomes and found that left bundle branch trunk capture results in a normal axis right bundle branch pattern and S in lead 1 and AVL, which is similar to that during sinus rhythm, and the R wave in 2, 3 and AVF, which is similar to that during sinus rhythm. So it's a normal axis and right bundle branch block pattern. Whereas if we do left posterior fascicular pacing, which we more commonly do actually, we get right bundle branch block pattern with the left axis, and there is a dominant R in lead 1 and AVL and dominant S in lead 2, 3 and AVF. Left anterior fascicular pacing we do see less commonly, but again the axis will be right axis of the QRS in the frontal plane and similar morphology patterns in the limb leads. Now they also looked at the procedural outcomes and found that compared to left ventricular fascicular pacing, patients with left ventricular trunk pacing, left bundle trunk pacing had a shorter QRS duration and QRS area but similar LVAT, normal QRS axis, rightward QRS transition zone and similar echocardiographic parameters at 12 months of follow-up. So whether it actually matters whether we do left ventricular trunk pacing or left fascicular pacing is actually needs larger studies to have a definitive answer, but looks like that we get similar clinical outcomes even with left fascicular pacing rather than left bundle trunk pacing. So what are the different ECG patterns which confirm left bundle branch capture? Again, we can do 3 things. We can pace at different outputs. and see the transition from non-selective to selective lead bundle or non-selective to myocardial only capture. We can do programmed extra stimulation by giving a drivetrain followed by an extra or a single or double extra. And finally, we can do VO pacing at slightly longer cycle length to see the differences in QRS morphology. So this is how we typically look at the transition from non-selective lead bundle capture to selective lead bundle capture. But remember, these transitions may actually be very, very minute differences in the pacing outputs and may not always be seen. But what happens is that when there is a transition from non-selective lead bundle branch captor to selective lead bundle branch captor, there is increase in the V1 R wave peak time, but the V6 R wave peak time, which actually denotes the left ventricular activation, remains the same. And there is broadening, slurring, and notching of R wave in lead V1 to V2, or increase in the S wave amplitude in 1 and V6. Not all these changes will be seen in all patients, but only some of these may be seen in some patients. So one needs to look at all these, and sometimes there is a development of tiny R wave in lead V1. So you see that the QRS width may not change much, but there is subtle variations in the QRS morphology that one should recognize to look at and see that there is a transition from non-selective to selective lead bundle branch captor. Similarly, you can have non-selective lead bundle to LV septal capture, that is loss of conduction system pacing, and again there is a not much difference in the QRS duration, but since you are losing lead bundle capture, there is increase in the R wave peak time in lead V6, and as I said, the global QRS duration change remains unremarkable, and there may be subtle changes in QRS morphology like decrease in R wave amplitude in V1 or development of QS in lead V1, and there may be certain other minor changes which may be difficult to recognize. Now this is native QRS and paced QRS looking at the different R wave peak time. As I said, R wave peak time in lead V6 will tell you whether there is capture of the left bundle branch, and it indicates the left ventricular activation time. So this can be used to differentiate or confirm left bundle capture. If there is QRS onset to R wave peak time versus paced QRS onset to R wave peak time, if differences are noticed, this can actually help you in understanding that whether you are capturing the left bundle branch or not. The V6 R wave peak time remains the same with non-selective or selective left bundle capture, but increases in left ventricular septal capture because there is loss of left bundle conduction and there is only myocardial conduction in the left ventricle. And so this difference can tell you whether what is the transition actually due to. Lastly, V1 to V6 interval criteria has also been described, wherein you don't look at these intervals from the stimulus or the onset of the QRS, but look at the peaks of R wave in lead V5 or V6 and the later peak in lead V1. And it has been seen that if this V1 to V6 interpeak interval is more than 33 milliseconds, it indicates left bundle branch capture. And this is a very simple and easier tool to follow during your procedures, because you don't need to do multiple measurements. You just need to look at your V6 peak and the V1 peak and look at the interpeak interval. And of course, you need to have ideally a 12-lead ECG attached during your procedures for this. So I'll conclude by saying that goal of conduction system pacing is to maintain or restore physiological activation sequence. Confirmation of conduction system capture, his bundle or left bundle, is critical during implantation and is guided by QRS complex morphologies. Conduction system capture results in faster and more homogeneous depolarization of the left ventricle than myocardial only capture, and his Purkinje system and myocardium differ in their capture thresholds and refractoriness. And finally, dynamic pacing maneuvers are used to utilize these differences to confirm conduction system capture. Thank you all for your attention. Yes, Dr. Ashish.
size heart, this is good. But do you think in heart failure patients who have LV enlargement, LV obviously enlarges more left and posteriorly. So should we have criteria which look at V7, V8 R wave peak time?
Yeah, so
That
that's
we are
what. So you
better.
cannot have multiple criteria for different patients because then your protocol changes. So that's what this study by Polish group showed, that though the V6 R wave peak time helps in differentiating between left bundle capture and myocardial capture, there is a lot of overlap compared to his bundle pacing, where there is a definitive cutoff point that one can use. And so one needs to use the other criteria along with that, and the one they described is the interpeak interval, which comes in very handy. And they have shown so many examples wherein you had a longer R wave peak time in V6, but a wider interpeak interval, suggesting that you had conduction system capture.
And with the different
Karthikeya,
systems,
can you hear me?
Yes, we can.
Karthikeya, fantastic lecture. I'm sure the discussion can be a little more longer, but can I tell you that here the stage is all set. I know it's a coffee time for you people, but you can always take a coffee and get inside the auditorium. And India had taken the access. He had placed some catheters, which probably is not really necessary, but it is learning. I want someone to present the case. Who is presenting the case there? Okay, she can present the case, and soon after the presentation, let us know. I will hand over to Dr. Tan. I'm unable to hear anything from there.
Ullas, we are with you. Can you hear us?
So Karthikeya, can you hear us?
Yes, we can.
Oh, great, excellent. So let's go through the case.
Case 1. 81 years female has a history of pre-syncopal episodes for 1 year. Her ECG shows sinus rhythm 2:1 AV block, complete RBB. Normal axis QRS was 130 millisecond. Echo was adequate function. And the plan was PPI.
All right, so I think currently she is 1:1 and kind of a narrow QRS, right?
No.
It's an RBBB? All right. And the axis is a little leftwards, right? Okay. All right, so with this, I think we are all, right now it appears, it's like a bifascicular block, it is right bundle and the leftward axis, the PR is a little longer or something. What is the PR? PR is normal. All right, so Dr. Tan, is this the right case for the
Yeah, every case is the right case for conduction system.
So she was symptomatic. I think this is almost like a bifascicular block or a trifascicular block. I don't know. What was the your AH and HV intervals here? Oh, HV is 70 milliseconds. So I think it qualifies even for a trifascicular block. And she has had syncopal episodes. And did they show on the ECG some intermittent CHV? 2:1. All right. So Dr. Tan. Is the right case for you?
Oh, absolutely. I think a few issues here that would be quite interesting and challenging as well.
Yeah,
One
before that, I would like to confirm from the auditorium. Are we all heard very well, Karthikeya, Dr. Saxena?
Yeah, surely we can hear you well.
We can hear you.
We are with you.
Yeah. Yes,
Okay,
Dr. Tan.
so a few things that will be quite interesting with this patient. Number one is a right bundle branch block, and we're going to attempt a left bundle branch pace to correct a right bundle branch block. And a lot of time it actually corrects it quite nicely. I don't know whether that was covered in the previous lecture and how it's actually done, or potentially can, but we can go through that, of course. Now, before we started this case, they actually have a His bundle catheter in there already as a backup, so we can actually see the His level, we can mark our His position for us. Second thing that I did was actually just to put the RA lead and just position it into the RV apex.
Can you show the fluoroscopy screen also simultaneously?
So you can go through and tell them what's going on.
We have placed a backup lead, which is the atrial lead in the RV apex. There is a quadripolar diagnostic catheter, the His bundle. The light screen also shows.
We cannot hear you.
Anindya, you don't have a great mic, I think.
Yeah, so the idea here is that we got a backup lead now. It's connected to our PSA system. In the event that she goes into a standstill or 2-to-1 block or whatever, complete hard block, we can either pace from the his position or we can pace from the RA lead at the RV apex. So she's as safe as it gets, really. So now it's trying to get the his pro in, getting the left bundle area. It'd be interesting to see how that can correct a right bundle branch block. And left bundle branch pacing can correct right bundle branch block, and we can go through that in a little while. But anyway, we can start shaping the his pro. Should we start shaping the his pro? So I don't know whether you want to show the camera. So basically, you got a his pro catheter. I don't know whether you can see it. Okay, so it's okay. It's okay. Don't worry about it. Yep. So basically, we'll prime it with the introducer in already with the his pro. Typically, I flex it just a little bit so I know the plane where it's going to flex. Once I know the plane, I'm going to make my primary curve, and really, that's all it takes. This is anatomically normal heart. Am I right to say that? Yeah. So that's my first curve, and this is really all it takes for me to make it. I don't need to make too much out of it. The secondary curve, again, because I have a flex, I know the plane already. I'm going to flex it downwards and outwards. I don't know whether you can see that. Okay. Downwards and outwards. And the reason why is that if I put it on the patient, you can see its pace going towards the septum straight away. And as I flex some more, it goes up, and it's going towards the septum. And it can maintain the curve quite well. Often what I would say is that make sure you got at least a 1 centimeter or 1.5 centimeter distance from this curve. See that?
Yes.
Yes, well seen.
Yep, you can see that, right? Going towards the septum. So as they get the introducer in, I'll go through that again with you. So oopsie. Yeah, I like it. Okay, often when I go in, I actually keep it fully extended when I go into the RV. Once I'm fully extended, I'm pointing the tip towards the RV apex, and then immediately I will start to counter. That means I'm maintaining the counter and the tip facing the septum. Once I'm in the septum, I can start flexing it, and when you keep flexing the catheter while countering, you're keeping the septal curve to it, and it will go up towards wherever position you want. Okay, and often that's all it takes. Okay? Well, hopefully this is a straightforward case then. Okay. So we have to be careful because the Turomo wire is actually into the CS. You don't want that. Don't.
Dr. Tan, how long that curve will last within the patient's body after making the curve with the Stylet help?
Not an issue, but you are right. If it's too long, it does lose its curve to a certain extent. Okay, so in the atrium is enough. Don't go into the CS. Yeah, you go ahead. Go ahead. Yeah. In the atrium is enough. So we're going to advance this. Okay, into the flora. You're very got to be careful. Huh? Go to flora. Go down. Yeah, slowly. So because you see the wire is back. Is the wire is back? Okay, that's good enough already. So in this position, if you hold the his pro, just hold.
You can switch the positions.
It's okay. It's okay. If you hold the his pro, I can take it out now. Okay. Sure. Up fluoro, if you got the fluoro. Up fluoro. Oh, okay.
You would like to have that control with you, the fluoro?
Yeah, it'll be good. Okay.
Usually we give it to him.
Okay, you can connect the his pro now. We're in the atrial side.
Yeah, so this is your control.
Oh, thank you very much. Thank you. So, oh, I can't see the signal. Gosh, that's so far away. Gosh, so the His Pro, the green one is His Pro, am I right? So the green one is actually His Pro. You can see that on the His Pro signal, you can see huge A signal. We don't see any kind of CS signal there. Basically, we're in the atrial. Now we can go to the RAO position. RAO, 30 RAO. Ooh, is she okay? So basically what I'm going to do is clock, so it's free from the septum, and just advance into the V. It's a bit lower. We've got to go down there. I should be in the V position now. If you can see the green signal, we're in the V position already. That's a beautiful position, but low. That's because I'm unflexed. I'm pointing towards the apex, unflexed, into the V position. Right? We can counter and clock.
Can you adjust the camera of the fluoro? We can't see the sheath.
I'm countering now, and I'm flexing it.
Okay, see, listen, this fluoro here is not covering that part. Excuse me.
Just adjust the camera of the fluoro so that we can see the sheath.
Yeah, I think it is better now.
Yeah, that's good.
That's good? Okay. Yeah.
So that's a pretty good position where I want to be, considering where the His is. This is RAO. So I'm countering and flexing at the same time. I'm pointing towards the septum now. I'm not putting any thought. I'm just holding that His Pro, LAO 30. Now is the time for us to check LAO. Beautiful position. Beautiful. Beautiful. Pointing towards the septum, RAO. I can keep it LAO for a while. Do you have some contrast?
Yes.
Okay. Do you mind coming over here and holding the sheet for me? Yeah, just hold it like that. Yeah, at the bottom. Yeah, just hold the sheet. Yeah, you can do some contrast, so we can do the septogram. You can 50-50 mix. It's a beautiful position. Slightly on the lower side, but that's okay. While we're waiting for the contrast,
Don't dilute.
you want to paste the His Pro? Okay, notchiness is, where's V1? Sorry. Yeah, hold on, sorry, I can't see the screen very well. Oh, I can see this one. I can't see the label, which one is V1? Great, notchiness is great in V1. You can see that W sign, that notchiness there. AVR is predominantly negative, AVL predominantly positive. Both 2 and 3, all negative, so it's a bit on the low position, but can I argue that 2 has a slight positivity to it before becoming negative? So I'm quite okay with this position. Okay, if you want to have a go at it, we can.
No, my question here is, it's a little more apical. All the inferior leads are negative, so you make only one side.
Correct. We can make it higher too, if you like.
Yeah, I think
Dr. Tan, when you're doing a Medtronic, when you're using Medtronic, do you try to position the same thing a little higher than this?
yes, I think he's going to be pulling it,
There.
to make it.
It's in the septum. Now I know where the septum is. So if you want to go higher, it's very easy. Okay.
Yes. So can you paste now again? It is still quite negative inferior leads.
Okay.
Yeah.
So first few things I would say, I may not want to go very high. Okay.
Yes.
If you look at the RAO position,
Yes.
you look at your His position, it's actually low.
Right.
You got a His catheter to tell me there that I'm already there.
Okay.
You see that? I'm only about 1.5 centimeter where my His position is. So you're actually having a very low lying His position. If I go a bit higher, it may not be so easy. It may not be the position you want.
Okay.
That may be your ideal position.
Right.
So it's nice that you have a His.
Yes.
Okay. But truth be told, even if you paste the left posterior fascicle, it's perfectly okay. I'm perfectly okay. But if you want to go higher, I can go higher too if you like. It's perfectly fine. So all you need to do if you want to go higher is just really clock it a bit and just flex your His Pro. Okay, she don't like what I'm doing. It's stuck against the wall, so I'm going to unflex and then flex again. Slightly higher position, can I argue that?
Yeah,
Slightly, pace.
Pace and check. No, lower output.
Very nice. 2 now more positive, am I right to say that? And update.
No, it's actually still negative.
Still a little, huh? So if you want to go a bit higher, of course we can. Let's go a bit higher.
No, don't do this nonsense on the touch screen. Hey, single screen. You're not used to that.
Is she okay, lady?
Yeah. So maybe you can sedate.
So again, the motion is quite straightforward. Just go to the apex where you want to be. Counter, and then flex it across. Again, going low. More scepter now. There you go. Higher position.
Yes.
Can pace his pro?
Yeah, actually we have some template beats came. Yeah. And a lower output. Yeah, you always pace at 4. Yeah, see, 2 became positive there.
Yeah, of course. You like this position?
Yeah, and
it's
I
good.
think it's okay.
I can go anywhere I like, really, to be honest with you.
It's okay.
Okay, LAO, let me double check, make sure I'm in the scepter. Beautiful position. Yes. I like this position. Okay, okay. I up a bit. I up a bit. You're hitting my his pro. Yeah, I up a bit. Yeah, correct.
Yes.
Okay, I'm happy with that position. RAO. Let's try the septogram again. Let's have a quick look. LAO, Mac that tip. This is actually quite a high position. Usually I don't go that high, but anyway, we can. It's not quite against the septum. You don't have Cine, is it?
Yes.
Yeah, it's against septum.
Ullas.
It's moved a little
yes,
bit.
Please, yes.
Ullas, Dr. Hajra here.
Dr. Hajra, welcome.
Thank you.
RAO for me.
I think there are a lot of new, I think the way you are doing, actually I started doing exactly the same way, but I completely changed my way. Because this sort of maneuvers can cause pericardial tamponade and damage. So what you do, you enter the RV with the wear, take a angiogram, RV angiogram. So that will delineate the septum exactly the desired plane you want, rather than manipulating the bulky sheath. Second, if you give so much of carb to the sheath, when you're actually pushing the lead, the torque may not be transmitted exactly what you are putting behind, at the tip end. Not only that, when you actually remove, there will be a sudden jerk of the torque transmissions, there will be chance of lead displacement. So if you really want to do a very elegant way, very simple way, just do the RV angiogram on the LVA, know your septum. And third point, if you are entering from top to bottom, rather than bottom to top, if you are entering from top to bottom in RA to RV, you may catch the septal leaflet. And your lead can go through the septal tissue, leaflet tissue, and that may initially it may be a failure because you feel a lot of resistance. Whether, if you go from bottom to the top, you entering into the RV apex on the RAO, then you pull your sheath little up and you know the septal leaflet negative shadow, negative solute, and you know exactly where you are. And if you start the torquing the lead, maybe that is the best way to know that you have not gone through the leaflets. So these are the 3 things I wanted to mention.
Yeah, exactly so. Yeah, I went a bit lower because it's not quite 90 degrees towards the septum just now. It was pointing up. So it's slightly lower, that position, but I kind of like this a little bit better. LAO. This is a much better position. Okay, RAO. I up a bit. Yeah, okay. Yeah. It's going to be a bit more negative. No, it's not too bad. 2 is actually still positive before negative. I'm actually okay with this, actually. Okay, can you hold this? Yeah, just hold. You need to put a bit of torque here. Yeah. There you go. Okay. Lead, please. Shall we?
Yes, of course.
Any question? Yeah. Sure. 58 centimeter lead. Do you have the bypass tool with you? Blue bypass tool. Okay, sorry, you were going to add? Any question? Okay, so we're going to get the lead through. Typically, I do it without the lead in first because I just get more flexibility with it. Granted, it may dislodge or it may reposition, move your sheath a little bit when you're doing that. When you're going through the curve, I always pull my stylet back a little bit. It gives a bit more flexibility towards the end until I get that lead into position. Okay. So lead coming in, lead going towards the tip, navigating that curve a little bit.
Dr. Tan, do you ever have to shape the stylet a bit?
No, never have to.
In fact, the stylet has to be quite away from the tip.
Yes, it has to be away from it. In this situation, there's a curve that it won't let me go through, so I'm going to have to reposition that a little bit. So therein lies the problem if you don't put the lead through first. Sometimes this happens. So you have to reposition it, unstraighten it, but it's okay. At least I know where I'm going to be. A bit of resistance there. Okay, so now it's towards the apex. No, it's okay.
So are you going with the screw out or screw in?
Screw all the way in.
All the way in.
Yeah, the screw is not deployed. Yeah, helix is not deployed at all because I don't want to damage the helix at all.
All right. So initially they thought that you have to take the screw out and the green half, you rotate around 10, 12.
No.
Then you take. Now we have moved away from that. We are actually going without the screw getting out of the system.
Absolutely.
Yeah.
LAO for me.
So if you go with the screw out, it may again catch the nonsense tissue like septal debris.
Exactly. Often you can damage your helix in that position as you go through that sheath.
Yeah.
Okay, place the
and second, on the fluoroscopy, you observe there is a V shape or L shape of the sheath. Now, if you have a L shape of the sheath, always the torque will not be exactly transmitted 1:1.
RAO.
So you reduce the V shape or the L shape to a more curvilinear or a semicircular shape. So what you do, you reduce once you reach the septum, then you reduce the L shape or the curve, then the torque transmission will be better.
Yep.
See, Hazra, I think that's a great point. Even with the Biotronic, now we stopped extending the helix out. Even though their standard recommendation is to prepare the lead outside.
Just hold the white.
Dr. Hazra, we take your advice quite seriously. We do not expose the helix.
Okay, mark the tip.
And the helix may retreat back. I mean, if you have a fibrous tissue, if you take the helix out.
LAO center that position.
And not only that, when you are not happy with the position, and if you take the helix out and you want to take it out, that will lengthen the helix and to damage the whole lead.
3-0. I up a bit. Okay, I'm going to deploy the helix now. You can see that deploying the helix when it's sticking just slightly out of your His Pro.
Before releasing the helix, you can take a angiogram.
Yes, a septogram. In fact, I can do it now too if you want. Okay. Now you can do it with the stylet back or the stylet all the way in. It's fine. Helix fully deployed.
Yeah. At this stage, we connect the electrodes to the stylet, so that also makes some sense.
You can, of course, you can.
So because
that's what I was about to say.
Looking at the certain parameters. So we have 2 electrograms. The green one is from the sheath, Agilis Pro.
You see that? Can you see that?
Some injury you can see already.
No.
You can increase the.
No. You look at the septogram. It's interesting. Could you play that septogram again? The His Pro has actually cupped it. Okay, we do it again. We do it again.
No.
It's okay. It's okay. We're going to do it again.
Yeah.
No. It's okay. It's okay. I'm going to do it again. Mark that tip. Okay, I'm going to do a septogram. Okay, I'm going to do a septogram. Just mark the tip. Mark. Yeah. Okay.
You know what? We showed this.
There you go. You can see that the His Pro has gone in for about 2, maybe 3 millimeter. Can you see that? Can you see the His Pro has actually punched through a little bit?
Yes.
Okay. So now I know I'm partially through. I don't want to drill too deep here.
This is, a tendril. Yes.
Do you have a unipolar unfiltered
Yes, yes.
on the screen?
Yeah, yeah. It will come up here.
Yeah.
Reduce the gains. There's an excellent injury anyway. What is the
Good.
impedance now? Make the signal damping better.
So that's okay. Typically, when you go in, it's about 400. We want to aim for about 100 to 150. So this may hit about 400 or slightly below 400 when we're in position. Okay?
Ullas, I think for the beginners,
Yes.
if you really want to know anatomically correctness,
LVAT.
you pull the sheath out, take a good septogram. And sometimes, there may be a cavity, small kind of empty space
Reduce
where
the
your
output,
lead
please.
is actually going. That may not be able to reach the left bundle branch. So if you know, you go, you come
LVAT.
out of that space and you go to
Reduce the
the
output.
LOA position where you get
Reduce
a straight septal septogram without any cavity there. So that is one thing. You have to move the sheath out from the
QRS.
septum to avoid the damage and to see the septum
QRS
properly.
duration.
All right, Hazra, you know what? We are doing certain measurements. Dr. Tan is going to be speaking about it. So go ahead, please.
Oh, sorry. Okay, the LVAT is about 73 now. The QRS, measure the QRS,
You know what I want?
is about 116, 118. Unipolar good current or injury, but you don't have a little R prime in V1. So that's okay. We just started anyway. We're not nowhere close to the left side. So we can start drilling towards the left. Okay?
Before you start drilling, Dr. Ullas, would you like to connect the black tip to the stylet?
Yes.
Yeah, it is already connected. So you are looking at 2 yellow electrograms, tendril in the unipole, and the down is the unfiltered one. And you can make out the injury. Can you just gain that up? Kartikeya, could
Yeah.
you see that clearly?
Yes, we can.
Yeah. So that's the advantage here. What is the impedance now? 5.5. And so I would like to ask you, at this stage, like what is your impression? You would like to give a couple of
Definitely.
more? Yes.
Definitely, because the impedance is good. There's good current injury. Obviously, we are not through. We are maybe about half a centimeter into the septum. We got probably another, 3 to 5 millimeter to go. Not far. The QRS is not narrow enough. It's still
Yes.
above 120. There's no R prime in V1.
Yes.
Okay, so we are nowhere close to the left side. Okay, we're nowhere close.
So now if you stop pacing, would you like to see the electrograms on the tendril now without pacing? Can you just gain that up? Yeah, is there any potential you are trying to see? No.
100 speed.
Yeah.
No, there won't be any potential because we are so far away.
So far away, okay.
We are far. We're far away. We
All
are
right, all right.
we are long ways away.
Yeah.
We're a long ways away. Okay.
So
Sure, not a problem. Okay, I'm gonna disconnect this. Do you want to keep it on? Typically, I take it off
I
because
usually keep it because continuous monitoring could be done.
Sure. Okay, so stylet back. You can see pulling the stylet back. Bypass tool in. Now we are good to drill. Okay.
We can pace while you're drilling.
Yes. We are pacing. Yeah.
So you can see the lead going through quite easily. Okay. Is there R prime?
Yes.
We can see that.
Yeah, the R is coming.
The R is coming, right?
Yes.
Okay, Ken. Let's stop here for a while. Give me the impedance. Stop pacing. See whether we got a left bundle potential.
520.
LVAT, QRS.
Okay. So
Is
now
there a left bundle potential?
increase the unfiltered little. Look at the injury pattern.
There is a small signal, right?
Reduce the See, are you seeing some potentials on the tendril? No, not yet. Okay.
But we're still away. It's okay.
Okay.
LVAT.
LVAT. You know what? Just get the better, better signature, the usual setup of the unfiltered. I want that nice.
LVAT now 67 milliseconds. QRS.
Not like.
Yeah. Getting narrower. Can I argue that?
Yeah.
Yeah, we're almost there. Almost there. Yeah. Okay, I would like to see a left bundle potential.
Yes. Increase the gain
You'd be
on
perfect,
tendrils,
wouldn't it? Okay, so let's start drilling. Because it's soft, I don't need to extend the helix. Keep an eye on your helix. You can see the helix is still extended. Bypass tool in. I'm going to drill just a tad more. You can pace as you go along. You can see it's rotating quite nicely. 530, yeah? Okay, Ken.
Yeah,
I'm going to stop there.
Increase the V1 little. And
Measure LVAT, QRS.
Color that little
looks
different,
good to me.
Looks good now, isn't it?
Yes, I think we can stop drilling.
We can stop now. I don't want to do any more. Yep, there's a R prime now in V1. Very nice R prime.
Yes.
Very nice R prime there. Come, QRS, LVAT is beautiful. Can't see much. Yeah, LVAT is more to your left, more to your left, more to your left. There.
Yeah.
Good.
Yeah, you can. Yeah.
QRS. Very nice interpeak as well. It's about 120. It's less than that, lah. It's less than that.
Yeah, it's about
120, 110, 120. I'm okay with this already. Stop pacing. See whether I got left bundle potential.
Yeah, please measure the interpeak also.
Oh, nice, nice, nice.
Yeah,
nice, nice, nice. Look at that. Huge.
Yes.
Huge potential.
Huge.
Yes.
Okay, I'm done.
Absolutely. Absolutely.
Finish.
Yeah.
Close shop. Thank you very much.
Yeah.
That's it, really.
Yeah, so we will. Yeah, all that we do.
Yeah. But you got to split it because see the ring is not out yet.
Yes.
Okay, so we got to split the sheath and everything.
Yeah.
So if you want, I can do this.
No, we'll do something. We'll show them high output, low output. It remains constant, and all that. So left bundle.
Go ahead.
Left bundle potential, and now you start. High output, low output. I think the QRS remains.
You can
constant.
measure the steam to QRS,
Yes.
high output, low output, left bundle potential. You know the split, right? Just slit. Yeah, it's just splitting it,
down.
getting in position.
You'll have to every time measure the LVAT and the QRS.
What volt is this?
6 volts. 6.
And the LVAT is 55. Yeah.
Okay.
Yeah. Okay, so every time measure and it remains constant, I think. Yeah. Yeah, 55
Fine.
to 60, yes, that's
fine.
right.
Yeah, keep going.
Yeah.
Yep.
So, Ullas, one is your electrical happiness. The second happiness will be mechanical happiness. I mean the lead stability. So you before thinking of splitting the sheath, you must come to RO again and see whether the lead is actually showing a sign of hinging. I mean, you take the stylet out a little bit and try to push it. Sometimes you may see electrical stability, but once you push or you keep the stylet at the maximum, to the last point, and once you are trying to split the sheath, everything may go in and can go into the LV side.
Hazra, you know what? You
correct.
really missed one of the fantastic lectures by Dr. Tan. What you have been actually quoting now as the repetitions of what Dr. Tan had, taught us.
Okay.
Well, thank you for emphasizing those factors.
Do you have a flush, please?
Yeah.
Normal saline flush.
Okay.
So this is what output?
Perfect. 0.8, 0.8.
So it was at at 1 at 0.4 milliseconds, I think. Yeah, all right.
Okay, so before we split, usually I like to flush, just to get rid of all the
So
contrast.
are we saying at different outputs the LVAT is the same?
Yes.
Yes.
So it is pure selective. all
Yes,
the way.
Ashish. It remained constant at around 55.
More flash, please. So the helix is completely out, so not a problem. I don't need to extend it anymore. I think if I extend any more, I'm just going to go through the saline. Yeah, just saline. The reason why I want saline is I want to flush out all the contrast in that sheet, so when I split, it doesn't stick on my lead when I split
That's
it.
a great point. Yes.
So I like to do that, and often I take this thing off first.
Yes.
Okay, his pro coming off first before I split. AP for me. AP. Disconnecting your lead.
You'll have to focus on the maneuvers, what he does here. Just try to make
Slitter.
proper. You can bring down the, I think, whatever. Yeah, but this has to be seen.
I still need to fluoro as well. Unmac is good. Okay, so that lead is in position. Stylet is all the way back. Advance your lead a little bit. What I'm going to do now is to push my lead forward, unflex, and pull my sheath back. Do you mind holding on to this fat fella? So you know what's going to happen, right? It's just like my sheath. As I pull back on my sheath, I'm pushing my lead forward, okay? So
And you are deflexing the...
correct.
Yes.
Deflecting at the same time as I pull back. Okay? Making sure I don't put any tension on my lead at all. You see that I like that kind of curve?
Yes.
And then as I deflect, you can see I'm deflecting, making sure it doesn't move.
Yeah, and that ensures the mechanical stability.
Yeah, it's very, very stable. And splitting, I'm splitting now, putting that slitter into the groove. I can cut a bit too if I like, and I do this. Okay, ready? Okay, wash. So I'm going to unflex first. Stable. Huh? We're done.
Beautiful, beautiful.
And once we're there, I can just set my heel, and you can test whatever you want. But my suggestion is split that, because you're not a safe sheath there. Okay, I'll let you split. Okay, just hold it. Don't. I'm just going to hold your lead so you don't dislodge it.
So this being a very large sheath, the air sucking is a common occurrence.
Yep. So we are being as careful as we can here. You can put a bit of pressure, and then now you can do whatever testing you want and anchor whatever you want. Okay.
Ashish, any comments?
RAO. Let's set the heel a little bit.
No, I think a great demonstration of a selective left bundle pacing. So happy to see that.
More atrium. More
LVAT is constant. The QRS width is acceptable.
Okay,
there is a
LAO.
R prime there. So as many criteria are satisfied to
L.
say it's a selective left bundle pacing.
Absolutely. So now the injury can be again shown. How is the injury now?
Beautiful. That's nice. AP.
Yes.
Another tip,
AP.
like when he was splitting the
AP.
sheath, sometimes
AP.
there is a circle formed in the lead.
Okay.
Complete circle is formed, like half
Okay,
circle,
I'll let you
full
anchor.
circle.
It's good. Yeah.
So what you do, you just make a anti-clock torque of the lead once you split.
Beautiful. You got left bundle
That
pacing.
will
Current
actually
injury.
reform the sheath into a proper shape.
You know
rather
what,
than just
actually,
pulling out.
shall we show you the bipole?
Yes.
The
Anode capture,
and
bipole.
then let's decide like what kind of an output you will have to be doing. Let's
Ullash,
demo.
do you see any axis here, or you just concentrate on the
No,
LVAT?
actually, you know what? I would have really been tempted to go a little more proximal, because the 2-3 AVF are more negative. But then he had a point that the his itself is quite low location, and then if you pull it proximally, you will go nearer the membranous septum, and it becomes a little more
Tougher.
difficult.
It's
Yeah,
tougher
so-
to get through
so
that
I think
position.
here the
Usually
his
I don't.
catheter, I think the his catheter gave you some kind of
Yes.
the
Absolutely.
guidance, how far you should be away from it.
Yeah,
Yes.
the membranous septum is more fibrous, but the lower one is more meaty.
Yeah,
So you get lot of meat there when it's easier to penetrate with the helix.
Yes.
Yeah, sure.
Absolutely.
Now, what we do is, for the next case, what we'll try to do at the his bundle.
Sure.
Yeah. So,
Sure.
Yeah, because
Of course.
that's my favorite. And this catheter is absolutely made for the his bundle.
Yep.
We spend some 15-20 minutes and make sure that every parameter is okay, stability is okay,
Okay.
And then only, we will station there, or else we come to the left bundle.
Okay.
Yeah. So,
Okay, you can go down now, check the threshold.
so
It's got anodal capture now,
Karthikeya
bipole
and,
with
Dr.
anodal
Saxena,
capture. Okay.
if
Go
you
down
think
slow.
you can carry on with some other lectures,
That
we
non-selective
would like
left
to go
bundle, is it?
offline. What do you say,
Go down.
Karthikeya?
Go down.
I think we can,
4.8.
we and you
Yeah, keep
also
going.
deserve a coffee break, isn't it?
Yeah. All right. So, we will just show you the bipole.
Yeah, you got the R prime
and then,
already. It's
we
non-selective,
can
loss
break
anodal capture.
for
Keep going.
some time.
Yeah.
And then, we can continue the lectures. Show the bipole, please, for the last time.
Oh, very nice. Very obvious now.
Yeah.
Loss of anodal capture is round about here, actually.
So there occurred a change in the morphology.
What is the output now?
Is this
So
unipolar
start at
anodal
3.
capture
Start
or
at 3.
bipolar?
Go down slow. Start at 3. There. There you can
Yeah.
change.
Yeah, that's
Loss of anodal capture. Very nice.
Yes.
Yep. We're going to do it again.
Yeah.
Go down.
Ullas, this is unipolar anodal or it's bipolar?
Bipolar now.
This is bipole. We will show you
Keep going.
the ring capture in the
Yep.
unipole.
2.6 is loss of anodal capture.
Yeah.
Okay, keep going. You can see the R is more obvious in V1.
Yes.
Yep. Keep going.
Yeah, there was a change, right?
Mm.
Yes. Yeah.
Keep going. Let's see whether we got selective left bundle.
Yeah.
Is there a selective there? Yeah, selective, selective. Go to 1.5, go down slow. Go down slow. Yeah.
Yeah. Yeah.
Yep.
Yeah. So now there is
It's
transition
a slight
is taking
change,
place,
right? There is
yeah.
a.
Yeah, no,
go down.
no.
Yeah, go down.
No, this is selective. Yeah. Yeah.
Yep.
Still there is a transition. Yeah.
Yep. Yeah, keep going. Let's see.
Yes. Yes. There.
Yeah,
it
you
is.
can see obvious, right?
Yeah. Just before
Yeah.
losing, it became very selective.
Correct.
Yeah.
So we got anodal, non-selective as well as selective.
Yes.
Very nice.
So we will have
Beautiful.
to choose whatever the best of the QRS.
Up to you.
And will you please show the unipolar ring?
Careful, the lead is not anchored yet. Don't pull on it. Yeah, yeah. Be careful. Just don't pull.
And then you try to show the injury patterns and.
Yeah.
So this is your. This is your ring not connected properly.
This is unipolar to the ring.
Yeah. So put some water or something.
Still no signal, is it? Okay, give me a minute.
Maybe skin.
Yeah. Now?
No, not yet. Put some water.
Okay. Unipolar ring.
No, not yet.
Go to tip. Let's see. Unipolar tip. Are you connected correctly?
No, it is tip. This is tip. This is tip. Okay, now what's the impedance? Show the nice injury pattern there.
It's okay. Same position.
Increase the gain on the uniform. Okay. So that was the tip for you. Go to the ring.
Go to the ring is fine.
Ring, okay, yeah. So the tip injury is more than the ring, and this is a W pattern on the ring.
Yeah.
All right. That's good.
It's okay. It's okay. It's fine. Because the connection is not very good on the skin.
So
it's not very good at all.
So Dr. Tan, you know what? You made this tool to be more friendly than any one of the tools. Honestly, I mean, it's absolutely great.
Yeah, thank you.
And we congratulate Dr. Tan and. The audience there, you may actually break out for a while and please do come back and then
anchor, just put
the
the A
lectures
lead
could
in
be
and
restarted.
that's it really.
Karthikeya?
Yes, Dr. Ola.
Yeah, that's it.
Yes, we'll break for tea.
I request all the members to move out to the right side of the auditorium where tea was served.
Thank you. I should have written back to you. Thanks. Yeah.
Let's begin the session 2. It's a privilege to invite Dr. Richard H. Hongo, cardiac electrophysiologist, director, cardiology fellowship program at California Pacific Medical Center, San Francisco, to share his thoughts on review of current evidence for conduction system pacing. And also I invite the moderator for this presentations are Ameya Udyava, consultant cardiologist, PD Induja Hospital and Medical Research Center, Mumbai, and Dr. Ajit Tachil, consultant cardiac electrophysiologist, Lisi Hospital, Ernakulam.
So, Dr. Ulas, thank you so much for inviting me. I'm very honored to be here. So this last week, I've had the pleasure, this is my first time in India, and I've had the pleasure of visiting a number of places. So it's great to see actually very familiar faces all through the audience today from all over India. It also speaks to how this symposium is drawing people from all over India, and it's been very impressive to see what's going on in EP here in India. So just a word about, I want to give my perspective, because what I'll talk about is with perhaps a different perspective from what many of you are experiencing. Let's see. So I'm in San Francisco. After training at UCSF, I went to California Pacific Medical Center, which is the largest private hospital in San Francisco. In that system, we've been very aggressive with ablation, but also pacing. And about 4 or 5 years ago, when his bundle pacing came out, we embraced it. But very early, we had a number of cases where the threshold went high, as I'm sure all of you have had a similar experience. And because we are a large network through Northern California, there were some decisions that were made from our hospital standpoint that we collectively decided to actually hold off on conduction system pacing and see where the data went. And then with the advent of left bundle, but also HRS this year, with the number of studies that came out, some of the key pieces of information that we had all been waiting for was starting to show. So we're actually now starting to do mostly with the 3830. So this is my perspective, and it's in that setting that we've been keeping a close eye on the data, but it's also a perspective where, you know, I see ourselves as not early adopters, but late adopters. We've been very anxiously excited about this, but in the setting of a large medical network, we've had some constraints. So it's in that setting that I do want to review kind of where the data is and also give some reflections on that. So if we let's take a second and remember what it was like about 20 years ago in the 2000s when CRT was happening. So here's a look at over a decade. This is the number of cumulative patients that were in the system. This was a nice kind of review of where the studies were. And this is me coming out of UCSF right when companion trials started. So if I think back to that time, we barely had 3,000 cases. Let's just kind of think about it. Barely had 3,000 cases, did not have any randomized controlled trial looking at any clinical data prior to companion. Remember, all this was just kind of observational studies, and everyone was very eager to see this work. But that was really the environment that we were at. And I remember coming out of fellowship being very excited and right away doing a lot of CRT, but it was in the setting of companion just coming out. And of course, companion showed us the data that we were all waiting for. But here, this just came out. In fact, this is from one of our faculty, and the next one is actually from our faculty as well for this symposium. But there's two recent reviews of the literature that do an excellent job. So if you're interested in seeing kind of what all the studies are, they list out everything for you. I'm just going to summarize it for you here, but also talk about the studies that are on the horizon that really are the ones that we're waiting for. So if we look at what's currently been completed and we have available to us, if we just look at his bundle studies, primarily bradycardia and heart failure indication, primarily early to midterm follow-up, of course, more than 6 months. And cumulatively, it's a little over 3,800, very similar to where we were just before Companion. In fact, one could argue more. And that's just his bundle pacing. And now we're looking at left bundle, so this review does a great job at looking at both of them separately, but left bundle area pacing studies, primarily still bradycardia, now starting to do things like heart failure as well as AV node ablation, only early follow-up, really, but still over 6 months. But still, despite the late entry of this particular, it's still more than where we were prior to Companion. So it just speaks to the excitement. I mean, all of us, I'm sure, even though I may be considered someone that's been cautious about this as a system, we've been cautious about this. There's no question we've been excited about it. This has been one of the more exciting things in EP in a while. But this gives you a perspective that I think is very similar to where things were back prior to Companion when CRT was coming out. So here's the other review by when it also came out this year. And really, the randomized controlled trials on CSP to date have really focused on physiologic endpoints, imaging, ejection fractions, hemodynamics, and really what we're doing is we're waiting, all of us are waiting for the randomized control, similar to the Companion was for CRT, to address clinical outcomes of survival in heart failure hospitalization. So as you all remember, this year at HRS, at late breaking, a number of trials came out that really prompted a lot of excitement. I remember being there because it was our hometown. And the two that stood out are the ones that let me just kind of show you as an example of what was enough. Really, in our minds, these studies were kind of the catalyst to say, okay, we've been waiting on the sidelines enough, so we're actually going to start doing this in more earnest. But there were two studies. One was a pilot study, but it was a prospective randomized control trial. So again, the importance is this was a randomized control trial. And this was in a population that was otherwise indicated for CRT, right? New York Heart Association class 2 to 4, non-ischemic, low ejection fraction, left bundle. And in this particular study, you could do either left bundle, well, you were randomized to either doing left bundle pacing versus biventricular pacing. And if you were unsuccessful, you could actually cross over. That was the design of the study. 40 consecutive patients, half men, half women, mean age of 64 years, and a left ventricular ejection fraction, mean ejection fraction of 30%. So very representative group. There was crossover. 10% of patients that initially were basically randomized to left bundle pacing, crossed over to do CRT. What at based on the study, successful left bundle capture for this particular study was fairly, we saw a lot more detail in the case that we just did, but for the particular study, it was essentially either, one could argue a little simplistic, but right bundle observed, or an LVAT less than 100 milliseconds, in addition to some other findings that would support that you're having a selective capture. So fairly straightforward, but that was what it was. And then there was also some crossover from trying to do CRT, but then crossing over. In fact, that's a little higher, 20% compared to 10%. Nonetheless, this was the study, and the endpoint, and this is where it does fall short of what we're all anxiously awaiting for. We want the randomized control trial that gives us clinical data. This is randomized control trial that gives us great data, but it is imaging, left ventricular ejection fraction, and so you'll see some other secondary parameters. So here's the results. So this is just the, on the left here is the breakdown of that, but let's just look at the results here. So the treatment effect, the primary treatment effect was ejection fraction. And as you can see, left bundle, this was a randomized trial. And this is what I think really got our attention, is that, one could say if it's equivalent, we would be happy. And yet this actually showed statistically significant better improvement in ejection fraction compared to CRT, despite some crossover, because anytime you have crossover, it dilutes out the result. And then if you look at intention to treat, so that means, you know, you basically, you allow that dilution of effect by just letting the crossover be there. And despite that, the left bundle branch pacing arm had smaller left ventricular and systolic volume. So again, this is another way of looking at reverse remodeling in these patients. And then if you look at, so if you look at intention, this is on the left-hand side. My arrow's not showing. On the left-hand side is intention to treat. On the right-hand side is per protocol. So as you all know, per protocol is basically looking at who actually got left bundle versus biventricular pacing. So if we look on the side on closer to me, you can see that with sinus rhythm, you can see the QRS complex, and with PACE, both of them narrow down nicely. But if you go per protocol, as expected, the left bundle paced complex is shorter. Not quite statistically significant because of the confidence interval you can see there, but clearly shorter, as would be expected. So some other findings that showed. And this was also interesting. If you look at the effect, so the closest to me is an ejection fraction that started off, ejection fraction improvement of a little more than 5%, so that's could be considered a smaller effect. But as you looked at patients that got a more dramatic effect, and that's moving out towards the right, so ejection fraction more than 10%, you see that left bundle, there were more patients with left bundle versus those with biventricular pacing that had that more than 10%. And if you look at the super responder group, this is what we're all kind of searching for, is there was a noticeable difference in who responded. The left bundle pacing group, and remember, this is randomized data, not the clinical data that we're ultimately waiting for, like Companion. But this is a great, smaller but a great randomized control trial that looks at noticeable improvement with left bundle pacing when compared to biventricular pacing. And this is in a population that otherwise would be indicated. Then there was the other trial that also, I think, caught our attention. And the reason why it really caught our attention is because this was now looking at the clinical outcomes that we want. Again, falling quite a little bit short of the randomized controlled clinical studies that we want. But it is looking at those clinical outcomes that we really want in a population, again, that would otherwise be indicated for CRT, right? So if we look at the fine print, this is an observational New York Heart Association class 1 or 2, so on the milder side, ejection fraction less than 35. So this is really, the patient you would consider for CRT, underwent successful BIV or CSP at 2 major health centers. Granted, these are very experienced centers, both of them. And they looked at 447 consecutive patients, about a third were women, mean age of 72, and mean ejection fraction of 26%. And the primary endpoint is, again, these are the primary endpoints we're now craving for, which is death or heart failure hospitalization. And as you can see, again, this is not a randomized controlled trial, but it is a large series in 2 centers that do a lot of great work in this field. And looking at conduction system pacing versus biventricular pacing, you can see that survival, this is survival, you can see that on the side, was higher in the CSP group. Not quite randomized, but without a doubt higher. And if you look at other factors, again, these are secondary endpoints, but QRS duration was also shorter in patients who were paced using bundle branch pacing. The ejection fraction, as you can see, was also better. So you can see the blue, I wish I had a pointer. You can see the blue, which is pre, which were both very equal. Biventricular CSP were both very equal, and both improved. No question about it. We all know that CRT works. but you can see the degree of improvement is actually better with CSP. So these are findings we're all anticipating on seeing, but the place we're at right now is that we still don't have the companion equivalent of CRT. But I think we're right there, especially with some of the review studies that were showing what are the studies that are out there right now. I think it is a matter of time that we get the data that we all want. Now, the HRS, Asia Pacific HRS as well, guidelines are still in the works, anticipated. But we do have the 2021 ESC guidelines that came out last year on cardiac pacing and CRT, and specifically, they did mention his bundle pacing, did not specifically mention left bundle. But if we look at the indications in this guideline for his bundle pacing, there were 3 that were related to his bundle pacing in terms of an indication. So the first was in CRT candidates in whom CS lead implantation is unsuccessful, his bundle patients should be considered as an option along with other techniques such as an epicardial lead placement. And all of us, I think, understand the limitations of left epicardial lead placement, so I'm more than happy to consider this as an option, especially with all the data that's out even beyond when this recommendation came out. The second is his bundle pacing with a ventricular backup lead may be considered in patients whom pace and ablate strategy for rapidly conducted supraventricular arrhythmia is indicated, particularly if you start out with a narrow complex. And so this is, again, class 2B, so not as strong as a 2A with a level C, but I think there is growing a comfort with that. But especially, as has already been discussed during this morning, is with his bundle pacing, there is the concern of increased thresholds. So you are making the patient pacing dependent. So a backup lead, there was actually a stronger language within this, within this guideline about recommending a backup lead if you're doing his bundle. And then finally, his bundle pacing may be considered as an alternative to right ventricular pacing in patients with AV, block, and ejection fraction of more than 40% who are anticipated to have a high burden of ventricular pacing. And that number is traditionally been 20%. The reason why it's above 40 is because those below 40 have the indication for CRT at this point. So at the moment, and I think we are all anticipating more guidelines to come out specifically looking at that, and I am hoping to see some more language that also guides us in terms of left bundle that may have a nuanced difference there. This was an interesting physicians survey, very large survey in Europe. I'm going to highlight kind of some of the areas, but these are in the survey what physicians perceived as obstacles to adopting CSP. And this is kind of relevant from my perspective as a system that has been kind of on the sidelines waiting to kind of work this out. And so this is really why we had been waiting. And we've kind of gotten to the point where now we see enough data, and it really is that pre-companion moment, companion trial moment for us, where we feel that this is something that we're ready to embrace. In fact, I had 2 of our younger EPs continue. We were supposed to stay away from it as a system. Just certain decisions are made through the network. But I had 2 of my junior EPs continue to do this so that we continue to have expertise that we will now kind of unleash. If this was a little busy, so let me just walk you through it. This is the same survey, and this was kind of interesting, again, to us. This is a survey asking of people that are doing conduction system pacing. For each of these indications, what is the proportion of how it's being done? So if you look at the column closest to me, which is AV block, preserved left ventricular ejection fraction, what it's saying is the yellow is implanters doing either left bundle or his bundle. The green is only doing left bundle. So these are physicians that said, oh, if I have a patient with AV block and preserved left ventricular ejection fraction, I just go straight for left bundle. So you can see a large, over 50% would do one or the other, but there's a growing number of people that just go straight to left bundle. And then right below that is still 25% of patients said, you know what, I will still kind of consider RV pacing first. And then you go on to, for instance, look at the two CR indications, the left bundle branch block CRT and the non-bundle branch block CRT. You can still see that biventricular pacing was something that at the time, this was, I want to say, came out, but it was a survey that was done a few years ago. So at that time, still a large number of European implanters were considering CRT indicated patients were still getting CRT. But that group, as you can see up there, was growing. Ablate and pace, you can see that most were doing left bundle, his bundle, or even left bundle only, and only a fraction of people were doing either right ventricular or biventricular pacing. So that gives you a sense of where, you know, where the direction is going already. And I think I'm talking to a group that may already relate to this type of direction. So really, you know, this was really just to give my perspective, but also to review for all of you kind of where we are, despite this being a very exciting field on the cusp of all the data that we want. There are a few pieces of data that we still don't have. And to summarize kind of where we are in terms of clinical or current evidence, there's a substantial body of evidence that supports the feasibility and safety of both his as well as left bundle. That's already been established. Growing body of evidence that shows that QRS complex narrowing improves as the left ventricular ejection fraction and functional class compared to, I'm saying compared to CRT and conventional therapy. And then early cohort trials do show impact on mortality and heart failure, but this is in observational cohort studies, not yet randomized. We are awaiting randomized control trials that tell us that in fact survival as well as heart failure hospitalization is improved and perhaps even better than CRT. There's already a sense of that with the observational trials. And of course, we are awaiting longer-term safety data. I think it's been voiced, you know, what happens when we're trying to extract, what happens with the safety of some of these leads, like that we saw in terms of that have weak links to it. And so this will take time for us to figure out. But like we learned a lot from CRT, and we learned what the safety issues were. Undoubtedly, we will find that. But there is no question we're in a really exciting time right now. And this is, you know, from my standpoint, this was a really timely conference because, in fact, we've been wanting to move away from primarily doing Medtronic, because that's what we've been doing, to a Stylet-driven Abbott. We're a big, San Francisco, interestingly, the Bay Area, San Francisco in the United States, the proportion of use of Abbott is actually higher than Medtronic. In the States, it's usually Medtronic. Just has to do with historical kind of development of the area. So we've been kind of using Medtronic, but really wanting to embrace this technique. So seeing this live, but also having you focus on it has been very educational. I'm going to take this back and really talk to our administrators about how we have to move forward with this. Yes. So do we have time for questions or?
CRT and LVB zone pacing.
I'm sorry?
Wide CRT.
Wide CRT. So non-left bundle branch?
No, that piezoelectric crystal, wireless CRT. WISE, W-I-A-C. Endocardial, wireless.
Oh.
WISE, W-I-S.
Yes.
Anyway, I'll come.
Wireless, yes, I'm sorry, yes. Well, so that's the other area of excitement right now, right? Because Avera is just coming out. And as you know, there are a lot of advantages to Avera that we are embracing because you can place it, it's a little more elegant, and most importantly, there will be an atrial wireless as well, which you can get dual chamber pacing. It's coming out at a time where obviously the current iteration doesn't allow you to do conduction system. And
no, actually, we are talking a different thing.
By
like
getting
piezoelectric crystal, the LV chip, and then you interact transmission of the energy by piezoelectric crystals.
Okay,
like
that I don't have.
Anyway, so I'll put a different question to you.
Yes, yes.
Suppose you have a patient with ejection fraction of 30%, and you've done the LVB zone pacing, and ejection fraction is 45%. And suddenly you switch off the CRT, would you think that QRS has become from 160 to 120 millisecond? If you switch it off suddenly, do you think the 160, the 120 millisecond of QRS will be 160 again? Or will take some time to go back to 160?
That's an interesting question. So you're saying that there has been remodeling enough, probably structural remodeling, where the conduction has also remodeled to a point where it's dramatically better. And you're asking what would happen if we just turned off CRT to see what happened? I've never done that. Because there is, as you know, there is evidence, for instance, if you stop beta blockers in patients who have remodeled, there is a proportion of patients that will regress again. And my concern is always, once it regresses again, can I get them back? It's not a given that once you let go of that improvement that you'll get it back. So I would say, I think the majority of us would say, if it's improved, you're going to keep it because that is what's doing the improvement. I guess that's an interesting question because I will get posed that question from my cardiologist, who I've put this device in, and now the generator is ready to come out, and the ejection fraction is better, and they'll ask me, what's the ejection fraction? Do you really need to put in a new device? And maybe I might not give a defibrillator if it's a primary prevention, but I've always insisted that once we have improvement with CRT, that CRT stays in, because that's part of the reason why it's improved, yeah. Hopefully that answers that question, yeah.
I had a question.
Yes.
See, now regarding ICD therapy, now there's current evidence to show that ICD therapy is more effective for ischemic subset
yes.
than the non-ischemic subset. So if in the absence of randomized control trial, if you have to say which is the subset of patients who is going to benefit the most with CS pacing, what would be your take? Means which is the patient, when you see them, you will say, no, this patient deserves a CSP, that I will offer him a CSP.
Yeah, that's a good question. So as you know, it's now pretty well established that non-ischemics do better with CRT. One would think that bundle branch pacing, because remember, both of these studies here were non-ischemic studies, which showed dramatic improvement. This is against CRT. So I would say the expectation is that you're going to see a very similar improvement, which is so one of the things I've realized is here in India is cost is a very important factor, for patients because of insurance or lack of insurance. And I think the question will come up, if we're doing CSP, do the patient, do we really need to consider primary prevention ICD therapy for these patients, especially non-ischemics? And as the data for non-ischemic primary prevention has become much more challenged, what we do now a lot is we do a lot of a cardiac MRI for these patients to see if there's a substantial burden to justify. Because there are studies that show that if you have no significant delayed enhancement on cardiac MRI for a non-ischemic patient, primary prevention may not be the answer. So, given what I've heard from many of you as I've been around the country this week, is that I see many of you using CSP as a way to treat patients very effectively with a pacemaker, basically, without even having to worry about the defibrillator portion of it. Now, when it comes to ischemics, that may be a different struggle that has to be assessed. But that was an outside observation that I was privilege to make.
In the
Yes.
heart failure patients, would you like to see a randomization of biventricular pacing versus left bundle area pacing versus lot CRT?
I would like to, yes. Just because, you know, CRT has data. It does show that it improves. And while it is very encouraging with the observational trials, the randomized control trial is the best. I do see, and Dr. Ulas and I were talking about this, we were lamenting the possibility that maybe as this takes off, CRT will just go away. Because, you know, I'm someone who loves CRT and the struggles of CRT and the joys of CRT when we can get it right. And I do think there will have to be, if all of us are true electrophysiologists that want to resynchronize these patients, either through CSP or CRT, there's going to be patients that respond to one, there's going to be patients that respond better to the other, and there's going to be patients that I think will need both to respond, and that will be a fun challenge, I think. I don't think we'll need LOT for everything. I think there'll be some that one modality will work effectively. And again, Dr. Lewis and I were kind of talking, well, which do you do first in that scenario to try to come to that answer? That will be very interesting to see as well.
So Ashish, if I could add to your...
I think, I know that, you know, those people who are kind of old into this practice, we will definitely we are lamenting about the exit of the CRT, but I think CRT is going to stay. CRT is going to stay because as we understand the conduction system disease, we will try to figure out who is that for the CRT, who is there for either the pure conduction system pacing or conduction system optimized CRT. I think the evidence, is more towards if it is truly conduction system disease, proximally located, maybe conduction system pacing would work, and then even the CS lead may not be required. But I think if you have an evidence for a distal conduction system disease, more of a myocardial disease, I think there is going to be a role for the conventional CRT, or you know, you can add the conduction system lead to optimize the therapy. I think this is evolving. CRT, I do not think I want to see it's getting exit in another 10 years, during which time, you know, I am still practicing.
So I would like to add to that discussion, Dr. Ullas. I think the problem here is the way we define left bundle branch block. Yes. Out of the 4 definitions of left bundle branch block, which are most commonly used, the ACC-AHA definition, the EHRA definition, the definition that was used in the Madras trial, and the Strauss criteria, there was only a 13% agreement among the 4 definitions on what constitutes left bundle branch block. So extending what Dr. Ullas was saying, if we can figure out what is true left bundle branch block, those patients, I think, would need only a dual chamber pacemaker with a lead in the proximal left bundle position and a right atrial lead. Whereas anything else, if we can figure out if there's a myocardial disease, we would need the CS lead to correct that also. And the way, at least, I go about it, and I think the reasonable way to go about it is put the left bundle lead first and the right atrial lead first, pace and see, and then take a call on whether we need the other lead.
Yeah, so but then, you know, there's another argument here. Put the CS lead first and then see.
You could.
So
I mean, the only way to, as of now, the only way to figure out that is on table.
We are yawning. The older generation will put the CS lead first and check. And you are putting...
The whole problem is we are still not figured out what exactly is left bundle branch block.
Yes, that's his. That's assuming CCM will look as promising as these other therapies. CCM, cardiac contractility monitoring, a very different topic than today, but I think we are at a very exciting time where we're going to have to be figuring out a lot of stuff in the next 10 plus years, which is exciting. So again, thank you very much for.
We will focus more on Stylet-driven. I know, but this discussion would never end unless you chip in and you talk about what do you think is the way forward, extending his talk.
So we had published a paper of 188 patients from PGI Chandigarh of dilated cardiomyopathy and shown that over a median period of the total median duration was 8 years. And even after 3 years, 1/3 of the patients who recovered their LV function, they relapse when we stop the conventional anti-heart failure drugs. So we had proposed in that paper that even after recovery of LVEF, the drugs should be continued. And those patients who developed LBBB development is because of the fibrosis of the conduction system. So LBBB, when once develops, it is unlikely to regress. Like he told, if we shut off the CRT, it is unlikely for the QRS durations to come back, even though the EF might improve. So there are case reports for everything.
So ladies and gentlemen, I think just to give a perspective of what you spoke, I think he's going to show something about the evidence and
Not evidence, is basically all of your discussion is very interesting and oopsie. I'm trying to make this thing work. Okay. So yikes. Okay. I'm trying to write this thing out and get some ECG and just give you a perspective of how it works. And it kind of ties into the initial ECGs of lab bundle pace and oh gosh, what is happening here? Sorry, give me a minute. Oopsie. Okay. Why is it doing this? Sorry, give me a minute. Sorry, give me a minute. Why did it go and close this thing? Okay, sorry. There you go. It went hiding on us. Okay, give me a minute. This is in relation to ECGs and me just doing maneuvers to kind of give me an idea of how lab bundle can correct this and us trying to understand this may go a long way to explain this. And when I brought it up and I presented during APHRS, there was quite a lot of interest in it. Okay, so let's go with this, and I can go through some of the cases with you. And this is kind of like impromptu, stop me, but it should be able to explain quite a few things. And this is a slide I'm gonna go through this with my subsequent talk with conduction system pacing and heart failure, but it kind of gives you an idea. Now, just now we saw that patient had a right bundle branch block when we actually pace, and the left bundle branch area pace can actually correct that right bundle branch. And I had a discussion with Dr. Olhas on how that happens. And basically, when you pace the left bundle, you can actually correct the right bundle, and his bundle obviously correct right bundle, or the left bundle for that matter. We'll come back to that in a little while. And how the left bundle pacing can correct this is, you have several wavefronts. One of it is capturing the left bundle. The left bundle goes through transeptally. Conduction goes to the right side and correct the right bundle that way. Non-selective left bundle can have myocardial capture on the left side, deep myocardium, and go down the septum, correct your right bundle that way. You can have your anodal capture, conducting down on the right side, correct your right bundle that way, engaging either your right bundle or your moderator band and correcting the issue there. And importantly, you can have transverse conduction between the left bundle towards the right, or retrograde conduction up to your AV node and then coming down to your right. But the trick is, how do you prove it, and how important it is when we come back to how left bundle corrects it. So I'm going to jump around a little bit, but I think this case will be quite interesting. Again, I do conduction system pain just about everybody because it doesn't take me a lot of time to do it. And this is a patient basically with sick sinus syndrome, syncopal events, post-conversion pause, refused to have AF ablation, just wanted a pacemaker and get out basically. And so ended up with a pacemaker. Left bundle went in. Again, I'm just going to go through some of the ECGs about the maneuvers that we did. 12-lead ECG, left bundle with anodal capture. You get a deep QR pattern in V1. Yep, with anodal capture, output 3.5 volts at 0.4 milliseconds. As we drop the threshold, you lose anodal capture. from anodal capture with non-selective left bundle to non-selective left bundle branch capture. Just bear with me. I'm just going to go through this so that you know actually all the output. And you can see that the QR, the Q becomes less of Q, and it changes when the output drops to 1.4 volts at 0.4 milliseconds. So I know when anodal capture has been lost, and you're getting non-selective left bundle. Yeah, we all agree there, right? Yep, okay. Then as I continue to drop it, and this is where we lose anodal capture, you can see the QR pattern actually becomes less of a QR pattern in V1. Yeah. As we continue to drop, as just before we lose, and we demonstrated that just now, from anodal capture to non-selective left bundle to selective left bundle, and you can see that it's all R now. You get a big R in V1, you get selective right bundle, and the last beat is safety pacing from the HISPRO. So you get that 6 beat, you get all 3 morphology in just 6 to 8 beats. I just love this ECG. Okay, just get everything there. But what is interesting is this. Now, again, showing how it changes from non-selective to selective left bundle. Again, non-selective to selective, local EGM, you can see the changes. It just jumps up with an isoelectric line because they end up with selective left bundle. You can see that. So I'm not trying to pull a fast one here. And conducted beat down with a left bundle potential. And most of the time now, about 80%, 70, 80% of the time, I can get a left bundle potential. I can actually capture the left bundle. Okay, so again, we did the same thing with unipolar. Now, unipolar doesn't have anodal capture, obviously. It's just going to pace all the way from non-selective to selective. And then with the safety output, with the big spike, because the safety output, the last 3 beats, you end up with, sorry, non-selective left bundle branch pacing again. Now, the interesting part is this now. Now I have the output, and it's very clear at which output when I can get non-selective, selective, and anodal capture. Okay, so how do we prove how the right side is actually engaged in this way? Because if you look at the literature, they always tell you that if you get a left bundle capture, you get a right bundle branch block or partial right bundle branch block. So how does that work? So what we're doing is I'm going to do NIPS. I'm going to use just a device and just a 12-lead ECG, a lot of paper, and just keep running that thing. And then I'm just going to do NIPS. And I'm just going to give a train 8 beats, and then just give an early beats. And the idea here is that if I give early enough beat, I can cause ERP. I'm trying to select the effective refractory period of the myocardial tissue, the left bundle or the right bundle. How can I prove that? So as I drop with unipolar, non-selective left bundle, as I drop it down to 450, 300, 450, 280, I don't know whether you can see that, you get an isoelectric line and a full right bundle branch block. Okay? Now, why that happens is that now I've lost my right bundle. I've also lost my myocardial capture. I'm just capturing my left bundle alone, and that's why you get a isoelectric line with a right bundle branch block. Okay? Now, if I drop my output some more to selective left bundle, just selective left bundle capture, and I start to drop it, again, because it's unipolar, selective left bundle, you can see that it's isoelectric line. I got selective, so I'm not bullshitting you there. That's actually selective. As I drop it, you get the same picture. You get the right bundle branch block when I drop it down to 450, 280. That means I've lost my right bundle. I can get my ERP for my right bundle is slightly longer than my left bundle. And I can just selectively cause block for my right bundle. And we can prove that actually it's because of retrograde conduction. And because I pace, I can demonstrate that. Now, what's interesting is that, what if I do bipolar? Because now I got anodal capture, right? That's the interesting bit. Okay. Now, if I got anodal capture now, we got another wavefront. It's going to be on the right side with the anode that is capturing it. The myocardial capture on the left side, as well as the left bundle capture, and my right side has all 3 wavefront, everything coming through towards your right side. Now, as I drop that output, you get the, and this has been reported before, NIPS, you get selective left bundle with a right bundle branch block. But you still have the anodal capture, right? As you drop 450 to 280, right bundle, your right bundle has lost. Left bundle still capture, but myocardial is selective now. That's the isoelectric line. But in this situation with bipolar, because I still got anodal capture, and if I continue to drop it down to 450, 260, now you get a QR pattern. So that's so cool. Now you get that because now I've hit my left bundle ERP. I've lost my left bundle. But now I still have my septal capture on the right side from the A node. I can still capture it. That's why I get the QR pattern in V1. Cool, right? So that's 450-280 to 450-260, you get a QR pattern. And you have lost your left bundle. I can still prove that if you measure your LVAT from V6, it jumps up to about 100 milliseconds because you have lost left bundle capture now. And this is really just a 12 lead, me just playing around with it. Okay? So in summary, by programming output and pacing, we can achieve anodal capture, selective as well as non-selective left bundle. Okay? And by doing the NIPS, we can actually play around with the ERP and we can demonstrate how the right side is actually engaged. Okay. Now, that being the case, I'm going to go straight to the left bundle. Okay, I'm not going to touch on this because this is another patient that we went through with a right bundle, which is also quite interesting. If you've got time, we'll go through that. But I think we just go straight to the left bundle, which I've used this for the other patient, which is my final talk when we do. Okay, so this patient, I'm just going to jump onto it because everybody's in it, but that means my next talk is going to be very short, unfortunately, because I use this as a case study. And this is interesting because we were talking about this. Full left bundle branch, EF 25%, clearly. Recurrent admission for heart failure. QRS is 170, 180. This is a huge QRS with the full left bundle branch. CRT, left bundle area pace. We're here for conduction system pace, so you know what I did, okay? So anyway, this is Terrence who helps me, and he says that, look, at 170, 180, we're going to hit it below 120, right? How confident are you? Below 120. Can you do it? Okay. He was a bit cocky, I must say. By that time, we had so much experience with that. He was saying, yeah, we're going to get it below 120, you know, we're just going to do it. So again, I won't go into this because that's the next talk, the evidence that we have. So initially, we went with a HISPRO, left bundle area pace, LVAT about 80 milliseconds, QRS 130 milliseconds, interpeak about 40, 41 milliseconds. Accept? Don't accept? Well, it wasn't quite 120 milliseconds. Huh? So we went on ahead and we tested out. We got anodal capture, bipolar anodal capture. Not much of an R in V1 because that's anodal capture. QRS about 140 milliseconds with the left bundle area pace. We continue to drop that output, and that's because there's conduction delay laterally still because the left bundle, assuming there's nothing wrong with the right bundle, but we'll come back to that in a little while. The right bundle in situation, assuming that there's nothing wrong with it, it's retrograde conduction coming back down onto the right side. But that's not all the case. Huh? We continue to drop the output, you end up with non-selective left bundle branch, you get a QR pattern, same patient. QRS now is about 135, 140 milliseconds. Accept? Don't accept? Not below 120. So we end up with a lot CRT, okay? Still not 120, yeah? So lot CRT, we know all of that. We touch base on this as part of my subsequent talk, so I'm sorry, I'm jumping the queue here a little bit. And basically what they did was that if you cannot lower your QRS, you just put in another CS lead with a left bundle conduction system pace, but they only lower the QRS to about 144 milliseconds on average. Okay, it wasn't anywhere close to the 120 milliseconds cutoff point. And these are all the parameters, again, so I won't touch on that. Seems to improve, and luckily for this patient, had plenty of veins and CS. We can actually do that very easily. You can see that, and the idea here is that I'm engaging the left bundle in the septal area, but because there's distal conduction delay, I'm going to pace this epicardially with a CS lead. Okay, so epicardial lead went in, CS lead is in now, and this is what we do. Pacing from the CS to the left bundle. You can see a little R before the Q in V1 because the left bundle is coming in first. 15 milliseconds, best fusion, 130 milliseconds. We try to pace the other way around because log CRT is actually the septal pace going towards the CS. At 15 milliseconds, we can hit it down to about 120, 130, slightly shorter. Except, enough? Not enough? Good? Not good? Not below 120 milliseconds. Still not good enough. Still not good enough because there's one more waveform. It's in Abbott. They develop it for that reason. Sync AV, absolutely. Sync AV was developed not to address the left-sided conduction delay. It was developed to let conduction come down to correct the right conduction delay. In this situation, the conduction block or the conduction delay, what's preventing QRS from narrowing is not just the left side alone. It was also the right side that had conduction delay. And whatever conduction system that you have, retrograde conduction back to the AV node are coming down to the right side. All the septal activation was insufficient to correct that right side. Theoretically, there was still nothing wrong with the right bundle. So in other words, the block was probably proximal to the left bundle. It can't come back. It can't come back fast enough. But AV node down towards the right, it could still conduct. Sync AV allows us to do that. And when we powered out Sync AV, and the Sync AV, that's how it works, 256 cycles, take the last 3, delta 50, and keep playing with the delta to allow more and more time. Now the conduction delay here was about 250, 300 milliseconds AV delay, measuring to the left bundle, okay? So we introduced a delta of 80 milliseconds, minus 80 milliseconds. And guess how much we got it? Okay, and that allows the right bundle to correct. And I won't go into too much details. No, that's the evidence for that, okay? And that's the QRS. 105 milliseconds. I'm not kidding you. When we got these results, I came out and I sat down there and measured this 3 times, repeatedly, again and again and again. I couldn't believe it was 105 milliseconds, but it is true. It is 105 milliseconds. From a baseline left bundle branch, 170 to 180 milliseconds, we cut it down to 105 milliseconds with locked CRT. Final positions. Okay, so in summary, there is consumption delay in the LV septum going towards the base of the lateral side. It is not correctable with just non-selective left bundle capture alone, QRS of 135 milliseconds, but left bundle area pace straight towards the CS, we can correct the left side to a certain extent. But there was also right-sided conduction delay. This right-sided conduction delay was not correctable by local septal activation alone on the right side. It was not correctable with the left bundle retrograde conduction coming down. It was still too slow. It could not correct it. But it is correctable if you let the AV node come down through the right side. It can. If you go with his bundle pacing, we have another problem. While it may address the right-sided conduction delay because it can come down through the AV node, you can correct that. But it will not be able to correct the left bundle area because you still need that CS lead. So you may be able to put in a his bundle, but you still need a hot CRT approach for this. So the answer to that question, and that's where all the discussion is CRT dead because we've got conduction system pacing? My answer is no. No. It's not one size fit all. Because when the patient presents to us, it depends on where your conduction delay is. Is it on the right? Is it on the left? Is it proximal on the left? Distal on the left. Proximal on the right? Distal on the right. And how we tailor our approach, now we've got a very real chance here right now. We can correct not just the left, but we can correct the right. We can correct both. Now, whether that translates to better outcomes, long-term, heart failure admissions, survivability, we don't know. We just don't have long-term data to actually support one way or the other. But my answer is don't just stay with CRT alone or conduction system pacing alone. If one doesn't give you that result that you want, be prepared to go for the other. Sometimes you need both. In this situation for this patient, you needed to correct both. You can only correct it by literally having 4, 5 different wavefronts coming down, correcting both the left and the right. Okay? I can't help but think that at a QRS of 105, you're going to do well. She's a super responder. That's for sure. She's not been admitted for almost a year now. No, I don't put I fix the threshold. Because the auto threshold will have one more problem. I don't know when there's selective, non-selective, and odor capture, for example. I can't tell the difference. In this situation, I want an odor capture. I want that. Because I know that waveform, I need all of that waveform to engage the right and on the left to fix this. Exactly. So I give enough of a safety margin to make sure I get an odor and non-selective capture. In this situation, because it's a left bundle, the threshold was so low anyway. even at a nominal output at 2.5, 0.4, I had anodal capture already. Typically, if you do a left bundle pacing, you realize the threshold is so low. It is actually very, very low.
If the tools are going to be better, I think the his bundle pacing could be the most physiological. All the limitations currently for the his bundle pacing is the tools are not present. Because you see, if you are correcting the conduction system disease with the left bundle, for example, typically in this case, if there was an inherent right bundle disease also, it's not going to be correcting, it's not going to making it as narrow. But imagine a tool where you really have this assurity that the lead stays there with all the good parameters. His bundle pacing could again come back to the mainstream.
I did all the maneuver as well for a patient with a full right bundle. As well, I skipped that one. If you want to look, I can go through. I did a NIPS for that as well, decreasing the output and how we can engage the right. Why you cannot engage the right in situation. So if you have time, we can go through that, but if not, we can just get on. No. Calipers looking at the 12-week ECG and I measure it straight out. Okay, but I think that at 100 milliseconds, I don't think you can. That's not difficult to say that this is probably 100 milliseconds. Probably that's an overestimate here.
I will read it
It's
as
not.
90 milliseconds.
Yeah, I'd say 100 milliseconds. I think I'm just being very pedantic. I'm just gonna make it as long as I can, really, because I didn't believe it was 100 milliseconds. I really didn't believe it.
It's not 100. It's less than.
It's less than. This patient has not been admitted coming to a year now. Before she had this, she was being admitted about once every 2 to 3 weeks with heart failure. By the third or fourth admission, she gave up and just said, just put one in. Okay, I can't take this anymore.
It is about 80 to 90.
I think the more important, not more, even more important thing is that there are no notches and stuff.
Axis.
Overall looking very good.
Yeah, exactly. There are no notches. Amazingly, there isn't notches there at all. I couldn't believe it. You look at every single lead there. There wasn't any notches.
You could actually show this simultaneously with the baseline ECG.
Yeah, well, I can show you the baseline ECG then.
Yeah, it's full of notches there, okay? So, you know, this CS lead has actually helped the distal conduction system to be corrected.
So it can. It can. It really, it can. I got another patient which is a full right bundle, and how we did the maneuvers, and how we can explain that if you have time to go through it, but if not, we're good.
What about the axis and the ROAB23A wave? The axis is, you know, this area is negative.
Yes. It's actually a little bit more superior because when I did the left bundle, it was actually a little bit more inferior. I hit the left posterior fascicle.
I think we should go to the next topic.
Sure.
Yeah, all right.
Cool. Thank you very much.
You got a strong statement to make.
No. I was just responding to your comment about the better tools.
Yes.
So I completely agree with that. But some disadvantages, like for example, low R wave amplitude or late rise in threshold.
That I think is a part of.
Yeah, exactly.
Not having better tools.
No, that is because of the position of the his bundle, because it's higher up, and late rise in threshold is because of the fibrosis all around. So these things will always persist probably.
Actually, there are engineers who speak.
Definitely.
If you make a loop now, and then there's an electrode which you are at the his, but you are taking the more R way by having a longer electrode, you will pick up the ventricular signals.
But we definitely need better tools.
Yeah, that's true. And then I think. Yeah, so you can pick up more V. Thank you.
Thank you, sir. May I now invite Dr. Narayanan Nambodri, KK, Additional Professor, Department of Cardiology, Sri Chitra Tirunal Institute for Medical Science and Technology, Trivandrum, to deliver his talk on conduction system pacing in complex congenital heart disease. I also invite moderator Dr. John Roshan, Professor, Cardiac Electrophysiology and Pacing, CMC, Vellore.
You can sit down. Basically, you only can understand what he's talking. He's an expert. I told you, he's an expert pediatric electrophysiologist.
Good afternoon. Thanks, Dr. Ullas, for having invited me to deliver this talk here and making it pre-lunch. This topic is on conduction system pacing in complex congenital heart disease. In fact, I'm not a pediatric cardiac electrophysiologist, though I do pediatric, and it is more about right bundle pacing rather than left bundle pacing in complex congenital heart disease. And of course, it is not Stylet driven also. It's my disclaimers. In fact, there are more adults than children living with a congenital heart disease in advanced countries, developed countries like US. And as majority of early interventions in these structural abnormalities are non-curative, arrhythmias and heart failure complicate the natural history in many of them, especially those born with a complex congenital heart disease. If you see the whole spectrum of congenital heart disease, children with the transposition physiology, transposition of great arteries, or single ventricle physiology are at higher risk of developing progressive ventricular dysfunction with or without dysynchrony and heart failure. And the role of physiological pacing or CRT for these miscellaneous indications is being more and more recognized. In this context, we should know what are the limiting factors for physiological pacing in complex congenital heart disease or concerns. Of course, the most important one is anatomical concern because they have to begin with complex congenital heart disease. And selection of patients for evaluation of response to therapy. That is also important, how to evaluate them. And there is, of course, limited clinical evidence in them. If you see the anatomical concerns, there are visceral and cardiac malposition like situs inversus, AV discordance, abnormal systemic venous return, presence of LSVC, abnormal tributaries in drainage of the coronary sinus, impaired endocardial access to the systemic ventricle, and single ventricle physiology issues with the systemic anticoagulation that put them at high risk of thromboembolism. And again, to evaluate the concerns in the selection of patients in evaluation, the quantification of the mechanical dysynchrony, there is no consensus. There are unique forms of ventricular dysynchrony, especially patients with single ventricle, more likely to have right opposed to left bundle branch block. NYHA classification may not be clearly indicative of the underlying pathology. A systematic assessment of benefit from CRT is difficult. So always a word of caution, that is extrapolating the adult heart failure resynchronization or physiological pacing experience to young patients or adults with a congenital heart disease should be done with caution. We will see two scenarios. One is conduction system pacing in systemic RV, another one in tautology of Stylet. These are the two cases I would like to show. One is with a systemic right ventricle, two conditions. One is congenitally corrected TGA or LTGA. Another one is post-mustard or sending, which we'll have a look at the congenitally corrected TGA. The coronary sinus anatomy is quite abnormal in them. Though atria follows in patients with situs solitus, the anatomy of the CS is more or less normal, the location, but they can have abnormal tributaries, disconnected branches, osteolatresia, and we are resynchronized in the right ventricle, not the left ventricle, which is situated on the left side. It's morphological RV. And altered IVS anatomy and fluoroscopy as well, and associated anomalies. We can see one case. This is not the case of physiological pacing. Just to demonstrate the difficulties, a patient situs solitus with a dextrocardia, corrected TGA, epstenoid malformation of the left AV wall regurgitation, post mitral valve replacement, congenital complete heart block later on, and systemic ventricle dilated, mild paravalvular leak, moderate PAH. What is abnormality in that? Look at the coronary sinus source. It is not draining into right atrium. Rather, right atrial filling happens from above through an H connection so you can see that to an LSVC we have injected. So there is a coronary sinus atresia with a retrograde filling of the retrograde drainage of the coronary sinus. So RA is filling late through the brachiocephalic vein. So these are the problems we face when you deal with patients with a congenitally corrected TGA. And with any of these modalities, CRT, the responder rate could be as high as 75. Very few number of patients in each study. So it is not right to make a categorical comment. With this, we also had done more than 10 cases in the past, pacing as well as CRT, and we had a rather dismal outcome, to be frank. We finally decided to put the patient on 40 rates backup rather than worsening their ventricular function over a long term, which many other internationally famous electrophysiologists had also followed. Here, pediatric electrophysiologist, I mean. The case, this particular patient, a 52-year-old male, congenitally corrected TGA, intact intraventricular septum, no outflow tract obstruction, good biventricular function, moderate systemic AV valve regurgitation, not in heart failure, CHB with a narrow QRS escape, class 2. Had a apparently normal, you can see the congenitally corrected TGA with the left AV valve regurgitation. And this is the basal one, CHB, not so wide QRS. This is the ECG during the study. Some residual conduction is the second degree at that point. 124 milliseconds during CHB. AH of 376, HV 40. This is one thing we should always know. You can have two types of corrected TG. One is with a pulmonary trunk atresia, another is with a pulmonary trunk wedged between them. So if you have a wedged one, I mean, if you have, then there could be a significant malalignment between intraventricular septum and intra-atrial septum. And this necessitates the conduction system to move anteriorly. This is the normal one, and this with the pulmonary trunk. And you have to go anteriorly and go through the subinfundibular septum. You can anterior connecting node, anterior infundibular septum, and it has to descend down. So people have tried pacing at the his bundle. It's very difficult to locate in these patients, and also at the anterior AV bundle. These are the options available: dual chamber pacemaker, which is conventionally done, CRT, his bundle pacing, and the right bundle pacing as an option which we thought of. This was never described before that. And long-term implications of pacing in these patients, high attrition rate over a period of time. And chronic subpulmonary left ventricular pacing also is very well known. This, this has been tried, his bundle or a right bundle, left bundle pacing, that is on the right side of the septum. You can see the pace QRS duration is not significantly less, rather it has increased compared to the basal. So with the evolution and our experience with the left bundle pacing, as most of the audience in this crowd, we were also confident in doing left bundle pacing by that time. We thought of trying a transeptal right bundle pacing in that. This is from that study, post-procedure QRS is more. And we also use the help of 3D electroanatomical mapping to delineate the conduction system. This is the first of the three cases we did, and this mapping of with high density mapping on the left ventricle and left-sided ventricle first to delineate the septal vesicle, and this is the initial site of activation. And also we mapped the right-sided ventricle, and HD grid was used to map the potentials and all activation. And with the gating using EnSight, the lead was gated transeptally on the right side, which corresponds to the earliest activation, the vesicle on the left side. That is, the vesicle on the left side is right bundle. On the right side of the septum, we screwed it in transeptally in the conventional fashion. So this is the one going through. Already we have seen the selective versus non-selective parameters, non-selective right bundle pacing, and you can see the location. At site 2 selective, we had to attempt a couple of positions, and QRS unipolar 5 voltage some isoelectric line, not much, 122. And the QRS duration has come down to 108 milliseconds, 144 milliseconds, to 108 milliseconds. Quite good for a patient with a corrected TG and a conduction system. I mean, you'll never get this with the conventional, any sort of pacing. This is the QR pattern and multiple points. 1.7, and patient is doing extremely well. And this is the depiction by our Dr. Sai Kiran. And we got it published in, it got accepted in Europe this time. 3 cases, and all the 3 you can see significant reduction in the QRS duration. This is the first time in the, we have published it as a novel technique in right bundle pacing, physiological pacing, correct. So another patient, I'm not going into details, a clear case of TOF, 16-year-old, underwent ICR in 2007, doing fine, having recurrent episodes of dizziness. And this is from some southern part of Tamil Nadu, Marthana, very close to Trivandrum. Noted to have TOF, underwent pericardial monoscope transannular patch repair and VSD patch closure in 2007. Episodes of giddiness 4 times, not associated with chest pain, having complete heart block, good function, ventricular function, and again, standard pacing only. Standard left bundle pacing, step-by-step area. Step-by-step approach, LVAT and interpeak interval highly acceptable. And parameters absolutely fine. Position looks a little down, but patient has got a patch abnormal anatomy. This is the position. QRS is pretty fine. And the 3D, we also confirm the location with a CT scan in this case afterwards. So concluding my short talk, this take-home points. Conduction system pacing can be safely and effectively done in many complex congenital heart disease. You should not be afraid of doing this because anatomy, if you have clear idea about the anatomy, this can be easily attempted and successfully done. The approach should be individualized for every case with optimal use of additional imaging modalities. If optimal pacing could be achieved, the incremental impact on the long-term outcome of these patients is likely to be much better than those with a structurally normal heart. Thank you for the patient hearing. Thank you.
TGA, and we again did the same. This patient actually had ejection fraction of around 45%. QRS duration was around 150 milliseconds. And of course, we couldn't use 3D mapping for financial reasons. So what we did was we actually mapped with a quadripolar catheter and paced from various sites to see where we got the narrowest possible QRS. And then we did conduction system pacing into that site. And patient's QRS was 102 or 103 milliseconds, and after which patient's ejection fraction is also improved. So it was very heartening,
if
actually.
If you have a dextrocardia with mirror image appendages, the interventricular septum alignment will be more or less same. Yeah. So then it would be almost similar to like that. If
it was slightly, the site where we paced was slightly deeper on the, more posterior than anterior, actually.
Third case, we didn't use 3D. We were confident by that.
Yeah, nice. Very nice.
No, one second. Oh. You know what, you exchange the niceties and pleasantries, with each other, we appreciate. But you know what, it is so very intimidating. You do not do a conduction system pacing with the HD grid in the complex congenital heart disease to map the conduction system and Please, that was not the take-home message.
No, I didn't put it in the take-home message.
I absolutely understand your academic interest, etc. But then, you should have toned down that it was all not necessary. You could still do it.
Yeah.
It appeared to me that, this is how we do complex congenital heart diseases. That's number one. Number two, I was just thinking, among all the anatomical situations where conduction system pacing is the most ideal is this abnormal heart of CTGA. You have a left bundle sitting on the right side.
Left bundle, yeah.
Why do you drill? If you want to engage, there's a discrete stuff coming there. You don't do it on the right side because this just spreads on the endocardium, so you cannot just engage even if you're on the right bundle.
This actually, left bundle is right bundle only because of its right bundle location. These patients with a disconnected left bundle, there is something called a Mongeberg's ring.
That's okay.
So that may not actually, people have tried. This is actually the study. Even Vijayaraman had published that.
No,
but
okay.
That QRS duration is not.
But I think, if you go
and
to
I think many investigators might have used much more than HD grid to identify these things
but actually,
in the
if
past.
you dig into the...
Yeah,
we are talking about the CTGA. Okay. You see, if you dig into the literature, let's come to that point. If you dig into the literature, the anatomy of CTGA is good for the conduction system pacing without drilling.
No, people have done, but their results had not been this better, actually. That is what I have shown. So basically, that.
Yeah, you know what? Actually, if you're talking about the QRS width of 5 milliseconds, this is narrow. 10 milliseconds, it was wider. I do not think really that that amounts to which was better. But I think we should be looking at CTGA. CTGA, you do not have to. I think
I strongly disagree. Actually, on the right side of the septum, it is something similar to an RV pacing in a normal heart. You may not capture the left bundle like that. And anatomy is also totally different. It's just a subinfundibulary. His bundle itself is quite high, subinfundibular location. Yeah, and it descends down on the left side of the septum.
I have not done, but I have gone through the literature.
Yeah,
okay, it's not marriage, it's all right.
Yeah, correct. That is why actually I put this slide.
But anyway, thank you so very much. And, it actually encourages to read more. And I think the data is, when the data in the normal heart itself is not so much, I think there's a lot to learn in the complex congenital heart diseases. Yeah.
Please have a look.
Narayan, with such complexity of the AV conduction system, are you likely to be doing a deep septal pacing most of the time in congenital heart, or will you always aim for a conduction system capture? If the deep septal pacing gives you enough of a QRS narrowing,
I think
many times you might have to accept that kind of an endpoint.
Anything narrow is good, probably. If you get a good conduction system capture in these complex cases, it is an additional bonus. I think we have to be very humble when you approach these cases. A good sustained outcome, clinical outcome we should aim for. Thank you. Oh, no, nothing. Uncorrected,
Thank you, sir. Now I call upon Dr. Ajit.
Sir, I have similar case 2 days back. Same 32-year-old girl with similar normal anatomy, CCTGA with intact CVS, intact interventricular septum, type 1 Mobitz block. She's got a moderate MR. Okay, so going by your talk, if I'm going to paste the right bundle which is lying on the LV side, if it is a right bundle, it's going to be slightly superficial, isn't it, sir? Same like what is there, what is going to be there on the RV side if it's a right bundle. So I'm going to go transeptally, get into the superficial part of the right bundle. That's what you're saying.
Yeah, that is a problem. The ramification of the right bundle may not be as in left bundle, like left anterior fascicle and posterior fascicle, and it may not be as dense on the left side of the septum like a conventional left bundle. That is a catch. That is a really a academic problem that we may encounter. That is why actually we mapped the ramification to begin with, because we assume that left bundle right bundle when it lies on the left side of the septum is similar to left bundle, which is actually not true. If you see that 3D mapping, we have found out the initial activation is not on the left side of the septum like a posterior vesicle. It was on the right-sided ventricle superior portion, like anterior vesicle, equivalent to left anterior vesicle. This is a new information for us also. We actually were working on that, whether to say that. But maybe Mobitz type 1 without significant in a corrected TGA, unless symptomatic, may not require a pacemaker also at this stage.
Now I call upon Dr. Ajit Tachal, Consultant Cardiac Electrophysiologist, Lissi Hospital, Ernakulam, to present the techniques of performing conduction system pacing with Stylet-driven leads. And also welcome the moderators, Dr. Richard H. Hongo, Cardiac Electrophysiologist, San Francisco, and Ashish Nabba, Senior Consultant Cardiologist, Jupiter Hospital, Thane.
Thank you, Dr. Ullas. Great to be here, as always, both for the conference and also for the hospitality. So I will be talking about how I go about doing conduction system pacing with Stylet-driven leads. The relevance is because, partly because I have not been able to lay my hands on the Hispro or the Boston system. So I've done about equal numbers with the lumenless system as well as the Selectra system. And just to put it in perspective, I'm still not totally convinced about the superiority of conduction system pacing in totally normal hearts, in normal ejection fraction with structurally normal hearts. I know it gets a little narrower QRS than a very good deep septal, mid-septal pacing, but I'm not totally convinced about the long-term superiority, which means that almost all my cases have been in dilated hearts with ventricular dysfunction or abnormal hearts. We need to extrapolate that because my choice of hardware in that may not exactly be the same choice of hardware if the heart rate be totally normal. Having said that, I've done it in about a handful, maybe 10 or 15 normal hearts, and I've not found any difference in the way the hardware is handled. So I just want to put that perspective there before I get into the talk. The second perspective I want to put in here is that I have not found any difference between the lumenless lead or the Stylet-driven lead in outcomes in patients with ventricular dysfunction, either with clinical outcomes or with relation to complications at more than a year of follow-up. So having said that, let me go to my talk. So I'll put it in 5 steps. First is knowing the tools. Second is deciding where to pace. And 3 is which tools to pace which particular region. Nowadays, with the tools we have available, we can access most regions, the procedure itself, and there's still scope for improvement. And like I told, first I'll be exclusively talking about the biotronic system. We have had an excellent discussion and demonstration on how the Hispro works. So this is the other system that we have. Of course, we have the Boston system also now, but there's hardly any experience on that in India yet. So it comes in 3 sheets. Now, out of the 3 sheets, the 32 or the 39 or the 42 refers to the length. And in Indian population, I think virtually every operator, including me, has used the 39 centimeter length. It seems fine. If you want in comparison, the C315 is 43 centimeters in length. This is just to get a comparison because most people are familiar with the C315. But there's a small difference between these. First, the similarities. The 3955 is virtually an exact mirror image of the C315 if you look at the distal shape. The others, you can see the curve. The 40 or the 65 or the 55 refers to the diameter of the circle if the tip were to be a circle. And the other refers to the length. But how this is different from the lumenless lead is how it behaves when we put the stylet in. Once we put the stylet and the sheath in, the stylet and the sheath being stiffer in nature compared to the 3830, it straightens out the sheath a little bit. It's the same sheath, the C315 and 3955 with the 3830 inside and the stylet and the sheath inside. It straightens out a little bit with the end effect that this is going to reach a little more inferiorly compared to the lumenless lead. and the sheath. So we need to keep that in mind. So that's about the sheath. The second is, like all leads, we need to know what are the fluoroscopically visible markings on the leads. So these are the fluoroscopically visible markings on the solear lead. So there's the helix. So the typical septum would be 10 millimeters, which means that this is going to be the hinge point, which is what all the discussion was about in the morning, because this part does not have any metal on it. So here's the ring, which is stiff. This much part is stiff. There is one small part here, which is 1.5 millimeters, which is not the stiffest part, which is the part where the hinge would form if you were to get it exactly the 10 millimeters inside in an exactly horizontal direction. Now, one report has been there on a fracture occurring on that part. I have not found any, I have not had any in my experience, but that's something that maybe we might want to think about. But this is how the lead looks on fluoroscopy. Now, the third tool that we have not talked about is the stylet that we have in our hands. Like we discussed in the morning, we are all familiar with shaping the stylet to reach wherever we want to reach. And this is one advantage of this system, I feel. A stylet which can shape the lead, and the sheath which can take the shape of the stylet. It's not too stiff that it cannot take the shape of the stylet. So I typically use a curved stylet. Now, nowadays, I initially started with this type of a curve. Now I don't put this much of a secondary curve, because later on I figured out that if I put this amount of a secondary curve, when the stylet is pulled back, it derotates the lead a little bit, and it makes it prone for a slight amount of, well, I wouldn't say micro dislodgement. It doesn't come back as much as turn the orientation. From a horizontal orientation, it might become oblique, and you might just lose capture of the exact spot that you want to capture. So nowadays, I reduce that curve to something like a 45-degree curve rather than use this nearly 90-degree curve. But this is what I wanted to highlight. You put that compound curve stylet in the 3955, and you put the lead and this curved stylet in, it mirrors the C315. So if you want it to look exactly like the C315, which I know most of us are familiar with, you want to do this with this stylet. And finally, how do you shape the stylet? It depends on the heart. It's just like how Dr. Tanbun was asked in the morning, how do you shape the stylet? You know how to shape the stylet. We've all been doing pacing. We know how to shape the stylet. We know how to reach which part of the heart. So it really depends. And the only thing I want to say here is that if you want to reach somewhere near the his bundle area, I really wouldn't give much of a primary curve. I would still go a little bit of a secondary curve to direct it septally. It definitely makes the procedure easier. So what is the target? The his is still the boss. I don't think there's any doubt about this. If you want to pace the heart, I think the best part is the his. It's just that we are not yet there technologically to guarantee long-term outcomes. But this is my perspective. If our outcome is QRS narrowing, a very proximal, deep septal pacing seems to get the exact same QRS narrowing as you would get a very proximal left bundle pacing. So I no longer try really hard to get a left bundle pacing, but I try really, really hard to get a very proximal pacing and very deep, as close to the his as possible, but in the septum, and it seems to work out as well if QRS narrowing is the outcome. Except, and gives the same lead parameter, stability, and EF preservation as doing a left bundle pacing, except in the absence of LBBB, that is. If a patient has a left bundle branch block, of course, it stands to reason that you have to capture the left bundle. But in the absence of a left bundle branch block, I think at least QRS duration-wise, they're all the same. So here's an example of a patient with hypertrophic cardiomyopathy with complete heart block. We all know what you would get if you pace a myocardium. You get a horrible-looking QRS if you pace a myocardium in HCM. So this is, of course, a proximal left bundle capture. Lead 2 is positive. Now here is an anterior fascicular capture. This is a patient with rheumatic heart disease, mitral valve replaced, moderate LV dysfunction, atrial fibrillation with complete heart block. We all know what we are going to get if you do either conventional CRT or RV pacing in this case. But this is pacing near the anterior fascicle. It's QR in V1, and the rest of it looks like an anterior fascicular pacing. The deep S waves in V5 and V6, and the axis towards lead 3. So here's another patient reasonably similar. I'm putting the sinus as well as the pace morphology so that you can compare. Rheumatic heart disease, post-mitral valve replacement with mild LV dysfunction, ablated in LA flutter, some other flutter from the right atrium recurred, multiple flutters recurred. I didn't want to really go about ablating again and again. She was off medical therapy because of sinus bradycardia. So this time I told her, okay, let's put in a pacemaker. Anyway, you're having a sinus bradycardia, you're about the age for pacing, and then let's give drugs and see what happens to your multiple atrial arrhythmias. So this was the atrial pace QRS morphology, and this is the ventricular pace QRS morphology. So this is once again somewhere near the left anterior fascicular area. You can make out by the change in the QRS morphology between this and this. Just look at the axis and the S waves that have developed in lead 1. So it's not really hit, or just about hit the left anterior fascicle. You can see there's a tiny hint of an R in V1, but I really no longer try to hit the fascicle or hit the left bundle, because if the target is going to be QRS narrowing, it looks like just getting deep into the septum is fine. So this is another patient, post-TAVR, CHB, mild LV dysfunction. Agreed, most likely the LV dysfunction would disappear because a TAVR has been done. But when I wanted to pace, I wanted to get a narrow QRS, and well, I was not trying for this. I originally intended to get a left bundle pacing, but once I got this, I stopped here. This is very obviously a deep septal capture from the, it's deep septal because the lead, I put the lead deep septal, but it's obviously an RVOT capture. And this is a patient without absolutely no escape rhythm. So this is a completely paced rhythm. So having seen all this, I'm not really convinced that you really need a left bundle capture in the absence of LBBB if the endpoint is going to be QRS narrowing, and I no longer try for that. However, in the presence of a typical left bundle branch block, there is nothing like left bundle branch capture. So here is a typical LVBB, a patient who got a dual chamber pacemaker, cost issues and no downsides to it. Typical left bundle branch block, severe LV dysfunction, left bundle pacing, fused appropriately with the native right bundle conduction using the appropriate AV delay. So that's how I decide where to pace. Now, second is tailoring the tools to target the, to meet the targets. I use the 39 centimeter length in all patients, whether it's for his bundle pacing or the left bundle branch area pacing. For left bundle branch area pacing, in some patients, I might choose the 3955, the bigger curve. The advantage of these sheets is that these sheets can be held very stably by the operator or himself with a single hand. You can just hold the sheath with your left hand. So this is a significant advantage over the lumenless system, where we often need two hands to turn the lead, and you have to give the sheath over to the assistant to hold. And then it really depends on if you have the same assistant every time, which may not be the case every time. So here you can just hold the sheath with your, I'll show that. You can hold the sheath with your left hand and turn the lead with your right hand, which means that you never lose control over the sheath. The important thing that we need to understand here is that 3940 reaches proximally, and the 3955 left to itself reaches near the left posterior fascicle rather than the proximal left bundle, especially if the stylet is not shaped and has been lifted up a little bit to reach anterosuperiorly. So this is a video of that. This is how it looks. So here's a patient with tricuspid regurgitation. This is an ischemic cardiomyopathy. Entire septum is infarcted, EF of 20%, biventricular dysfunction, severe TR, moderate PH, on the road to a transplant, cardiorenal syndrome, his creatinine is 3.7, cardioverted atrial fibrillation with heart failure, NYHA 4. He has a right bundle branch block with a incomplete left bundle branch block. I'll show you the ECGs later. Now I'm showing the left panel is how difficult it was to find the his. You can, because of the tricuspid regurgitation. This is what the tricuspid regurgitation was doing to the lead. It's just to give you an idea of the magnitude of the TR, but this is how the 3940 crosses. Now, what I want to highlight here is that since this 3940 crosses the anterosuperior corner of the tricuspid annulus, it virtually takes the right ventricular dilatation and the tricuspid regurgitation out of the picture, which is a big problem when you're trying, if you were to use the lumenless lead and sheath in this situation. Those of you who have tried it will know it will dance all over the place. It's very difficult to keep it stable on the his bundle location in the presence of this amount of tricuspid regurgitation and pulmonary artery hypertension. Whereas if you used any of these stylet-driven leads, going to the His bundle and staying on the His bundle is easy regardless of the right ventricular size or shape or tricuspid regurgitation, which is a big advantage, which has made me go back to His bundle pacing a little bit after struggled with His bundle pacing with the lumenless system in structurally abnormal hearts, especially with RV dilatation. So here's the His bundle from the lead, distal His bundle pre-deployment, and this is the His bundle post-deployment. Now I started pacing. There's a selective His bundle capture and there's no correction. I have not corrected anything. The ECG looks exactly the way it looked. But once I paced a little higher, I've corrected the right bundle branch block. This probably is by capture of the basal biocardium because the HV interval now is shorter. It's become much shorter than the native HV interval, which was 67 milliseconds. But the point is, I have corrected the right bundle branch block without correcting the left bundle branch block. It also suggests that we have probably captured the basal myocardium and that the right bundle branch block was probably a parietal issue. So we went on to put the CS lead, and we had the hot CRTD. And the QRS came down from 148 to 146 milliseconds, once again without any notches, which I think is a fantastic achievement for considering what we started with. And of course, there's the proof of the pudding. We had this proof on table. This is during checking, pacing off. So that's the blood pressure. It speaks for itself. And then pacing back on again. And the final proof of the pudding is in eating it. I did it just 3 days back. So his creatinine has come down from 3 to 2.5 to 1.8 in a space of 48 hours. His sodium has come up to normal. I have put the urine output with diuretic before the implant, without diuretic after the implant, and the hourly urine output without the diuretic. Now, of course, I can't tell you the long-term outcome because I just did this 2 days back. This is just to say that now, with the right tools, we still shouldn't abandon the His bundle. Now, about the difference between 3940 and 3955. The 3940, if you want to reach the left bundle area, you would cross like this, and it would just simply reach the left bundle area. The only difference is you stop the hand movement a little later. If it's a His bundle area, you stop it as soon as you cross the annulus, and you try to cross just above where the His catheter would be. If you want the left bundle area, you try to cross just below where the His bundle would be, and let it go just a little midboard distally. Whereas if you were to use the 3955, this would behave more like how the C315 would behave. It would cross a little more posteriorly. The His catheter, unfortunately, is jumped into the right atrium during this. But at the moment it crosses, I'm sure all of you will be able to make out that this is going to cross a little more posteriorly. There, it's crossed a little more posteriorly, and then we need to lift it up. So that's the only technical difference between the 3955 and 3940. But this is one step, and this is 2 steps. So it finally will lift it up, and that too reaches the left bundle area. But I far prefer this, because it's much simpler. It just reaches the left bundle area straight away. Now, tailoring the hardware for the procedure. For His bundle pacing, it's always a 3940. For left bundle pacing, also it's always a 3940, except in one particular situation which I'll come to later. Okay. Now, since I want to prefer as proximally, I'm moving a little bit more towards focusing on proximal pacing than bundle pacing, because the QRS doesn't seem to be any different at all. So because of that, I am tending to move towards the 3940 rather than the 3955. So this is the one situation where I find we have to be careful if you try to get the proximal sheath, because if we use the 3940 and we go to the left bundle area, and then if you're not really careful in a patient with complete wide left bundle branch block and a long PR interval, this being a stiff sheath, if you're not very careful, you could go a little bit more forward and hit the right bundle and can have a temporary flat line. This does happen with the C315 also, the lumenless sheath, but if it does happen, it will recover in a matter of few seconds. But I've had cases where this has happened with the 3940, and it's not recovered for quite a while. It's probably recovered only the next day. And since we don't want that, in some of those cases, you might want to take the 3955 and take the approach of lifting it up. But as of now, I prefer to use the 3940 in all the cases. So this is how, okay, I can skip that. It's a repeat of the previous video. So this, like I said, it's a huge advantage. So here's a patient with post-MVR and post-tricuspid repair and MVR, and it just crosses right there. One challenge is this, like I told, you might hit the right bundle in a patient with, like in today morning's procedure also, you can see that that procedure involves going down and posteriorly and then lifting it up. This is a very safe way to go about the procedure in patients who have left bundle branch block and a longish PR. So to achieve the same with this sheath, what I prefer to do is this. Take the wire deep into the RV apex and then put the sheath on top of the wire so that you are guaranteed that the sheath will not suddenly go up and hit the right bundle. And then you can gradually lift the sheath up. So the procedure itself, the helix may be exposed or retracted. I have not really found an issue with that, going with the helix exposed or retracted. I actually prefer to go in with the helix exposed because in the right anterior oblique view, very often you cannot really see the entire helix. So I just want to make sure that it's really exposed. Of course, I have not really found an issue with that. So I just go in with the helix exposed, but I'm okay whichever way it goes in. But what I do is I go up to the tricuspid annulus with the straight stylet. So the lead is going in and the helix is exposed. You can see that once it goes to the tip of the sheath, you cannot see the helix anymore. So you can't make out whether it's exposed or not. So that's why I exposed it early on. And then I exchange the stylet for the curved stylet. So, and then I seek the septum. So that's one thing that I do. I exchange the stylet before going in. It's introduced using the introducer tool. So there's a sheath. And once I put the introducer tool and the lead in, then I remove the introducer tool because that stylet guide at the tip of the lead, that green thing, it keeps it steady there. Once you give the rotations, it keeps the rotation steady there. So there's the stylet guide that we are talking about, this green thing at the tip of the lead. And the next step is to exchange the straight stylet for a curved stylet. I forgot to exchange it. Yeah. And before that, turn the stylet guide. Now, turning the stylet guide makes the lead stiff and keeps a torque there. And here is one advantage. I push the stylet in up to the tip, and you can just connect the cable, pacing cable to the stylet, which gives the advantage of pacing continuously during lead deployment. So here is what I was talking about. We can use our own two hands. So the left hand is holding the sheath. Of note, these two fingers hold the sheath in the counterclockwise location, abutting against the septum. This between the thumb and the index finger, after every rotation given by the right hand, you just hold it there. So this green stylet guide here, plus the thumb and the index finger holding the rotation there, I'll play that again, will ensure that every rotation is kept there. So every time you rotate, while rotating, just release the thumb and the index finger, and after rotating, just clamp down on it. That plus this stylet guide will ensure that every rotation stays there without backing out. And this is the biggest advantage. This is my fellow deploying a lead. Starts with a W in V1. The notch shifts distally. A small R starts appearing in V1. And now we have a QR in V1. This has taken 10 seconds to deploy. And the big advantage of this is you don't have to disconnect anything or connect anything or look for potentials. You just go from one end to the other, and the moment you see that QR in V1 and you see that you have a slight positivity in lead 2, that of course you can see even before you start deploying, you stop deploying. So that makes the procedure fairly simple, that being able to pace through the stylet and you just see the morphology and stop, that's it. So this has taken 10 seconds. This is the entire tracing of what I just played. So from this W in V1 to this QR in V1 has taken a total duration of 10 seconds. So that's the W pattern, and then the notch moves forward, and then you have a small r in V1, not enough. Go just a bit more, you have the QR in V1 and a small r in lead 2. This, like I told, is a patient with, I didn't tell this patient. This patient is a patient with primary tricuspidal disease, massive right ventricle, massive right atrium, permanent atrial fibrillation, gross right heart failure with post-tricuspidal replacement, bioprosthetic valve replacement, and after that has developed a complete heart block. She was on epicardial pacing at the time of doing this. So to get this outcome in that sort of a patient with just one single turn of the lead taking 10 seconds, I think is quite good. And it's the hardware that helps us do it. So that's the final QRS on this patient and the LVAT. So the second point what I want to make is the direction of the lead. Penetration into the septum is easy. And 2, we can rely on the marker distances. Unless a lead penetrates horizontally, we cannot really rely on the distances between the markers. Because you might measure the septum to be 10 mm, but if it's going to penetrate obliquely, we really can't rely on that. It's just going to be guesswork. That's where that continuous spacing comes in. You cannot keep on pushing the lead till you get a QR. A slightly oblique deployment is also okay. In fact, I prefer a slightly oblique deployment because I don't want that 1.5 millimeter to be the hinge point. So I'm not sure if it's a theoretical worry or a real worry, but I don't like that 1.5 millimeter in between to be a hinge point. So once you deploy it slightly obliquely, the hinge point comes so that it's beyond the ring electrode and we are all safe. So if you're really worried about that, you can take the 3955 and deploy it far more obliquely. You'll finally reach the left bundle and the ring electrode will be inside the septum. So that way you've taken care of that particular concern, but I don't prefer this. I'd still prefer the 3940 to reach proximally, because like I told, it just seems that proximal pacing may be as good as left bundle capture, who had this ECG. So this ECG is basically you're going obliquely and we are going towards the left ventricle and we are climbing up and reaching the anterior vesicle. You could do the same thing and get the deep RVOT septum. It's just that it doesn't really go that far deep in and that far towards the left side. But just need to pay attention whether you're going obliquely or going horizontally. So here's the same patient. Now you can see that this lead is burrowed parallel to the septum and it's on the RV side rather than on the LV side. We ended up with deep RVOT septal pacing. We still had a narrow QRS, so I'm not really sure whether it really matters. So here's another thing which we need to be cognizant about. This is the cardioverted him on table during the implant. The moment he touched him, he went to VT. And I think it was, his EF was normal, but it was fairly obvious that he's going to become pacing dependent pretty soon. So we opted to put a dual chamber ICD with a left bundle lead for pace sense. Now, here's the thing. This anatomy is so altered. Here's the standard LAO30. Now, I want this lead to get in 17 millimeters. So what's happening here? Has the screw, the helix come in, or it's something else? No. When you do not see the helix in an altered anatomy, the next thing to do is to profile the septum and use a caudal view. So same position, this is LAO60, caudal 45. The lead is very much in. It's in about 15 to 16 millimeters. So if you were to just go by that LAO30 view, you would feel that something is wrong. but once you go to the appropriate view, use it. So when you work in a dilated heart or a distorted heart, don't just rely on the LAO 30 and the RAO 25. You'll just try to figure out which view to use. Now the next part. Once I get the lead in, we still need to slit it out. Now, slitting is hardly an issue with the C315 and the 3830. You just slit it out. But here some additional maneuvers are required. The two questions are, do you remove the stylet first, or do you pull the sheath back and keep the lead there first? I always prefer to remove the stylet first. But while I remove the stylet, especially because I give that septal curve on the stylet, and I'm cognizant of the fact that pulling that septal curve back might derotate the lead, I always keep a slight forward force on the sheath and the lead while removing the stylet. So it may be wrong to give it slight forward. That's a decent amount of forward force. So I can see that I'm keeping the sheath and the lead pushed against the septum. I'm not really pushing it forward, but I'm giving it a forward push while removing the stylet. That's very important, otherwise it just might derotate and come out. And then we give a slack on the lead while pulling out the stylet. And slit the stylet, slit the sheath only once it reaches the right atria. Simultaneously feed a slack on the lead and let the lead rest at the floor of the right atrium, so that there is no further pull on the lead. There are three things to avoid in what I figured out. The first thing to avoid is a fibrous septum. The second thing we already discussed today morning, Dr. Boone's talk. If helix is retracting but lead is not moving, which means that the lead is stuck there, but the helix seems to be retracting. Now this, to my mind, can only happen only if the tip has just got there. Unless the tip is just got there, I can't see how the housing could turn on top of the lead so stably. So the moment I see that the helix is beginning to retract, I think it is a good sign, because the tip has caught onto something. Then at that moment, stop rotating the lead and then just simply deploy the helix again with the lead screw. And I've used this very effectively, and such deployment has always been stable, but one needs to be cognizant of that. And we must stop if the lead is buckling. At some point, if the lead is buckling, if you continue at that, there will be trouble, because all three are markers of this. The fibrous septum, or failing to recognize that a helix is coming back, or failing to recognize that a lead tip is buckling, can lead to this. Now, it's a good thing, because this has never happened to me after the first 10 cases, because we realized this. And this has happened in an equal number of cases, whether it was a lumenless lead or a stylet-driven lead. So I don't think it's anything to do with the lead. It's something to do with what we are not realizing during the procedure. So fibrous septum, I think we are not yet there with a lead which can really penetrate this well. In fact, I'm not sure it's a good idea to penetrate a fibrous septum or pace from a fibrous septum, because you want to induce ventricular tachycardia, you pace from the area of fibrosis or close to the area of fibrosis. I could guess that a similar effect could happen if you could get a lead in there. But I think none of the current tools are good enough to get into a fibrous septum. What we need to be cognizant about is this. The fibrosis may not be a transmural fibrosis, so every conduction system pacing that we do in an abnormal heart, I think we should look at the echo ourselves to ensure that there is no thin subendocardial fibrosis on the left ventricular side. We had a small discussion on this on the morning also. The tough parts are both the endocardium, the right side as well as the left side. And if it's going to be like this, we may or may not be able to get the desired result with attempting a left bundle pacing. You might straight away try to go obliquely up the basal septum. So rule number 2 is direction of penetration as perpendicular to the IVS as possible. It just makes penetration much easier. And rule number 3, I already mentioned, stop rotation immediately if lead begins to buckle, especially if there's an oblique penetration where I feel the force transmission is less compared to a horizontal one. So if you start seeing this, stop immediately. There you go. You can see that the lead tip is no longer progressing forward. It's trying to move left and right. It's no longer oriented. If it happens, just stop, realign the whole thing, and then restart it. I think if you're cognizant of these things, we can take care of the helix distortion issue. A fibroseptum, I mentioned, it may not be a good idea to penetrate it. Another big scope for improvement, which I'd love all the companies to address, is this. We are all still doing this inside the EP lab. At some point, this technique, all these techniques have to go outside the EP lab. Now, when it goes outside the EP lab, one of the fallacies we have is a programmer to get a proper potential, a his bundle potential or a left bundle potential. So this is the same lead, in the same location. I've connected to the Biotronic Dynamic programmer, which filters at 15 to 80 hertz, the Medtronic 2290, which gives virtually an unfiltered electrogram from 0.5 to 250 hertz. And we all know that the potential that we are looking at is going to be at the higher end of the frequency. And I've connected the same lead to an EP system, and I've tried to mimic this, and I more or less mimic this with the end result of not seeing a hiss. But once I filtered at 30 to 300 hertz, we know that the hiss is there. So it's just that we do not have programmers with configurable filter settings. If you could have programmers with a configurable filter settings, it could easily solve this problem. And it would be great if you could just see the V1 ECG and the PSA. Now, of course, nowadays most of the cath labs also do have a 12-lead ECG or a V1 ECG. But if these few tiny improvements, if it could be made to the programmer, could make our job much easier and could go a long way and take this technology out to the EP lab. So some of the things I've learned is that the stylet-driven leads offer choices of shapes, sheath shapes, and advantage of stylet shaping to reach the desired proximal locations in dilated and distorted hearts. Fluoroscopically visible multiple markings on the lead tip help to tailor the extent of septal penetration, especially in hypertrophic cardiomyopathy or thick septa, where you want to penetrate to a particular number, which is not the case with the 3830. You have only 2 markers. The stylet gives excellent stability while slitting and can virtually direct the lead anywhere by altering the sheath and the stylet curve. Too acute a secondary curve on the stylet predisposes to dislodgement during stylet removal, and a different filtering setting on the programming would be appreciated. Thank you. Too hypoglycemic to talk.
You know what, I have a few observations because I think we have done nearly 50 of biotronic devices. A few things which we do and few things which I think we do not do. Stylets, shaping stylets, had never been kind of a requirement for us. And we really think, as Tan was telling, putting the stylet, into, especially making a shape and then, drilling, I thought it rather, imposes some more resistance, I was thinking. Second, I was not sure whether when you prepared the lead outside, you gave an extra turn on the pin.
I did.
And then you fixed that tool onto the ring, right?
Yes.
Okay. So where was that time where you actually again tried to give extra turns?
No, I didn't.
I actually read you gave some more
No.
turns in the helix.
What I said was that I didn't give the extra turns on the lead outside. Or I'll tell the exact sequence. So the helix is exposed outside, and the lead is introduced into the sheath with the helix exposed without giving the extra turns. Then the stylet is exchanged for my preferred curve of stylet, and then the lead is stiffened by giving the turns, and then the stylet guide is fixed. That's all done inside the sheath. But I don't exchange the stylet after stiffening the lead. It doesn't make sense.
Yeah. So I'm not sure, if you go by what they recommend was to give that extra.
Yes, that's what they recommend. But what I figured out is that if I did that and then I took the stylet out, all the torque just went off.
No, it remains, right? Because your fixing tool is there.
It doesn't remain.
Okay, fair.
I tried that. It doesn't remain. That's why I did this.
I think
That's why I changed to this.
no,
I started the way they started recommending.
Not only the tools are evolving, our practice is also evolving.
Yes. 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 Absolutely. It's just that just getting the basic ideas right, and finally each operator is going to have his preferred technique. It's just like deploying the posterolateral vein lead. Finally, each operator has his own preferred way of delivering the lead. It's just to be aware of the different ways of which we can go about it.
Yeah, so you know what? I'm sure he is exclusively Agilis his program. But I just was thinking, do you have any comments to make about this system?
Yeah, just wondering. You pre-tensile the lead outside the body, and then you put it in, but you don't remove the stylet back. I find that quite an interesting statement, because sooner or later you're gonna have to pull the stylet out to fix the lead, right?
No, I don't pull the stylet out to fix the lead.
I mean, sooner or later when you've deployed it and you need to connect the lead into your pulse generator.
I don't need to. That's at that point, yes.
Yeah. So what I'm trying to get at is that once you deploy it and you actually drill through already and you actually pre-tensile everything, if you pull the stylet back at that point in time, how does the lead tip behave? Does it counter itself? Does it lose that pre-tension, and will that helix retract at that point in time?
It doesn't retract at that point, provided I keep the sheath and lead pushed forward with the left hand. Before I started doing that, it used to. So I showed one video where I was pulling the stylet with the right hand. At the same time, simultaneously, I'm giving a slight forward push on the sheath and the lead. Before I started doing that, it used to derotate at that time.
I see. So you keep it forward and pull the stylet back first, so you maintain that torque.
Yes.
And
Yes.
I see. Okay, thank you.
All right. So if there are no more questions, lunch could be served. Huh? No questions for the lunch?
The only question is, when is lunch?
Yeah, see, we're all waiting for your lecture to be finished. So great job. So I think you are at the right time.
Thank you for sharing your knowledge with us, sir. Let us break for lunch, which is arranged on right side of the auditorium. Let us assemble back together for upcoming sessions.
நீங்கள் வாங்க. இப்போ இந்த ப்ரெசன்டேஷனில்
இது டிசைனில்
பொண்ணுல அது மறந்துட்டேன். டிசைனில் போயிட்டு
இது ஒரு ஸ்லைட் சைஸ்.
ஸ்லைட் சைஸில் போயிட்டு
வைடு.
ஓகேண்ணா. அது இவர் கொடுத்தாரு தமிழ் எடுத்து வந்து, சரி நீங்கள் அந்த டைமில் நான் வாங்கி வச்சுட்டேன். ரெக்கார்டட் வீடியோவா? இந்த ரெக்கார்டட் வீடியோ போட்டுதான். ஆமாம், அது என்னென்ன டைமில் எப்படி ப்ளே பண்ணணும்னா அவர் இருப்பாராம். காப்பியா ஸ்பாட்டா?
ஒரு
ரெக்கார்டட் வீடியோ இங்கே வேறு இருக்கு. மைக்கை இது இங்கே போடியம் இருக்கனால இவங்க சரியாக பேச மாட்டாங்கன்னு நினைக்கிறேன்ல.
check, test, check, check.
Let's get back to our presentation. Here we have Dr. Ashish Nabha, consultant cardiologist, Jupiter Hospital, Thane, to speak on left bundle branch pacing, optimized implantable cardioverter defibrillator. And the moderator of this presentation is Dr. Deepak Batmanabhan, senior consultant cardiac electrophysiologist, Manipal.
The thing is not working, huh?
More display settings, more display settings.
We should have set this. Last time we have done immediately.
No, two, one second. நம்ம லேப்டாப்ல போட்டுருங்க. உங்க லேப்டாப்ல இந்த பிடிஎஃப் ரெஸ்ட் கொடுக்கலாமா?
What do you want to do? Close. Yeah. It has those videos, no, some of them, that's why. No, if it is not on this laptop, then the supporting thing is not there.
So 10 seconds, 10 to 15 seconds, sir.
10 to 15 seconds.
இதுவே முதல்ல முடியும் ஏன்பா கிட்ட வரீங்க அங்கே ப்ராப்ளம் இருக்காது ரெண்டுத்துக்கே வராது நீங்கள் வெயிட் பண்ணி அவுட் ஆன ப்ராப்ளம் தான் அந்த லேப்டாப்பில் இருக்கும்போது கரெக்டாக இருக்கு இது மேக்ஸி என் தம்பிக்கிட்ட இருக்கான் தம்பிக்கிட்ட லேப்டாப்பில் மாற்றணும் இது சப்போர்ட்டிங் ஃபைலோட மாற்ற சொல்லுங்கள் இது கூட அது கனெக்ட் ஆங்க அதுதான் ஆர்டிஸ்ட் சொல்லணும் இது வந்துடுச்சு ஸோ காப்பி த ஃபைல் அவுட் இஸ் நாட் கமிங்
No.
அவுட் இஸ் நாட் கமிங்
Oh, output not coming. Last time I did 2 months back on this. It was working. Ah. Yeah, but then these things will not play. You can copy.
copy in pen drive.
This one.
Yeah.
You want to copy?
Yeah. You have to copy. The file is there in this, huh?
No, no. I will take from you. The thing will not play.
This file, huh?
Yeah.
வீடியோ சப்போர்ட்டிங் ஃபைல் இருந்தால் தானே அது ப்ளே ஆகும் பென் ட்ரைவில் இருந்தால் போதும்ல பென் ட்ரைவ் ரெண்டு டீ காட்டுது அது ஒன்று தானா
It will play, the movie will play.
வீடியோ செக் ப்ளே ஆகுதா செக் பண்ணிட்டு போடுங்க ப்ளே ஆகுதா பென் ட்ரைவ்ல போட்டு செக் பண்ணுங்க பென் ட்ரைவ்ல ஆன் பண்ணுங்க அந்த ஃபைலை ப்ளே ஆகுதான் செக் பண்ணுங்க வீடியோ வாங்க கீழே வாங்க கீழே வாங்க இல்லை வீடியோ அது அதே இல்லை அதை ப்ரெஸ் பண்ண முடியாது
Yeah.
அதை ப்ரெஸ் பண்ணுங்க ஸ்லைட் ஷோ செக் பண்ணுங்க பேக் போங்க ப்ளே ஆகல ப்ளே ஆகல இந்த வீடியோ இந்த லேப்டாப் எடுத்துருக்கோம் இந்த லேப்டாப் எடுத்துருக்கோம் அப்படி வராது இதுலேயே வரணும் இதுலேயே வரணும் இதுலேயே வரணும் HDMI cable மட்டும் பார்த்து வெண்ட் ஆகுதுண்ணே, அது ஷார்ட் ஆயிடுச்சுன்னா தொல்லைண்ணே, அது கொஞ்சம் நேரம் எடுத்துப்பா. இந்த கேப்பில் போட்டு கரெக்டாக வைங்க, நெட்டு தேவையில்லை இப்போ.
Sorry for this, we probably could have done it in the lunch time, but any case, we are started. Thanks to the guys. So Ullas asked me to speak on lot ICD, and I had done one such case, and I really got in touch with people to find out who had done this. Even the name is very specific. Our own Shanmukh Sundaram has coined this term of lot ICD, which probably means that the patient primarily needs ICD therapy, and you think that cardiac resynchronization is in addition useful to him. So which patients deserve a CRTD? Let's start there. It's probably patients who have primarily an ICD indication but who have a wide QRS, preferably a LBB kind of wide QRS. But probably also patients who have a ICD indication, a low LVEF, and are likely to require pacing 40% of the times. There could be patients who have primarily a brady pacing indication, but they have low LV ejection fraction, and so an ICD may come in addition to CRT, or in pacing-induced cardiomyopathy, it may be an upgrade that is required. And sometimes patient may have a CRT indication with a high scar burden, and that's where you might have to think of a CRT-D. Is it always possible to think of a CRT-D? There are certain concerns, more so in any setting, but cost is peculiar to our setting, that when you use a CRT-D device, the costs multiply. The device longevity would also be affected when 3 leads are working overtime. And there could obviously be device-related complications because there is the big device and there are 3 leads, and there is always a risk of lead displacement in the short term and lead malfunction in the long term. So more the hardware, more the issues. Therefore, how can we abbreviate this, the requirement, how can we abbreviate the hardware in the setting? So let's start with left bundle area pacing, and we have been discussing it since morning. It's just that what I want to say here is left bundle area pacing is definitely an alternative for CRT, provided it is done in the right spirit, in the sense that you demonstrate the left bundle capture. In addition to the RBB pattern in V1, you should have at least one of the other criteria, that is demonstrate the potentials or different outputs. You show a transition from non-selective to selective or non-selective to myocardial capture, or the peak LVAT time or R-wave peak time should be in V6 less than 90 milliseconds, and or by programs. All this we have discussed in the morning. So you need to essentially show a good left bundle area pacing capture, and once your lead is in such a position, usually it's stable, and you can show with a septogram that the lead is quite deep into the septum, and similarly you can testify that in an echo. So normally when you are doing a left bundle area pacing, figures from Dr. Vijay Raman are that you can do it 85% of time successfully. Now, why I'm trying to say that is because when you're doing a lot ICD, you are more required to see that the spirit of having achieved a synchronization, the responsibility is much more than in, say, a bi-V pacing. So we must remember that there is inherent limitation that we can achieve that in a certain number of patients only. But once you achieve a left bundle area pacing, the numbers of R wave amplitude remain good for a long time. So about 6 months data shows that the R wave sensing remains good. So all that is important when it's a part of an ICD. Also the thresholds remain good. That is important from the CRT perspective also, as well as, yeah, anti-tachycardia pacing is usually done at the maximum output, so maybe less relevant. But to maintain the synchronization, this is important that your left bundle area pacing lead continues to give a good pacing threshold. And again, equally important is that the lead dislodgement happens in a very, very small number of patients when you do a left bundle area pacing. So all that is very promising when you are looking to do a lot ICD. trying to do left bundle area pacing as a CRT definitely works. These are figures from, again, Dr. Vijay Raman. The clinical response is in 72% of the patients, echo response is good, and similarly they are super responders also. So left bundle area pacing alone can work well as a CRT. And once again, these bar diagrams show that this happens by reducing the QRS duration. It happens, what happens clinically is that the LV ejection fraction improves, the LV dimensions reduce, and the NYHA class improves by at least 1. And these outcomes are better in patients who have LBBB and who have a non-ischemic cardiomyopathy. So LBBB as a CRT can work. Where it does not work is probably in patients who have ischemic cardiomyopathy, where the LV dimensions are very large, and those who have intraventricular conduction defects. So essentially a non-LBBB kind of a wide QRS. So this remains, is required to be at the back of the mind when you are considering to do a LOT ICD. One thing, as I said in the start, is you should definitely achieve a left bundle capture when you are trying to do a CRT. And again, this point has been adequately stressed in the previous presentations. This slide testifies to that when you achieve a good left bundle capture in heart failure patients, your QRS duration is narrower than when you are doing just LV septal pacing or deep septal pacing. So your QRS durations are narrower, your ejection fractions do improve, the echocardiographic and clinical response is better. But this is likely to happen more when you are really doing a non-selective or selective left bundle area pacing. So the requirement when you plan a LOT ICD is that you should do a non-selective or selective left bundle area pacing and not accept just a deep septal pacing. Once again, these trials have also been quoted. They are very recent. They're from this year. This paper from Wong, where first time a randomized data was provided between left bundle area pacing and biventricular CRT as a resynchronization therapy. And each group had about 20 patients, so small number of patients. But what I want to point out here is there is a possibility of a crossover. So it's important when you're counseling the patients that you are saying that you're trying to reduce the cost by doing a LOT ICD. But you have to have this in back of the mind that from this publication, at least you can gather that 10% of patients who are planned as a left bundle branch CRT required to switch to a biventricular CRT, and almost 20% of BIV CRT had to be, you had to resort to a left bundle area pacing as a CRT. So there is a definite crossover, but once you achieve a left bundle area pacing, then the benefits are sometimes more than biventricular CRT. So at 6 months you see that the improvement in ejection fraction is better in left bundle area pacing than in CRT. Now this is not yet uniform because this another paper which came still recently, the level 80 trial, showed that the conduction system pacing is not inferior to biventricular pacing. So in this publication it was not superior but not inferior to biventricular pacing. There was a lesser LVAT. There is a LV reverse remodeling, the hospitalization reduced, NYHA functional class is improved, and the QRS interval shortens. So all these benefits are there, but they are not inferior to the biventricular pacing. So we still have more information, we still require more information whether the left bundle area pacing is superior or just non-inferior to biventricular pacing, and these things will definitely play on our mind when you are trying to extend an ICD indication to a LOT ICD or downgrade a full-blown biventricular CRTD indication to a LOT ICD, looking at different aspects of the procedure and also probably the costs. How about escalating the procedure to a LOT CRT? Now LOT CRT definitely will be better in terms of synchronization because you are pacing the left bundle as well as you are pacing the LV free wall, and the example that we heard in one of the previous talks by Dr. Tan showed us that this does work. And here is the reason why, because the reduction in the QRS is maximum when you do a LOT CRT, and the reduction achieved by left bundle area pacing is definitely superior to what you achieve with biventricular CRT. So therefore, lot CRT is likely to be better than all other forms of CRT, and the lack of QRS narrowing after doing a lot CRT is a rarity. Only 3% of the patients do not have the QRS narrowing, whereas when you do biventricular pacing, you have almost 20% of the patients who do not yield required QRS narrowing. The difficulty is the following: if you were to do a lot CRTD, you are going to introduce 4 leads, and obviously with increase in hardware, there are increasing difficulties that can happen because of hardware in the short term and the long term, particularly with the leads. Just to say how you do a lot CRT is your left bundle area pacing lead goes into the RV port. The RV pace sense port is capped. The DF ports are introduced at the right place, and the atrial lead is introduced at the right place. So not complicated, but the number of leads that are required to do a lot CRTD is definitely a multitude of hardwares that is going in. Now once again, there have lot ICDs have been done, although they have not been projected separately. For example, this article from Dr. Vijay Raman's group shows that they had a few number of patients in which the dual chamber ICD was implanted, so that there is a CRT achieved, means they must have put an additional lead to give the CRT effect in the dual chamber ICD, additional lead in the left bundle area pacing method. Now, as I said, I have done one patient only where this was an 85-year-old lady with complete heart block, non-sustained VT, and a moderate LV systolic dysfunction. And she seemed, because she was quite vital otherwise, she seemed to be a candidate to get a CRTD. But because of her age and creatinine of 1.7, I didn't want her to be on table for too long, and didn't wanted to limit the use of contrast. So this particular is a biotronic system where the VDD lead is used to give the effect of an ICD as well as AV synchrony, and there is a separate area in the left bundle area pacing region to achieve the CRT effect. And the QRS with unipolar and biventricular pacing is reasonably good in terms of the narrowness of the QRS achieved. So this is one case that I did, and therefore I was kind of fervently looking forward to and asking who have done more cases or what is the published literature on lot ICD. And that happens to be little limited. So I could lay my hands on 2 publications. One is from Shanmugh Sundaram, published in Heart Rhythm O2, where he has published having done a lot ICD in almost 19 patients. Let's say attempted a lot ICD in 19 patients. The method is that you have an atrial lead, you have a DF lead, and you introduce an additional left bundle area pacing lead, and you put it in the RV port. So that is a standard configuration, and it does achieve, when done successfully, good results. This is the QRS at the beginning, this is later. He had a mix of patients. 9 patients who had ischemic cardiomyopathy, 3 non-ischemic cardiomyopathy, and 1 infiltrative cardiomyopathy. And as you can see, the QRS width is reduced to a reasonable width, 118. The R wave peak time was about 80 milliseconds. The difficulty is the following: is he very nicely acknowledges that this was possible only in 11 out of 19 patients. And this is because he would do a crossover to a biventricular pacing if it was not a selective or a non-selective left bundle area pacing capture. So what he's actually pleading for is that you cannot be happy to have just a transseptal or a deep septal pacing. When you're doing it for this indication, you should have a selective or non-selective left bundle capture. And that's why the 60% success rate is concerning when you are trying to do only a lot ICD. But if you do a lot ICD successfully, then it does help. The QRS reduces from say 176 to 118, and the ejection fraction improves, the LV diastolic dimensions reduce. So it does work, having done it successfully. And in that publication, it is also outlined why LOT ICD could not be successful is mainly in patients who have a septal scar where you could not drill that lead all the way to the left bundle to achieve a left bundle capture. One limitation or two limitations of this publication is that there was no DFT testing done in these patients to see if the sensing for the VF and the shock remains as effective as in a normal ICD scenario. Because here you are sensing through one lead and shocking through another lead. And eventually in the follow-up also these patients in real life did not have any ICD therapies. So that again remains a little lacuna in universal acceptance. So probably the shortcomings is that the success rate is pretty modest. And these are some real life scenarios that DFT testing and no ICD therapies in real life. To some extent, this was addressed by the second paper that I could read from Clementi, where they did in 10 patients and they did DFT testing. So in this publication, they did DFT testing by sensing through the left bundle area pacing electrode and shocking through the DF lead. And as you can see in this cartoon, it works in both scenarios. So they alternated the sensing with both the left bundle area pacing lead and the DF lead, and obviously shock through the DF lead. And it works in both ways. So that is a little settled issue. So the induction success was as good. The shock delivery was always successful. Only the induction to charge time was a little longer with the left bundle area pacing lead. So the additional value that came out of this paper was DFT testing confirmed that this configuration can work. But once again, even in this publication, there were no real life inappropriate or appropriate shocks. So that kind of remains still a concern. In fact, over the 6 months, they found that the sensing improves with that left bundle area pacing lead. The sensing was from 9.7 to 18 volts. The pacing threshold improves and the median impedance decreases. So one thing is sure that this lead works good in terms of pace sense parameters. So actually this is all the data that I tried to reach personally to Shanmuga, Dr. Vijay Raman, Dr. Buri, and that's the maximum published data that we have on doing a LOT ICD. Dr. Vijay Raman said that he had done certain cases, some 5, 6 or so using, I think, the biotronic equipment. So the major limitation of this topic is probably that we have few small and non-randomized studies, so we need more data, more than whatever is discussed till now about left bundle area pacing, at least on this particular topic. We need more data on whether this will help us to extend the indication in non-LVPP kind of wide QRS, who need a ICD and who have heart failure. What worries is the disparity in the implant success rate. So from Shanmuga's paper it is 60%, whereas the Clementi's paper had 100% success. So in different hands, how often you'll be able to achieve a successful LOT ICD is still something that will need more studies. And as I already said, there is no device therapy in real world that is described in both the publications. So these are some of the limitations. Understanding these limitations, there'll probably be still a niche where an ICD patient requires a CRT. You might think of curtailing the cost, reducing the duration of the procedure, avoiding complications of the procedure in terms of nephropathy or having complications during the procedure like dissection of the coronary sinus or the standard difficulties of putting a CS lead where you might have to fall back and come to a LOT ICD. So it will definitely find a niche role to do that. And I think that is still a matter of evolution. I think I'll stop here and I thank you for your patient listening. Yeah, any questions or we can, yeah. Not necessary, no, the DF1.
The pacing bipole will have to be bipolar. You would
Yeah.
not be able to get a unipolar.
Unipolar, yeah.
So that probably might end up with more anodal pacing over a period of time as compared to, or at the time of implantation itself, you'll have to check with the bipolar rather
Yes.
than the unipolar that we do.
Yes.
The other question I have, sir, is say you're doing a rescue CRT. You failed the CRT, you're trying to do this. Would you say then you still want to implant the CRT generator versus actually downgrade that CRT generator into a lot ICD?
Sure, I think having failed the CRT, having failed implanting a CS lead and probably not considering a epicardial surgical implant of the lead, I think that decision would have been made that you, so it depends on whether you achieved a good left bundle area pacing capture or not. If on table you got a good left bundle area pacing capture, at that point you will decide to stay with the dual chamber ICD. If you still are unhappy with the capture and the QRS width, then probably that remains open as to whether you want to do a epicardial lead later and therefore use a bipolar kind of a CRT device.
Would it be, I mean, there's no way to go one way or the other, as you said.
Correct. So I think after implanting the left bundle area pacing lead, you would be able to take that call as to whether you can really do a dual chamber ICD device only, or whether you should preserve something for a future possibility.
Secondly, you'll have to not implant the DF4 ICD lead.
That's never, yeah. That is given, yeah. So that awareness. Yes. That is also possible.
Then you're allowing yourself to have the pacing bipole between the tip of your conduction system lead and the LV coil so as to be a pseudo unipolar or a wide extended bipolar, you could call it. If your bipole is going to fit in into the LV pacing.
LV port.
Whatever lead that you've taken for the LV port. Boston, for example, yeah, device has to be bipolar. The LV lead has to be bipolar in your generator set. For example, Boston will not provide you with a LV bipolar.
Yeah, Medtronic and Abbott have that.
Yes, yes.
Another advantage of using this strategy is that if suppose the patient doesn't improve and you want to go epicardial, then it is a possibility.
Yeah. So, sir, I have a question for you and everyone else. Having seen that and having done conduction system pacing cases in so many cases, now when you're going to put ICD in a patient, narrow QRS, at back of your mind, does it play that I'm going to give a DF4 lead or a DF1 lead? That suppose this patient develops left bundle branch block down the line, if we give a DF1 lead to begin with, so it will be easier to have this approach as compared to if you start with a DF4 lead.
Yes, it is similar something
So
to
does
we
it
started
change
with
your
dual coils and came to single coils,
Yeah.
and now this DF4 we want to let go and
So
go to the
many-
DF1, which
many
allows you more
companies-
possibilities in future. Yeah.
That being said, actually I am a fan of DF1 lead.
Me too.
But the companies and devices are actually going toward DF4 technology. In fact, all high-end devices are mainly DF4.
Only Boston and Medtronic have DF1 MRI compatible high-end devices, otherwise no.
Yeah, Boston and Medtronic. And Medtronic one is actually 1.5 and 3 Tesla compatible both with DF1, but Abbott doesn't have it. So you are left with no choice sometimes.
Yes.
In fact, one of the major advantages of DF1 lead that I have utilized many a times is that if the patient improves, it's not for conduction system pacing. If the patient improves over the years and your CRT-D was for primary prevention of sudden cardiac death, you can downgrade it to a CRT-P. And I've done that in many patients, many of my patients, of those, especially those who have been super responders. Cuts down the cost, cuts down the ICD lead complications, and it's much smaller, more cosmetic.
Yeah. Okay. Sure. Okay. No more.
Let's move on to a live presentation. Case 2, a 62 years old female, diabetes mellitus, systemic hypertension, has complaints of 1 episode of giddiness. An ECG shows intermittent complete heart block, atrial rate at 90 beats per minute, ventricular rate was 35 beats per minute, with narrow QRS escape. The QRS distance was 90 millisecond, and the electrolytes was normal, and the echo shows adequate LV function. And the plan was permanent pacemaker implantation using CSP.
Ask them whether I'm audible. Dr. Tan is around?
Yes, we can
yes,
hear
yes, yes. Yeah, so I just would like to know whether we are connected, audio-wise to the...
Yes, we can hear you.
All right, Karthikeya, so you will be the moderator and take some help of the other experts there. Ashish, I think it was a great talk. So now, Dr. Tan has infused the confidence in all of us, and now he wants me to do the case. Tan?
Yeah, by all means, proceed.
Yeah.
Quite an interesting patient.
So however much we have done in the past, in front of the experts, we always tend to get nervous. But then I have Anindya, always my Bahubali. So I think this is kind of a little straightforward case. I think Tan would tell us what should be our approach here.
I think we can just go ahead and do, because even with the one-to-one conduction, the QRS is actually narrow. I think his bundle capture is actually a
So I
good
just
idea.
was thinking, you are actually pro for left bundle area pacing. But as I was saying, always I try from the his bundle. Let's see how the parameters we end up in having.
Yeah, of course.
Yeah,
You can
okay.
try the his, and if the parameters are not satisfactory, you can always go to the left bundle, which is the
And
beauty
then,
of it. At least you know the his bundle position.
And then when we know that this Agilis Pro is actually made for the his, we don't reshape today. I mean at this time. Okay, I'm just inserting the very large sheath here is what 10 French. 10.5, and then I inserted that. We should be careful that, no, that is okay. So, it usually sucks the air, so we need to be a little careful. It's a very large bore sheath. So now, we are going with the guide here. It doesn't really matter whether we enter into the RVOT or on the RV apex. As long as your goal is to reach the his. Okay, now Flora, please. You can make a little bit of a flexion there, so it goes a little more easy. Go here. Try to avoid the injury there, and so I am removing the. You can flush the. Okay, so we connect the cables. We'll start looking at the Agilis sheath electrograms. So the connections are good. Can you just get the edge a little up there? Yeah. Get the introducer, and we can actually, before they connect it, we can even start mapping with the Flora, please. We can actually start mapping with the You can come this way, please, little. So we already know where the haze is, so you try to get in nearby. And maybe there is a, there is, right? So that's the his, yeah. Okay, so we get the lead in that area. So can you get me the? So I have introduced that, he calls it a bypass. What is that he calls? It's a bypass tool, but it is a lead introducer essentially. When you introduce this bypass tool, actually doesn't really bleed. So no concerns while you are actually screwing, right? So I'm going in there. There will be little resistance at that curve. So especially you make another curve, it will be little more resistant. So now you connect the stylet to the electrodes.
So Dr. Ullas, we noticed couple of things. One is that you removed your dilator while your sheath was only in the brachiocephalic vein.
Yeah, it's because that sheath might sometimes injure the junction. SVC junction.
And the other is that you are performing in the AP position.
Yeah, it's okay. Just the beginning of the day, we'll change the positions as we get bored.
Or you are.
So,
you can do even without fluoro, I believe.
Yeah, true. That's what we usually do. But then people should believe that we are doing the case, right? So can you just reduce the gains on the unfiltered? Yeah. So we are almost, can you just make a tendril a little better? You see there are some paste complexes, that's the parahesian thing. Yeah. Not the paste, the catheter-induced complexes. Okay, so try to get some good His signal on that. Okay, fluoro. You can now go to some RAO view. So this can be off. What is it? His in where? Okay, now let's concentrate on the tendril signals. Okay.
I think that's a hiss and a tendril as well.
Yeah, looks like that. So now you'll have to reduce the gains, I think. Maybe occasionally there is something. Okay, now we can pace and see how at low output, high output. Yeah, so there is widening. Yeah. Yeah. Come down. Let's see. Okay, it will be rather wide. So go to 7, 8 and then check. Yeah. All right. So just check some parameters there at that site. Update and check the QRS or whatever. LVAT and all that quickly. So essentially there is no capture here, it's just a myocardial capture near the His bundle. And then 86 and the QRS is quite wide, I'm sure.
You got a baseline right bundle now.
Yeah.
In the conducted beats are all right bundle at the moment.
Okay, yes. Now can you just stop pacing? Did we injure something? It's still narrow. We have not, still narrow. A little bit of an RBB, little injury may be there. A little injury is there, okay.
Yeah.
So you know what?
Right
Yeah, so we spend another 5 minutes here to get real good His on the tendril. Okay, fluoro. Gain up the tendril. Let's get some A kind of
slightly lower.
Yes.
Because your His catheter is slightly lower than your position.
Yeah, so I would like to deflex. Huh? Yeah. We can actually go now to the LAO area, and I think there may be some suggestions. Okay, come to the LAO, and then we'll see.
Yeah, there is but you have a right bundle again, is it?
Yeah, yeah. So we cause some right bundle there. Yeah.
You
Okay.
have a right bundle now.
Yeah.
Because when you get the right bundle, you get the his signal as well.
Okay. So now, yeah, I think it is very close, but no, the his is not there in the his quadrupole.
Could you measure the his to V? Is it a right bundle potential, or is it a his potential there? Can you see the his to V on your tendril? On your tendril. Is that a his signal? Can't see.
Not that is agile, is down.
The tendril. Yeah, there's a his signal there.
There may be, there's a hint about it. Okay, now can you just pace and check whether it. Yeah. Sometimes when it is, was it a fusion? It must have been a fusion. Okay, but whenever there was a narrow, it was a fusion, I think, correct? Yeah. So wait to get the his bundle again. Stop pacing. Fluoro. There may be. This is a little better. Yeah, I know. Actually, we have it here, but this time, can you even push it in inside a little more? Okay, so now it doesn't matter. No, but then the camera might have a issue. Okay, now can you just pace here? Yeah, sometimes the V2, I think. No, mainly A. Okay, fluoro. Yeah. This is CS, I think. Okay, now this is. Yeah. Okay, now pace here.
Ullas,
Yeah.
Dr. Hajraya, now we know that his bundle is a cloud rather than a focal point.
Yes.
Now, if you have a larger footprint lead like what you are using here, Abbott versus Medtronic, where the footprint is smaller,
yeah.
Do you think the larger footprint will make it easier to capture the his bundle cloud?
Not sure. It is just that trial and error. We'll have to be hunting for that spot. So far, the quadrupole had helped us to an extent, but not truly, even though I was almost touching the tip. Okay, come back to the audio a few more minutes. You can stop pacing, let's. So there was, yeah, okay, now you pace here. You see that? This is good, right? This is good, right? This is good, right? Okay, now hold it here. Hold it here. A piece. This is okay, yeah? This is good? Yeah, okay, now again show the local electrogram. You may gain less or whatever. Yeah, it's okay. And now pace. Yeah, pace, yeah. We lost? Yeah, I think it's okay. There is some degree of isoelectric line. If we I hope we succeed here. A few things, we'll have to get us the A and the V values without pacing. It's all V, almost. Yeah. Yeah.
Another, Ullas, your large footprint sheath with the lead, the injury.
Yeah. Sure. There is a backup there. Can you see? Okay.
What I'm saying,
go little.
The amount of injury with large sheath and large footprint Stylet
Okay, now, so
much higher than the Medtronic one with the
Yeah,
slicker sheath and smaller footprint.
yeah, you be around, I think will not cause any injury. So I think it's a time yeah, yeah. Okay, so now what we am doing is I follow the advice of Tan. Don't bring any stiffness at the tip. So take the stylet little out.
Actually, if you're in this position, you can just put a
Okay. Okay. All right. So sure. So now, when you are not making a shape, you can always push the stylet as much. Actually, it is almost at the tip. That's correct. Okay. So I did that. Okay. Now one more time, you paste before screwing.
Yeah.
That's okay.
Dr.
So
Tang, does it make sense to take an angiogram like
not really, because this is a membranous area. So okay. So now I am going to bring the helix out. Yeah. So I am continuously also observe what is happening. You can pace. Okay, now zoom the. No, it's okay. Zoom. Can you just hold the lead also a little? Yeah, see, my lead is outside the sheath.
Yes.
Helix would come out in a while.
Beautiful.
I know what you would. I want the regular fluoro. Yeah, but it is not so clear. See, I think there are the helix is completely out.
Yep.
I'm not going to be screwing it further.
Yep.
I would now like to see the.
Would you do his angiogram to make the visual impression? The lead is going to be very
No,
stable.
it's not capturing, right? Okay.
Like septogram, or does it make
intermittent.
any sense?
Okay, now listen. I want to see the injury. There's hardly any injury. Okay, what's the impedance? Okay, fair enough. So what is the output now?
This is at 5 volt.
5. So at 5 you are losing?
Yeah, intermittent.
Okay, that is at the 0.4 milliseconds. 0.5. Okay, but I think we can pursue on screwing little more, or the body turn now.
Yes, I was about to suggest that.
The body
Actually,
turn now.
you can do the body turn. So pull the stylet back a
Yes.
little bit, rotate the body, and see whether you can drill further
Yeah, so
into
now at this
the
stage, the
sheath.
stylet has to be little out.
Correct.
Correct?
Now you are rotating the body.
Yes.
So
Yeah.
I would pull the stylet out
Okay,
a
and
little
then
bit.
when I am doing the body turns, I make sure that the bypass tool is put.
Exactly.
Okay, get the bypass tool, please.
The bypass tool and then stylet back. Now you're going to drill it a little bit, but I won't drill too much because they're in the his position now.
Yes, yeah, we shouldn't be. Yeah. So
yeah,
now
because you don't want to go right across.
I am going to be
It's not that
inserting
thick, that area. So bypass tool in a
Good.
little bit, stylet back, and then just drill forward.
Yes. So you are pacing?
This is at 7, sir.
No, it's okay, but you are pacing and then there's some capture at this, which is not so bad. You can just check some of the QRS and the LVATs here also. Okay. So now at this stage, I'm pulling the stylet
Stylet
little
back.
out.
You can pull the stylet back a little bit.
Yes.
Probably about 5 centimeters or so, because you only made one curve there. That's okay.
Yeah. So now I have removed.
Yep.
And
Then rotate the lead body.
the crocodile clip is on the stylet.
Yep.
And then we are getting all those.
Yep.
Yeah. Right. So now we'll see what happens when I turn the body.
Yeah, just turn the body, but you just want to go forward in maybe 1 or 2 millimeter at a
yes.
time.
Yes,
Okay, you can fluoro. Yeah, just rotate the lead body. It's going to move forward now. Yep, it's moving quite a bit now.
And the helix have remained exposed.
Exactly the same. Yep.
This is the 6th or the 7th turn. Now it's the 8th
Okay,
turn.
I think that's quite a bit. That's quite a bit. That's quite a bit. That's quite a bit.
Quite a bit,
Yeah,
and
yeah,
then
you
it's
can stop
holding
fracturing
there.
yourself. Yeah. Yeah, probably more towards the left.
Yeah.
It's okay. You can try that now.
Yeah. Yeah.
Coming down from 7.5 to 7, 6.5, 6.
Yeah. So this is.
6 is capturing.
No, it is not.
Intermittent.
It's not. So that's the usual case. We'll try another couple of turns and then we are done. We
You can
go down to the left panel.
Yeah.
Correct?
Sure.
Okay.
Sure. You can try.
So
Of
now
course.
let's try one more time, Flora. Okay, so now,
Yeah. Oh, careful. It's a lot. It's a lot. It's a lot now.
okay, so now I think I should stop here.
Yeah. You should stop.
Okay,
You
now
should stop.
whether the injury is more, check that. Stop pacing. Stop pacing. Yeah, there is an injury, which is little better than before. Correct?
Yeah.
Not much, but yeah, small. And then, do you see any signals on the tendril?
I don't.
Okay, may not be. Okay, now pace. Hmm. Hmm. Hmm.
Oh, good.
No.
Oh,
Actually, I usually wait for another 5 minutes at this stage.
Yeah, you can wait. Can you check at 1 milliseconds pulse width? Start at 5, 1 milliseconds pulse width.
Okay. Yeah. Nagendran, you sing nicely, no? If you sing one song and by the time it finishes, the thresholds usually get better.
Yes. Yeah, it does. I mean, typically you get current injury, but you don't have much current injury there, though.
Yeah, okay.
I must
So
admit.
I just was thinking, you can just stop pacing. I just was thinking, Fluoro, is there any, okay, you see, I think it is coming, maybe we'll have to, I give 1 or 2
You
helix turn.
Yes,
Helix
sure, you
turn.
can. Yeah, you
Okay.
can.
Start pacing again.
Yes, sir. So, pacing on.
Mm.
Back on 1 millisecond and 5 at 1 millisecond.
Just like that, I'll just put 1 or 2. Nothing. You see, it is no tension here, no tension. How is it? It should be okay. Okay, now DCM ones. Okay.
Yep.
Okay, that's fine. Now listen, can you just see whether it improved?
Clip the, this is 5 at 1, impedance 620, it's capturing, coming down 4.5, clip unfiltered 3.8, 3.6.
Oh, nice.
No,
Loss.
no, there's a loss.
This is 1 milliseconds, am I right?
I think, at 1, it should be 2.5.
You can wait for a while and see how it goes.
Okay, now what's the length, Fluoro? So, you know what, I'm thinking of body turn.
Sure, you can try again, go a
Again,
bit
yeah.
deeper and see how it's
Yeah.
because you don't get a lot of current injury, right?
Yeah,
Could you stop
so-
pacing? Is that current injury?
Fluoro?
There is it? Can't see which one is the lead. No, it's okay, it's okay. Yeah, it's actually quite deep there.
Yeah, I don't know. Okay, now check.
Taking on 5 at 1, impedance 620, start capturing, coming down 4.5, 4.
What is currently the threshold here?
No, it's not better. It's not good. It's about 3.7 or so at 1, na? Yeah, so that's not great. Okay. You know what? I want that unifilters. These guys are today not working good. These unfiltered. Okay, so
Not
Dr.
very good.
Tan. Now I think we go to your approach, or okay. So
Well, if you want to wait for a while, you can, but
yeah,
I certainly this is the
2
optimal
minutes more.
threshold.
2 minutes
I
more.
agree
You know
with
what I would do? I will little deflex this. Yeah, I deflex this little more. Okay. I was thinking the sheath itself was dragging it down. So now at this stage, this is the last.
Yeah, you can try bipolar pacing and see
Yeah,
whether it
yeah.
makes any difference, the threshold.
Usually the ring won't capture here.
can advance the lead out and pull your sheet back a little bit and see if bipolar makes any difference.
Hmm. Hmm?
Probably should pull your stylet back a little bit when you do that. Yeah, so that, yeah, then push your lead in and then give you that nice heel so you don't dislodge it.
Okay,
Yep,
and the stability, I think it is quite achieved
Yeah,
here.
very good, actually.
Okay, now it is just the thresholds, right?
Yep.
Okay, now there is no A at all. It's all V, and it is just the threshold questions.
Yep. You want to try bipolar pacing?
Yeah, we could do the first unipolar.
Mhm.
Hmm.
On at 90, 5 at 1, impedance 590, it's capturing, coming down 4.5 at 1, 4, 3.8, 3.6.
Yeah.
Oh gosh.
Yeah, it is just at the. No. 3.6 is too high. Bipolar, you check. Okay, see, this is the bipolar signal for you. See, actually, there is a ring capture, you know, the element of ring capture is there. Yeah. But the QRS is a little wideish.
Looks like mostly a myocardial.
Yeah, so the anode is. Okay, you know, it's all right. The thresholds improved, but the QRS morphology is more myocardial. Anodal capture, ring capture was more, not the tip. Okay, so now let's look at you know, the QRS morphology. Put the 12 lead and check. No, you put at 100 speed and check the QRS morphology, etc. So it's quite wide. You know, you go to 200 speed and check. It's quite wide. This is about 120, 130. Okay. Okay. Yeah. This is quite wide. This is quite wide. Bipole is not giving a good result. Okay, now finally you check the unipolar, please. Tip unipolar. You could even actually demonstrate the ring capture how it is. Huh? So this actually is good. This good. Huh? Hmm. 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 Yeah. No, I think this is more than that is acceptable. A ring, there is no capture. See, this is the ring, right? So this was contributing in the bipole. This was contributing to the bipole. So I think we waited enough. The thresholds are not acceptable. Okay. No. What do you say? What do you say? Too high. And you know what? Somehow. Yes. Yeah, and you know what? Even the unipole, that QRS morphology was not like great. Okay, there was not you know, what do you call, very clear-cut isoelectric line. Just for the sake of it, you know, again tip and then check. So this is the final time you are checking. This is at what? Yeah. So now just show the 12 lead in the 12 lead page. You'll have to reduce the output. Okay, put at say 4. Okay, 200 speed the 12 lead. Update. Update and 12 lead. Yeah. Not too bad, but you know, the thresholds are not okay. thresholds are not okay. But you know what? If the thresholds were to be okay, I think we would have been finishing it here, right? And you know, it is just about 1 volt. Yeah. Anida, tell me a story. We'll listen and then. Okay, so in the meanwhile, let's get the audience reaction here. I think, you know, it is just a touch and go. We are not very happy about 3.5 to 1 milliseconds thresholds. Any comments, Karthikeya, Ashish, anybody?
Yeah, I think so. We need to take it out and clean it and reposition it.
Yes. You know, there's some more work there. You know, we'll have to reshape the sheath too. And, you know, when you remove everything, I usually put, you know, another one dilator into this. Okay, so we'll have to get one dilator on the wire. No, not same dilator, but I'll have to make a shape now. Okay, last one, final time, check. Okay, now stability was good. The V were good. There was no oversensing of anything. So it is just the threshold made us to now come down to the left bundle. Okay. All right. So lost. Okay, leave it. So we are going to be moving from the his bundle to the left bundle area. Okay. So now, when we remove, you were telling us to counter the body fluoro and not to not. Yeah, so no pull, nothing. Yeah. Yes. And you know what? I don't have much resistance there, so I'm not pulling any tissue there. Huh? Yeah. Yeah. So I could easily remove. And now let's look at the tissue that has you know, you can focus on here. Yeah, so I have taken out the his bundle, right? Yeah. Is there? Okay, you see this is the amount of some clot and some tissue. I don't know whether they see. Yeah. And then, you know, there is some kind of a distortion of the helix. Yeah. A little. Yeah, maybe. But then I think we can still use the same lead at this time. Or you want another lead?
I think it's okay. You can retract.
Yeah, I think we can try. We can try.
Okay. Yeah, I think it's okay.
Yeah, so Nagendra may not be unhappy, nah? So you give me the. Yes. No, you give me the thing. So now, no, the lead. I want to clean it. So there are questions now. Should we get me one? Should we retract this or let it remain there?
I will retract it first and then re-extend and retract just to make sure everything is okay.
Okay.
But when I reintroduce, I always retract when I put it back into the
Okay, fair. All right.
because I don't want to damage it anything more than what it is.
Okay, but you will have to confirm that, you know, the mechanism still is intact. Okay, and then it looks like the mechanism should be intact. That is going to be checked. You can focus here. Clip. Here. So in 4 to 5 turns, it has to come inside. 1, 2, 3. I mean, it's got inside. So okay, the mechanism I think fairly intact.
Yeah, everything is intact.
Okay, I don't have to again, you know, I don't have to. Okay, I got it inside.
Yeah, it's perfectly serviceable.
Right. So you know, you give me one more vertigosh. Yeah. Okay. So you'll have to get a. Again, I introduce in the thermo. No. No. Yeah, but you know, I wanted to put on wire.
Yeah, you can put one wire in because it's okay.
I think it is better to put a wire.
When Ulla's lead got some meat inside,
Yes.
there are many ways of to clear those meats and fibrous
Yes,
tissue.
tell us your tricks.
Yeah. Now, the caution is if you do not put this insulin needle tightly into the syringe, and if you start injecting, the needle will hit your finger immediately. It will get ejected and it just immediately go into finger. So be careful that your needle is absolutely nice.
Yeah, so that's what no, not dilator. You just give one more.
Second,
10 French dilate.
Second, use a smaller needle like insulin needle, and you can scrap the helix with that insulin needle without using the syringe, or you can use the jet, normal saline jet there.
All right, so now Dr. Tan's lesson in the morning, we are going to practice now. So when it is, you can just show.
Just introducer in.
Yeah, so we put the introducer. We put the introducer. Oh, see that? There's so much. Yeah. Okay, now you give me the. There's so much of a clot. There's one more port here, right? Give this. Okay, it's clean. One more time. So much of a clot. Yeah. Yes. So. Okay. So we're done here. Yes. So now I'm putting this in. Okay. So now you can show this. Yeah. So now with the dilator inside. Okay. Yeah, so this is the plane. Yeah. Yes.
So you know that it's flexing in that direction.
Yes.
Now you can make your first curve.
Okay, now is the flexion enough, or you want to go?
Plenty good. You don't need so much. It's just to tell you this is the plane where it's going to.
Okay, right.
Yeah, and then you just need to make your first curve.
This way.
Not that one. They're more proximal. You want to make them. No. Here, primary proximal.
No, this is you want to start from here. Yeah. So.
Make the curve how you make a curve. Let's say you want to go into the army.
Right. So.
You can take quite a lot of beatings, so don't worry.
So this should be okay.
Yeah, that's good.
Okay. Now, so this is the primary.
Yep, the primary. Now the secondary one.
Yes.
Okay. Now you can flex a bit more so you know your plane clearly.
So now this is the plane.
Yep.
You want to be perpendicular to this.
Yeah. So not up towards, but down towards the patient.
Right.
Because you take a look at your sheet.
Yes.
This is how it's going to go in.
Yes.
If you point down towards the patient, it's towards the septum.
Yes. Okay.
Just bend it down and then forward.
So I think the audience may be looking at it. So this is the plane. He advises us to bring it down, right? So.
Yeah, because that's how your sheet will sit, and you need to point it towards your septum. Yeah. So just bend it down even more. Don't worry, you can bend it all the way down. You won't break. Yeah.
Yeah.
Bend it all the way down. There you go. There you go.
So now I think we give a little bit of here also.
Right. That's fine. That's fine. Just understand that the more curve you make, just make sure you're in the right plane. You see, you're not quite in the right plane right now. You see, you need to make it. The thing has to point straight down. You're pointing it away, but down towards the patient. There you go. That's what you need. You need it to point it straight down towards the septum. There. Exactly so. So don't point it up there, down. You need to point it down.
Yeah. See, this started looking this way, right?
Yes.
Yeah.
That's what you're trying to do. Something like that. Yes, something like that.
Yeah. So now this is one primary here we made, and then this one you said to make it down here, and then don't.
Just think of it like a Mons curve. How would you do a Mons Stylet curve? How would you do it? Right? It's the same thing. You're trying to do exactly the same thing.
Okay. So this is pretty much the same. Okay. So now you think we are prepared this?
That's
not so great, but not so great.
It's not too
Is it okay?
You can try that. You can try that. The proximal one, I'll probably make a bit more of a curve so you can go through your tracks a bit more, but a little bit better.
Yeah.
That's it. You can try that. Not a problem.
Don't bend it there. Make it a little more there.
Absolutely correct. Exactly so.
Yeah, so.
Correct. Just make it in the
And by the way, it is, yeah, it is, yeah,
exactly so. That's all you need to do.
it is better to show the see. Actually, maybe if you remove this, it will look even better,
Correct. Yeah. Exactly.
Okay. Now, can I just also show to them, how it looks when I remove this?
Nice.
Yeah, is that well prepared, or some more you want?
So you can flex it a bit more. Use the knob and flex it. See, it's more. So when you flex it a bit more, it should be pointing back.
Yeah. So no, but then
Slide it back in.
yeah. So
Flex it a bit more so you can twist it.
I think it wasn't. Yeah.
Flex it a bit first. There you go.
Just put it this way.
Yes. Yeah, point it away. So when twist it up towards the leg.
So
Twist it up towards the leg. Your leg. Yes. The other way. Something
Yeah.
like that. Yeah, it's good. Something like that. Yes.
enough.
Yeah. Yeah. You can
Okay.
try that.
Okay.
You shifted quite a bit already.
Okay. Now, if I again release this, take this out, and do this.
Yes. It should be able to give you that.
Actually, this has to be a little more this way, no?
Correct. So you got to point it towards that.
Okay. All right. Now.
Flex it a little bit first so you know your direction. And then point the blue tip that direction. That's right. Point it, just twist it, and down towards her. That direction and then towards her. That's right. Okay. Now you get the idea. Now you get the idea. Okay. Now if you let go, it should be able to hold the position much better. There you go.
Again, so? Not sure. Better?
Yeah, better.
No, really, not really.
Flex it. There.
Some more? Actually, the way we do it was, this has to be a little more this way.
If you want to, you can, but this is pointing back already.
Okay, sir.
You will
Okay.
not do that much
More?
anyway.
Okay. Yeah.
Right.
Okay, hopefully, we get through with this. Okay. Get the verticals, please. Okay, now the sheath which is shaped. Hold it there. All right. Some light can be off here. Flora. Flora. Yeah, so Flora. Yeah. So so that's quite kind of apical. Okay, so I'm going to be removing both the dilator and the wire. Okay.
Dr. Ullas, huh?
Yes, yes.
Till you are trying to reposition it, can we have a talk in the meantime?
Who is in a hurry?
No one is in a hurry. We just thought while you are repositioning.
You should teach us now, like what is that you are seeing. Okay, 2 minutes again,
Sure.
Otherwise, it will be interrupted there.
No problem. No problem.
Okay, fluoro. Okay, so now. Yes. Yeah, fluoro. You can actually, kind of pace also here now. Get the tool, the bypass tool. One second, I'm just connecting things. Yeah, yeah. Yeah, there is kind of a notch is there. 2 is positive. So V1 you can make a color there. Okay, now pace, yeah. So yeah, there's a little bit of a notch, yeah. From the agilis. So now I think that's from the agilis. So maybe you will have a better W with the Stylet. Similar, okay. Yeah. Okay, now we can pace with the agilis. Tendril you can go. Okay, so I think it is still inside the sheath. Okay, fluoro. Maybe. Okay, now at the higher output. That's interesting. Yeah, sure. Okay, now one more time show the agilis. Yeah, I think when I expose the helix, it could be all right, I think. Okay. Okay, now what is the impedance on the tendril? Yeah, so that's why I think it has to come out. You get the bypass tool. Yeah, I mean everything is right now. Okay. Fluoro. So my Stylet almost has reached the tip. Okay. All right. I'm connecting it to the electrode, and then now I will expose the helix now.
So the idea is to tag
Yes. Okay. Okay. You can actually mag once. The second, third. Push the lead little inside. I think helix is coming. Okay. Are you pacing? Okay, so the notch is good there. Okay. Okay, so now I am taking this out. Okay, now can you show me the helix, please? Okay, that is okay. And then your morphology is not bad presently. Coming up there. Okay, now you give me the bypass tool. Okay, so leave that. Yeah, and then the Stylet is completely in. I'll have to pull the Stylet out. Yeah, huh? Sometimes it is. It's okay. Okay, now I'm taking out the Stylet, say about 5 to 6. Yes, that should be enough. and there's no stress on the lead here. Okay. Then I turn the body now. Yeah. Okay, now can you just show me the spine, please, little? Yeah. Achha, the good news here is this because of the robustness of this sheath, you know, actually we can really give a good support on the sheath while we are drilling, right? Yeah. So, yeah. So now. Yes. And watch the helix. Yeah. Yes. And just to go on telling us some morphology change on the. Okay, the helix is still out, but maybe, you know what, yeah, this is good. R prime intermittently, but I think you can go forward a bit more. Okay, stop. What is the LVAT here? And what's the impedance? Okay, check the impedance, please. Fluoro. Okay, it has come out. I mean, I think you'll have to push that. You know, the stability. It came out. Yeah. So you know what? We will have to. 1 second. Fluoro. Little sheath is, pushed. Okay, now. Okay, now the helix is out, but you know, maybe one turn I will give on the helix. Yeah, give me. Yeah, but then it's okay. It's okay. You know, already you saw W, you saw that R prime coming up, so I think it's okay. Fluoro. And look at his and this are quite proximal, so we are actually there. Yeah. All right. So. Yeah, actually inside, right? Into the fluoro. Oh, yeah, fluoro. Just rotate the body. Just gentle forward pressure as you rotate. Just let it little go inside. You don't have to push too hard. Keep the sheet in that position and just rotate the lead body. There may be a bit of resistance where you are. It looks like there is a bit of resistance there. It is taking the turn. Slowly. You don't need to twist that fast. The faster you rotate, the more likely it's not going to go forward. So just slow, deliberate clockwise rotation of your lead, and it will drill. Forward movement a bit. It's not moving much. You're moving forward. You are moving forward. Just rotate a bit more. Not fast movement, not small movement. Just slow, deliberate rotation of your lead, and it will drill. Yeah, it is rotating. Okay, you want to test here? Yeah. There R prime. Yeah. Technically, there is an R prime there. Yeah, keep going forward. You're almost there. Sometimes you get a little R prime there, sometimes. There, diffusion. There, is it? Okay. Yeah, there is a bit of R prime there. Okay, so now can you just demag and show the curve? Demag and curve. Demag and show. I think we need to be pushing, falling back. So I'm not sure about the stability now. Can you just? Oh, it's the loss of capture also. Okay, now are you pacing? Yeah. So. Okay. You see, I think we need to be pushing definitely the forward. And I hope I should be able to. Otherwise, I think we'll have to change the position. Yeah. Yeah. Okay, but the parameters are great. You can just check once, what is the threshold here? Elevate must be around 70. Check the elevate. Hmm. Hmm. Yeah. Okay. So anyway, the R prime is not coming up more. Yeah, I mean maybe there was, No, just before the loss. Okay, do one thing. You again go back to 1.5. See what happens when you. Huh? No, look at this. This R prime here. Some R prime now. No. Yeah. Do one thing. You see. Okay. You will have to check from 2 and down. Yeah, we can give. See that? At time maybe it is a fusion. Huh? Okay, chal. All right. You know what? Give me a turn. The helix. See, the helix anyway is out now, Flora. So no more to give any more turns on that. Okay, now we'll rotate the body. Yes. Yeah. See, my stylet is quite outside, all right? So it is not, okay. Okay, now go a little more inside. Okay, now, that this is the final thing, which I would like to try before we change the position. Ring has to come out of the sheath, and it should not buckle. Is there any change happening on the morphology? And you are going to tell us some impedance values. Any morphology change? Falls back. So change the position something? No? Okay. Give. I'll have to remove this, otherwise it will come out. Flora? See, it has not gone, it falls back, so I think we should be changing. Okay. Okay, so, yeah. Yeah, it's okay. Yeah. Yeah. It is just that, it is coming back, huh? Correct? So we need to, we. Yeah. So one time more. Yeah, but I'm not. So a lot of support it is giving, no question. It is just that I'll have to be daringly be pushing. So impedance needs to be get. Okay. It's okay. Is that okay? Okay. You keep sheath also. All right. So this is the last time I try.
a lot of fibrous tissue there. Yeah, you're right. Probably a little bit entanglement. Maybe we should change the
Go on telling little loudly the impedance.
I think
We should change. Yeah. Change the position and maybe change the lead. All right. Yeah. Yeah.
And it should come back out into the sheath. Yeah, just keep countering. Just keep countering. Keep countering until it falls into your sheath. Just keep countering.
Okay, stop fluoro.
Often when you counter like that, the lead just comes out nicely. It doesn't
I don't know whether you can focus here. There's no helix, and I don't know why. Just give me the whether.
go forward, go down slightly, go up slightly, go anywhere you like.
Interesting, you know, the helix appears to have broken inside. Okay, good. Still looks good actually, intact. All right, so we change this. Yeah.
You can change the lead, or you can change it. Definitely change your position.
Okay, and then how about making some better curve, or is that okay?
That's perfectly okay because it's a failure.
Okay, fine. All right. All right. So just flush once here into this. And then you flush here. So now we are quite proximal to the his, maybe little down.
You can, definitely.
Or little up. I think little down would be okay.
Little down would be okay.
All right.
Yeah, I'll go at least a bit down.
Yeah. So did you flush? Huh. No, it's okay.
If you pull it, keep it here, push it. It will be like here. You keep it here. Not push it here.
It's okay then. Doesn't matter. No, what's the big deal?
When you're not using it, just pull it and keep it here.
No, let it be there only. Flora. Okay. Yeah. Okay, so now it easily went. So maybe the curve, you think it's remained. Okay, let's see. Go to the RO. So we make a counter here.
Okay.
Yeah. Flora.
Yeah, push it a bit forward towards the apex. Unflex all the way. Just unflex your sheath. Unflex. That's flexing. Unflex it. No, don't flex. Unflex. Unflex. Point towards the apex. Point towards the apex. Unflex all the way.
This is actually unflexed. Yes, this is unflexed.
Okay, now clock. Not counter. Clock.
Clock.
Free it from the septum. Just clock.
Okay, this is clock.
Clock, and then now push forward with it, unflex. Go towards the apex a bit. There you go, very good. Now counter and flex. Counter and flex. Yes, very good. Flex it. You come up, don't worry, just flex. Countering and
This is actually the maximum flexed.
Dr. Ullas, can Dr. Tan also get a mic so that we can hear what he's saying?
There you go. There you go. There you go. There you go.
I think Dr. Tan's voice is not heard, I think, there.
Okay, that's very good. Pace here, his pro. I will speak louder. LAO.
Flora.
LAO.
Apical. Apical, not much good W there, or there is. A lot lower. We may have to. Karthika, the Tan's voice is heard there now?
No, not at all.
Not yet. Okay. So we are giving you a different mic. You can speak into the mic.
Hello.
Karthika, now?
Yeah, now we can hear you.
Okay, so you
yeah,
had some
this
questions?
is lower. but I'm okay with pacing the left posterior fascicle actually.
That's okay. Now we will okay, this one, this is the position.
Simply put, because if you go a bit higher, we know
That's
there's
the
lots of
same problem we may again encounter.
We may or may not, but this
Okay.
is actually lower.
Yeah, so what, we should go a little up or here?
I think we're okay here. I think when you go up, it's where we originally
all
were.
right, okay. So
There's
now,
actually
you
a
know what
lot
I
of
do?
fibrous tissue there.
Okay,
You
what
may
I
not be
do
able
is
to
I
drill
bring
through.
the lead at the
Mouth.
the mouth without the helix exposed.
Correct. Now
Ah.
you can actually expose your helix.
You can
and
just
drill it
place
through.
once the tendril.
So the tendril may not,
may
be
not,
able
may
to
not.
pace because the helix is not extended.
Okay, fluoro.
Only the helix can conduct.
Sure.
So if it's retracted, it will not capture.
All right. So now I'm going to be, the stylet is all the way in.
Yeah. It's okay. You got to extend your helix first.
Okay, doesn't matter. So now, okay, now see, check, please.
You can't. You can't. His
Okay.
pro. You got to pace his pro.
Yes, some W is there, okay?
Yep.
Not such a greatest of the W, but say.
Yes, it is.
Okay, so now I am, okay, you push the lead a little bit.
That's okay.
And then, you know, I'm giving some turns to expose the helix. Push
Yep.
the lead a little more.
Yeah, it's good.
Some more.
Until full extension. Yep.
Can you just push the lead a little more?
It's okay. Don't have to push so much. Don't have to push so much. It's okay. It's okay. Yeah, just extend your helix. It's good. Just extend. Keep extending. Keep extending. Yeah. Just keep extending. Just keep going. Keep going. Keep going. Keep going. Okay, we are good. We are good. Now you can pace if you want to pace. Now you can pace.
Yeah, it's quite apical. It's okay.
Yep.
Yeah, the W is better than the agilis.
Okay.
Hmm?
Yeah. Okay.
You go with the body turns here. And
Yes,
hopefully
of
we
course. Bypass tool
Okay,
in,
so bypass
stylet back, and we are good to go.
Yeah, so now the stylet is quite away.
Yep. Good. We are aiming for about 100 150 ohms drop. You can start rotating the body.
What is the impedance, is it? 780. Okay.
So we're probably hitting about a 600, 500 mark should be good.
Okay. So now, you know what? I'm turned the little up this IA.
Fluoro.
Yeah, fluoro.
Yep, it's drilling. I like the way you do it. Slow and steady. Good.
Some change in the QRS.
Am I right to say there's a little R prime now? There's a little R prime there in V1? Yeah, we're there, we're there, we're there. LVAT. LVAT. We're there. Somebody measure LVAT.
No, what is the impedance? So the I prime came, nah, QR.
I think they should be enough.
Okay, no, sure. I'm not doing anything here. Yeah.
Sorry?
Okay.
90.
90 is it, 90.
Yeah, it's more to your left. Sorry. If your his signal, drop it, decrease your gain for your his signal. Your his pro 1, 2 decrease so it doesn't cover your V6. Or pull your V6 signal up so you can measure properly. You can't tell the difference there. Your his signal is covering. Can you see that? Decrease your gain for your his signal. Decrease it some more. His 1, 2 decrease your gain.
No, that's fine. Okay.
No, not the active one, the measuring screen. Okay, never mind, it's an update. There you go. Very good. Now you can measure. No, to your left. Yeah. Yeah, something like that.
70,
Yes.
70.
Measure
80,
your QRS for me.
But there's a, see that QR is there. And you know what?
I'm okay, it's about
will not-
110.
I'll not be surprised if you have a fascicle now.
Yeah,
You
stop
can
pacing.
stop pacing and look for the fascicle there. Just gain up tendril once. Yeah, that's what I'm saying. Yeah, that is.
Gain your tendril.
The tendril you gain. Yeah, so the injury was good. Yeah, yeah, maybe, you know, I mean, because we are a little biased, we are seeing it, but it's not so clear. But anyway, so now you tell us the, so tell us the impedance. Huh. Yeah, so I think this is okay. It is just that, you know, my ring, this should be definitely less than 2. Yeah. Okay, yeah, it's about 2. That's okay. That's at 1. That's at 1. That's at 1.
Pulse width.
0.5. So that's actually good.
That's good.
Now, you know, I have a question. See, show the fluoro. I think the ring is in the sheath.
Yes.
Okay, can I go 1 millimeter?
No.
No?
You're perfect. If you want to do a septogram, you can, but I won't go.
No, I don't want to
further.
do septogram. No.
It's okay. If you want to test the ring, you can, but I'll pull the sheet back first.
No, that's okay. But I just was thinking, you are not seeing. Okay, stop pacing. I'll tell you why I was telling. You see, usually, when this is a right bundle or an arrow, I usually get that potential. If you believe that there's a potential, I will not screw. But if I drill one more time, maybe the potential come out.
You can, but if you want to do something like that, I would just extend the helix a bit.
Okay, I'll do that. Huh? That's
I would
that's
just
the
extend the helix,
safe
give you that
compromise
1
between me and you.
millimeter. Yeah.
I wanted push, but you helix. So I think helix is
I'm
okay.
not as brave as you.
Please, you only have given us the confidence. Okay.
Just
So
extend the helix. You're there already. I don't think this is a perfect position. ECGs looks good.
That's okay, no? That's okay. Okay, can you just you know, show the?
Just extend your helix, couple of turns. Yeah. Yeah, I think you're there already. Yep. Stop. Probably.
You're done?
Yep.
Done. Actually, I gave enough turns here. Huh. I think you're done. Okay, you're done.
Okay.
Okay, so
Stop pacing.
what we have not checked is the ring, right? Yeah, without doing anything, you just see whether the ring captures.
Bipolar.
No, just the unipole ring.
Okay, sure. You may not, because the ring is still in the sheath.
Okay, see now this is tip. Is it coming? Right?
Pace, please.
See, so this is the tip. Huh? Okay, so now this is the ring. Oh, so the ring is not captured because it's inside the sheath, right? Yeah. So now, so that simply means it has not come out of the sheath.
Yeah, definitely not. You can see
So
that.
so what do we do?
So if you want to test bipolar, pull the stylet back, pull the sheath back, unflex, push your lead forward, like what you're trying to slit,
right.
so that the ring is
Okay, so now we are not pushing it anymore.
Yeah,
that we are certain.
We are very happy with this position
Okay,
already.
so now again I go back to the things here, or maybe I can just.
You don't even need to. You can disconnect that.
Yeah,
Make sure your stylet is back.
Is back here. Fluoro.
So now fluoro, you can go AP. Fluoro AP. Fluoro AP, please. Can? Okay, now you can fluoro. You can flush your sheath a bit now, so that you can get rid of all the contrast. Because we're going to test the ring in a little while.
It is just that, for me the concern was the ring has not gone in. That's all. But
not necessary, because your septum may not be that thick.
Not necessary. And then you do not really insist for unipolar ring capture, right?
I will test it once I pull back out.
And
I
then
will definitely test.
And if it doesn't capture?
Typically it would, but the threshold may be a bit higher.
Okay, fine.
That is true.
Right, so what are we doing?
So hold on to your lead,
Yes.
push your lead forward and pull your sheath backwards and unflex your sheath at the same time.
Fair.
Almost like you're
Okay,
going to
now fluoro.
slit the
So
sheath.
fluoro. You see, I am actually pushing
Push
the,
your lead forward.
And then at the same time, I am
Pull
just...
your sheath back. Push your lead forward.
Yes.
Pull sheath back and unflex.
So I'm unflexing
Okay,
here.
your lead needs to go forward a bit more. Lead, go forward.
Yes.
Okay, now keep pulling back your sheath.
Yes.
His pro back, come back, unflex. Keep pushing your lead forward. Yeah. Can, yeah, keep pulling your his pro back. Keep pulling your his pro back. Pulling and unflex. Unflex his pro. Unflex. Unflex. You're flexing. Unflex it. Unflex.
So this is unflex now. This is unflex only. Okay.
Pull your his pro back. Pull his pro back.
I'm doing it.
Yeah, good. Some more. Some more. Some more. Some more. Some more. Okay. Unflex his pro. Flexing there.
Yeah. So no, this is the unflex. This completely unflexed.
Okay. Good.
Yeah. So that is the curve what we have made. I think it is remaining
Okay,
there.
that's good. That's good. It's okay. Now you can try to pace bipolar.
Yes.
LAO.
Fluoro, I think the stability. Show me again, fluoro. Yeah, I think this is good stability there.
Yep.
Yeah.
LAO.
So now this is a unipole again. Unipole injury is maintaining. Okay, pace. This is unipole. Okay, that's fine. Now you go to the bipole. Yes, so the injury is great. Okay, so
LVAT and then the QRS duration.
See this, what is that one, the PVCs? I think there's something to do with the PVCs from the lead or the sheet.
Lead. You got too much of a coil
Yeah,
there.
yeah.
You see the back,
So
the
now
coil
what is
is
happening
whacking
here?
against the lead.
What is happening? Yeah. So you know what? Can you just maybe?
So what
just
you can do is AP fluoro again, straighten out your lead so it doesn't
Yeah.
give
So
you that.
maybe those
yeah.
PVC will not come. Fluoro.
So fluoro, AP,
Ullas, is
fluoro.
that sleeve
So
back
pull
to the
back
maximum?
your
Because
lead,
the distance seems
pull
to be
back
less.
your sheath and lead together as a unit. Pull back, yeah. Some more, little bit. Not too much. That's good. That's good. That's good. That's a good position. Now you won't get PVC.
No, there are. I just was wondering, are they paste beads?
Now you actually have an odor capture
Yes.
because there's no R prime now
That's
in
correct.
V1.
So node is captured. Yes.
Yes. Okay.
Yeah. At the lower output, you get the QR now. Yeah. Yeah. So,
there you go.
yeah.
There's the change. You lose an odor there.
Yeah.
This is what only the cathodal capture, is it? This.
Yeah. So presently, it is the tip capture.
Okay.
We lost the ring capture by around 3.
Okay.
Yeah.
Yeah. Go. Yeah, keep going.
No, it lost. So
Yep.
1.5 around. It is at 0.5. 0.5. Okay,
That's
fair.
fine.
Okay, I would like to see at the unipole one more time 12 lead and show the measurements. LVAT, etc. Unipole pace. Yeah. Okay. So now in the bipole, I think you have a unipole. Okay.
Not even pacing.
Okay,
You're not even
bipole, just
pacing
check
right.
the. Potential is there? That has to be shown to. Yeah, can you focus that to the audience there? It can't be. It's okay. You know what? Actually, on the PSA, yeah, you can just show it to them or something. You can focus or whatever. May not be, huh?
It may not be a potential.
Okay, leave it then. It
May not be a potential.
Okay. All right, so now
there's a slight sharp
suggestion
little one
because we are biased. That's why we are seeing it. Okay, otherwise it's not so very clear. And so now this is at this stage. Are you doing any more parameters testing?
But you have to gain it up. But typically,
Ring morphology you can see.
your
This is the
system will see
pace.
better.
Pace. This is the tip. Okay, now he goes to the ring. I think. Go to the ring. Yeah, so that's what it is. Yeah, so that's the ring.
The
Go back
ring
to
is
the
terrible.
tip. And that's the tip.
Check the
yeah, that's the
threshold,
tip.
please.
All right.
Yeah, this is good.
Yeah, no. We changed the ring to the tip. We did. Okay, we're done.
Yeah.
So now, so you should wish me luck again here because
Yeah.
I need to be slitting it, right?
Sure.
That is also kind of a really an
Yeah.
adventure only.
You can disconnect firstly.
Yeah.
Disconnect your his pro first.
Yes.
Disconnect your his pro from your. There. You can disconnect. So when you pull back, you don't have to contend with that.
Yes.
Okay. You don't have to contend with that. Make sure your stylet is pulled back. Yeah. It's okay. You can keep that. That's fine. It's okay. Don't worry. Your assistant will. will get hold the fat one.
Yes.
The fat one there.
Yeah. So now before that, fluoro. See, it has remained very well. Okay.
Yes.
Stability is no issue.
Yep.
And though completely flexed, it is still completely unflexed. Still, it is having some curve.
Yeah.
I think that is a curve we made actually.
Very good.
Right.
Yes.
Okay. So now we are going in this.
Yep. So put it underneath and go through the. Yep.
So what he says is, yeah.
So the blade will have to point
Yeah.
towards the gap there. You see, there's a blade there, right? Point it towards the gap. The gap. No. Yeah. Your hand, the handle go up. This end go up. Yes, that's right.
All right.
Now fluoro.
Achha, now what you are saying is to gain some more length, you can actually hemostasis
correct.
wall could be cut.
So you see your left thumb.
Yes.
Your left thumb. You see your left thumb, not your right. Your left thumb.
Yes, this is the left thumb.
Hold your lead. Push your lead against the handle. Not the other way. Against the handle. So push it like that. So now your slitter can go forward.
Yeah.
Your lead won't go forward. Huh?
Yeah, so
Fluoro.
I'm holding this lead here
Correct.
on the body of the handle.
And then just push
Okay,
your
fluoro there?
slitter forward. So
Okay.
your lead is not going to go forward like that, right? Just slice a bit. That's right. So now you're good. Now left thumb, remove. Lead goes into
Under the right thumb.
under right thumb. Wait. There is also a little plastic lead holder there. You got to make sure the lead goes into that lead holder. Okay, yeah, you can go into the right thumb. Make sure the lead comes out. Huh? Okay.
So show that.
Okay. Now we can start slitting. Yeah, just pull. Beautiful. Yep.
Okay, that's the air got sucked there. That's the usual story. Doesn't matter. Doesn't matter.
Fluoro. Check position. Fluoro, please. Fluoro.
Yeah, that's the air.
Fluoro.
It's okay. It's
Yeah,
okay.
yeah. Pull
And there's
the
enough of slack there. Okay, now you remove.
Fluoro. BP is okay, right?
Yeah. So I think we will wait for a while before we suck the air out. No, you push the. You did that. All that. Okay. Now we push the. Leave the hand. Leave the hand. Which is the one?
Your fluoro still on,
fluoro?
right? Yeah.
It's okay.
BP
okay.
is good.
It's okay. Huh? Okay, fluoro. You see now, that's fine. Now you see, I am going to be making a little more curve here, okay?
Sure.
See, this should be enough here, huh?
It's a bit too much.
Okay.
RAO?
No, by the time we connect, etc., it should be all right. Okay. So we're done here?
Yes, we're done.
Okay, so
I'm
Dr.
happy with
Tan,
this. I'm happy.
Dr. Tan, it may not have been as great as what you could have
really
achieved.
good.
Yeah.
It's
Achha,
pretty
I think Karthikeya and someone can comment on Dr. Tan's performance, please.
I didn't do anything. I didn't do anything.
They are there with us? Karthikeya or someone?
Yeah, hi, Ullas.
Hi, Saxena sir.
Yeah, so I was saying that given the chances of air being sucked in,
Yes.
Isn't it better to tear the outer sheath first and then take out the inner sheath? Because the chances of having to go in again are very less.
Yeah, absolutely correct.
The
Just slit
chances
the
of
outer
air
one
embolism
instead of
are
the
more.
inner. Correct. Usually we use a safe sheath.
Yeah, so that's the.
So
safe sheath
I don't have to contend with that issue.
Yeah, but here I know we have a problem.
Yeah.
Achha, by the way, you see what happens is I cannot just take that sheath first because we lose the entire control on this. And however much massive this air looks, it's very rare that we had to enter in to suck the air out.
Yes.
Okay, so
Typically
it
it's okay, just
it looks a little
oxygen should be
frightening
okay.
on the fluoro. But then it's okay. It is there. Pressures are still maintained. I'm not too keen on taking it out. 120, 70 is the pressure. Yes.
That's impressive.
Yeah, oxygen saturation also could be okay. Just check. What is it? It's 99. So
It's okay. Maybe we can anchor and then just do the
Yeah.
alien and just close
Yes.
up really, you know.
So gentlemen, you will do? Okay, all right. So Saxena sir, any more questions, remarks?
Great case, enjoyed.
Oh, great, sir. All right, okay.
Okay.
So again, thank you very much.
Thank you
Yeah,
very
okay,
much.
okay,
Thank you,
okay,
thank
yeah.
you, thank you.
So you know what, there, you know, the next speaker can start the lecture. So I think you think
Now let's get back to our session. We are fortunate to welcome Dr. Avinash Verma, Senior Consultant Cardiology, Fortis Memorial Research Institute, Gurugram, to discuss about limitations of lumenless lead for conduction system pacing. The moderator for this session will be Dr. Joseph Theodore, Interventional Cardiologist and Electrophysiologist, Kaveri Hospital, Trichy.
I would like to thank Dr. Ullas for providing me this opportunity. So to begin with, this talk was given to me, conduction system pacing with, sorry, the heading is different. So the talk is limitations of 3830 lead. Now, this is my disclosure. I have almost exclusively done 3830 leads. It's around 280 plus cases. Abbott, I have only 3 case experience. And that was also in the beginning, right at the beginning when it was not even launched. So with the current technique which Dr. Tan has said, I'm pretty sure that I'll go back and try more. It looks pretty robust system and it may work. Biotronic, I have done around 10 cases with reasonably good success rate, and Boston Scientific SPSS just recently started around 6 cases. So my experience is pretty much with 3830. Now 3830 lead is basically a fixed helix lead, and it's just the lead body that you have to use, and it is without stylet. So without stylet, fixed helix. Now this thing was already tested, fixed helix. The first case, in fact, that was done for distal His bundle pacing was also a fixed helix screw lead that was used. Now Select Secure 3830 with CS315 was an early entrant. That's why we have so much data on this. So to speak about the limitations and the shortcomings of this, it's a pretty reasonable database that we have and pretty reasonable experience that we have that we can talk about this. One thing is pretty sure, why most of the operators have this lead as their go-to lead is the reasonably high success rate that almost all operators can achieve. So right from 80% up to 95% and more, which Dr. Huang's data shows, you can achieve that kind of success rate using this lead system. There are some pros and some cons of this system which helps us to have this high success rate. Now, having a high success rate is very important, particularly in context, in our context of India, where a patient has to pay for the lead. Now, suppose if we take a system of whose success rate we are unsure of, and you do the case and you don't achieve that, and if your therapy relies on your success, then you'll end up using one more stylet or one more lead, and the overall cost escalates. So what reasonable success rate that you can achieve with a system, I would say that stick to it. You can experiment, but provided that you have a backup so that your patient doesn't suffer because of experimentation and trying out new things. So stylet driven is also fine. Different stylet drivens are also fine. Every system has their pros and cons. But achieving proficiency in any 1 or 2 system is, I think, a much better way to go forward rather than trying all 4 systems. So Select Secure 3830, there are pros and cons. It is the thinnest lead, 4.1 French. Isodiametric screw and body, so that is why it's so easy to progress. It goes like cheese in a hot knife in a butter. And I have done hypertrophic cardiomyopathy, thick septums 20 mm septums, and it goes right across without any trouble. It's a sturdy, no moving part, no matter how many times you reposition. Till now, in all those cases, just one lead I had to discard because the screw was just not usable. But otherwise, every time, lead was never an issue. It's easier to clean and reposition because there's no retraction mechanism. So generally, there's no moving mechanical part, so it's easy to clean up. C315 is a double plane curve, and we all know that how important the secondary or the septal curve is. So for example, in Agilis His Pro, where we don't have it to begin with, we put that curve. So it's very important. And this lead started with that septal curve. So there are also the cons associated with this lead and this system. Again, what is the pro is also the con. It's thin, so it's easy, less traumatic. Even if you do 2 or 3 times or 4 times in a septum, you don't feel bad because it's so thin. It's like 1 millimeter, 1.3 millimeter lead. So it doesn't do much harm to the septum. As opposed to a 6 French lead or a thick lead with a cuff outside, it might do more damage, like the photo that Dr. Tan showed, that it can literally create craters inside the septum. So that is the pro, that it is very thin. But the con is also that it is so thin, it's like a string. It's a piece of string. So it doesn't have any inherent support. So the lead, alone the lead will not give you any support or any help. Isodiametric screw and body is very easy for progression. So even when it's inside and the momentum is not with you, and you want to just go bit by bit, you can do that very easily because the screw can pull the lead body along with it. There's no extra resistance. But when you don't have the isodiametric lead body design, your small screw is supposed to pull a much bulkier sheath. For which there is not much grip in the front of the lead. So it's your push which is also helping you. So along with the pull, it's the push also which is helping you. But with the isodiametric screw and body, both kind of helps you to get through the septum. So just by lead rotation, you'll be able to move. And the push itself is not so much required. And it is also not possible to push the 3830 lead. Like I told, it's so flimsy that your push will not do any good. So it's basically the rotation which helps, as compared to the Stylet-driven lead where your push can actually help. So there's no one-to-one transmission. I mean, I should say there's no 2:1 or 3:1 torque transmission also. It's so difficult to gauge. It's easy to say that give half a turn or 1 turn, but it's so difficult to happen in real time. It doesn't happen so easily. It's more often than not you give 2 or 3 turns and you hope that once it turns. More often than not. But yeah, sometimes when your support is very good and the sheath is very perpendicular and everything is all right, then 1:1 torque transmission can happen. But this is very, very commonly that we see. It is totally dependent on the sheath for support. It is also totally dependent on sheath for the torque transmission. So your sheath is your Achilles heel. Your lead is the good part, but sheath is the Achilles heel. It's a non-steroid eluting tip. So there is a powder which is there in front of the lead tip. So there is a steroid dipped or there is a steroid powder residue which is there on the tip, but as soon as you put it in the blood, it's gone. So we have, in spite of this, we have reasonably good data, long-term data, up to 5 years data, that even in our patient, we are doing it since last 3 years, left bundle pacing. And the chronic late rise in thresholds is something which we have not observed. And that's the globally, the data which says that this steroid elution is not a big factor. And C315 is a fixed curve. At least in India, the sheath which we have, most of the centers we are using this fixed curve sheath. Now, having said that, this fixed curve is again reshapeable. So in many cases where we find that either the sheath is too big or too small, we can reshape the sheath. The shape retention is okay. For first few minutes or first 5 minutes, it does retain the shape. After that, you have to reshape it again. The problem is that it offers very less support. It's good for a healthy heart, non-dilated, where there's no fibrosis, you don't need extra push, extra support. But wherever the case gets tougher, you start having more and more problem. So in comparison, this slide was also shown by Dr. Tan. The delivery mechanism in both Biotronic and Abbott is much more sturdy, and SPSS. All three sheaths are much more sturdier, so they give you much better support, particularly in challenging cases where we are dealing with either fibrosed septum or dilated anatomies, where you need better support. As far as pacing lead is concerned, lead body design, it's a personal preference which lead body design you prefer, isodiametric versus non-isodiametric. I personally will prefer a Stylet-driven isodiametric fixed screw. But it's a perfect lead, it's still not made. Stylet-driven lead is definitely a very good thing to have. So that's one thing which 3830 sorely misses. There's no Stylet support which is there. Fixation mechanism is rotation to the lead body as compared to in other mechanisms where both the rotation to the lead body and extension of the helix is a possibility. Now, one thing we all must, with all these talks, that everything is repurposed. Even 3830 was not made for left bundle. It was made for his bundle and selective site pacing. Of that selective site pacing, left bundle was not thought of when it was made. But Dr. Huang found it very useful, and that's how left bundle pacing started. But all the leads are repurposed leads, except the Biotronic and Boston Scientific, the SPSS and the Biotronic sheets which have come up, they have been purpose made for his bundle and left bundle pacing. But it's just the sheath, not the lead. So lead still is a repurpose used of that lead. And in long term, sheath is not the Achilles heel, it's the lead, because like Dr. Tan was showing, there's that kink, it moves like this. It has never been tested inside a septum, in a thick septum, that moving portion, how will it behave in a long term? So I think sooner or later we'll have that data. So what are the challenges with the 3830 system? So these are the sheath-related challenges which I have faced. Outer 7 French sheath has to be used. Sometimes I find this, but I'll show you one case where I find this 7 French sheath to be too snug, that even after this 7 French sheath, I find that maneuvering, lot of torque is getting wasted just on getting rid of the tightness of the difficult cases which we feel in the SVC area. In those cases, I have also used 8 French sheath, just to have a free movement of the C315 sheath. And why this free movement of C315 sheath is important? Because this sheath is very prone for kinks. It's a very flimsy sheath. I mean, you all must have whipped it like this. Even if you take it out and you're not gentle with it, you can kink the sheath while removing it from the pack. So it's so finicky of getting kinked. And once, if it's a small kink while taking out or by banging here and there, it's fine. But if while rotating you over torque and it's a rotational kink, then your lead gets stuck. You cannot do counterclock and move the lead simultaneously. Your lead will not move. So you will feel that you have stuck a wall of fibrosis, but actually it's not a wall of fibrosis that is not allowing the lead to move, it's your kink. So go up and check the sheath again, and if there is a kink. So of all these cases, I would say a fair amount of time, 5-10 times, I have to change the sheath or take the other sheath because of the kink. Lead only once. So sheath itself is a very delicate sheath. Insufficient torque. The lead, there's a limit to how much torque you can, to the sheath, there's a limit to how much torque you can give. If you give beyond that, it will kink. Friction in the sheath. Again, if you don't flush your system quite well, don't use heparinase saline, even just a very small clot can cause a very fair amount or significant amount of friction in the sheath. You cannot map with the sheath. So that is again one drawback of the sheath, that every time you have to keep the lead inside the sheath, and then only you can map, otherwise you cannot map. A difficulty in being mid-septal due to short reach. So this is another thing which I have found with the C315 sheath lacking, is that the medial curve, the medial septal curve which is there, it's very small. It's just 1 centimeter or 1.5 centimeter curve, as compared to the curve which we saw Dr. Tan made today with the other sheath. So many times, particularly in dilated heart, that small curve gives you a very limited reach to the septum. And what happens is, to reach there, what you have to do, you have to extend the lead or push the lead towards the septum so that your lead can grip the septum, and you give 1 or 2 turns so the lead takes a bite, and then you railroad the sheath towards the septum, and then you oppose it. So the reach of this sheath is a big limitation. So that's the technique which most of us used. We keep at least 1 centimeter of the lead outside the sheath to have a better reach in case of dilated hearts. Otherwise, what will happen if you do counterclock to abut to the septum, it will take the sheath down rather than mid-septal. So difficulty in mid-septal position due to short reach, and the way to avoid it is to extend the lead body beyond the sheath. It is difficult, it is problematic also, because then you can catch hold of tendony or the valve or muscle tissue. But yeah, that's the drawback of this system. So curve is small for dilated ventricle. Even the primary curve is small for a dilated ventricle, and many times you need to give a much bigger curve or use a sheath-in-sheath support just to reach the septum. So these are the limitation of the sheath, which is the C315 sheath. So this case, for example, which I'm showing you, where I find that it's completely occluded vein. So we did CSP in this case, and you see as I give dye, there's some dissection there. Now we didn't abandon this position. If you can see, okay, I'm not shown here, but we passed a Teramo from there, and we then did a venoplasty, and this is the same case. Finally, the lead is there, and the sheath is there. I was able to manipulate the sheath there. Now, another thing which you will notice here is that how the sheath is dancing. It's not a stable sheath because it's so flimsy. Even some valve motion will move it. Even cardiac motion will be able to move it. So the support itself, you'll have to do multiple positions to have a very sturdy support. As compared to if you use the other stiffer sheaths like a Biotronic sheath or a Agilis Hespro sheath, it gives you much better support. So this dancing of the sheath which we see here, this will never be seen with the other sheaths. So that is another one point. So 7 French is too tight for here, because the C315 sheath anyways doesn't have very good torque transferability. So I use 8 French in these cases. And yeah, I mean, if this is the kind of support you have, it's not going to happen. So you must have better support. So this is another problem which I was talking about, that it's slightly below. I mean, it's a similar kind of place where we did the first case. But if you want to have a better, so over here, if you counterclock this sheath, it will start pointing downwards. So your torque transmission or your abutting. Now remember, this lead which is there, you cannot have a better contact in this lead without the help of sheath. So your sheath is your primary help for better contact and better penetration force, lead tip pressure. Now, if the sheath is not perfectly perpendicular to the septum, you will not be having this very good tip pressure or very good tip support. Like for example here, your tip is not absolutely perpendicular. And mind you, I'm not giving a very good counterclockwise torque as of now. If I give counterclockwise torque too much here, what will happen is that the sheath will start buckling down. Now, if suppose this was a deflectable sheath, I could have deflected it and put it somewhere here. And over there, the torque transmission would have been much better, and it would not have slided down. So most of the times, if suppose the position is suboptimal, we either use the initial buried portion of the lead as a railroad to guide the sheath or abut the sheath very well to the septum, and then use the counterclockwise turn.
This is another problem that we have. Particularly, I use RAO view for screw-in for the same reason sometimes, because the sheath buckling is a problem. Now, if you see C315 sheath, you will see there's a slight backward curve of that sheath, very slight backward curve. So what happens is that in RAO view, if you're not handling the sheath very carefully, and if the sheath goes in slightly more, your sheath immediately buckles and it starts pointing backwards. From there on, the lead is not going to go in. So most of the times what we do is we pull back and counterclock rather than push and counterclock. As compared to in our Biotronic or SPSS sheath, where you can just counterclock and you don't have to pull back. Rather, you can slightly push because there is no backward curve. So the sheath buckling, so keeping the sheath pulled back is very important for this, so that it doesn't happen. Another problem, missing the left bundle by starting too low or too high. Again, this is a problem of a fixed curve sheath. You can get rid of it by reshaping the sheath. So reshaping is a pretty standard thing, and it's actually not a limitation. It's quite doable, and it retains the tip well, the memory well. Now, there are some lead-related complications. So thin septum, it causes frequent perforations. So what I found is that 3830 is one lead which is very easy to go through and very easy to go through and through. So it's easy to go in the septum, but it's also easy to pierce out of the septum because it's isodiametric. Just the little bit tiny screw out and it will go out. As compared to the other leads which are non-isodiametric, even if a tiny bit of screw goes out, it won't pull the entire, or it cannot pull the entire lead out. So the frequent perforations I find is problematic, particularly if you have a thin septum. So we have a cutoff of anything less than 7. We don't do conduction system pacing. It's very difficult to guarantee an oblique placement. You can try oblique placement, but it's very difficult. Lead getting displaced due to less anchoring. Or again, this is a case for oblique placement. As you can see that if this lead, because it's so flimsy, it's very prone for cardiac motion. So if you are not away from the valves and away from the other things, they can cause the lead body to move a lot as compared to other bulky leads. So this can be troublesome in a very thin septum. Usually otherwise it's not a problem. But on the contrary, if you are away from the valve tissue and moving parts of the moving cardiac parts, and you are bang in the septum and there's nothing nearby, this lead will hold even if slight amount of tissue is there because it has literally no weight. CHB during implant, so that's again if you're very close to, so if you start high, then you're going to have around 20, that's what there in literature, 20 to 30% risk of CHB in case of LBBB, pre-existing LBBB. Otherwise, it's not a problem. RBBB during implant, we saw it today also. So that's not particularly lead related, but it's just the shape of the sheath. This lead doesn't have much feedback. In fact, I would say it's like you don't feel it going in. There's no feedback. It has very less torque transfer. Again, it's not one-to-one. So initially we give lot of turns, and that's why it's said that you try to give lot of turns in beginning to have that momentum to take your lead through. And usually it works. The one problem with that approach is that if you are giving turns quickly and there is no live EGM, like we saw today in both the cases how helpful the live EGM is, even while pacing, while sensing. But with this lead, you cannot have a live EGM. So at every point of time, you have to come back and check. So that was a very big drawback. So that's why we rely on the template beats. In fact, in the first case also, we saw very good template beats. And in fact, a lot of cases which were shown today, we see that we saw a lot of template beats. So we rely on template beats in this rather than the live EGM feature and the live pacing feature. But that is one feature which is sorely missed in this system. And you cannot pace and screw. So that is again the same feature which is not there in this lead. So lead body and the sheath has very less torque transmission. So if you are in a difficult case and you're finding lot of fibrosis, you'll find that the lead and the sheath both are swaying like this.
even with your best of positioning, it's swaying like this. So I find that it doesn't give you that better or that good support. It's much better to have, if you are dealing with these cases, it's much better to have a Stylet-driven, stiffer support sheath. This was the lead kink that Dr. Tan was talking about. And you see that half of the lead is in, and it's just till that portion in where the buckling happens. So you can see here also it's buckling, and you can see here also. It's just buckling there. So till now, the data is, I mean, all our patients are doing okay. Nobody has come up with any problem with this buckling. But yeah, it doesn't give you a very confident feeling that when this happens. Then there are procedure-related challenges, lead getting stuck. So far till now, of all the around 280 plus cases, no Medtronic lead has got stuck with us. It has always come back. I mean, in some cases, we have to apply considerable force. In one case, the lead got damaged. But otherwise, it's uneventful most of the time. Bits of tissue always get stuck. I mean, it's like every time it comes out, it's with a biopsy. And every time I use either the vein lifter, the yellow color vein lifter tool, or the needle to thread out those bits and pieces. So lead cleaning is required. Torque retention of over-torqued and alpha loop, this is a big problem. Like I said, there's no one-to-one torque transmission. So you don't know how much torque you have given and how much torque the lead has received. And suppose you just slit the sheath without slacking back that torque. What happens is that you end up with an alpha loop. And this has happened quite few number of times. And that's how we learned that you have to remove all the extra torque from the system. Otherwise, alpha loop is very common. This lead doesn't have too much of lead body. So any amount of extra torque will cause alpha loop. And the way you get rid of alpha loop, because the usual tendency is that if there is any extra loop, you pull back. But in alpha loop, you don't pull back, you counterclock, because it's the excess torque issue and not the extra lead body issue. So if you pull the lead, then entire thing will come out. It's rather anti-clock. So it's also difficult to increase loop, like the cases which I saw where there was so much fibrosis to begin with. If you have not done your loop maneuvering before, after you have slit the sheath, there's no way you can increase the loop. If you're lucky and if everything is like express highway there, then you can increase it. But if there is any obstruction there or some curve in the innominate vein, then your loop will not be increased. As compared to a Stylet-driven lead where you can just put the Stylet and increase the loop. So that possibility is not there with this lead. Variations in anatomy. So I think this we have already covered. Right side we cannot do. So right side is challenging. So you have repurpose and reshape the lead for the right side. Similarly, you have to use sheath technique for increasing the reach, or you have to just push the lead body out of the sheath to get that extra reach. This is the right side curve which you have to put. So these are additional steps which are needed. I think both the Boston Scientific, at least Boston Scientific has the right-sided SPSS sheath. I have personally not used it, but it's there. So the conclusion is that CSP with 3830 is easy and effective. It's probably the most amount of data that we have, and with most certainty we can say that if we take a patient, that will be this much % chance of success, because of the huge amount of data that we have. Stiffness of the system is lacking, both in lead as well as in the sheath, and is of issue in difficult anatomies. In routine cases, I would say anybody with a normal functioning heart, it's not a problem. In most of the dilated cardiomyopathies also, it's not a problem. In ischemic cardiomyopathies and in dilated cardiomyopathies with scarring, it's a problem. And in massively dilated hearts, it's a problem. It's more prone to kink and need to be handled carefully. The sheath particularly, it's very prone for kinking. It has to be handled carefully. 1:1 torque transferability is lacking. So you end up either giving too much torque or too less torque. It can cause alpha loops. So you have to be mindful of the torque that you are giving. best studied CSP system with large amount of safety and long-term data. So that is one plus point for this, and I think rest of the systems will surely catch up with that. A combination of a fixed screw lead with simple mechanism with Stylet might be the better solution for developing newer leads. And I think sooner or later, everybody will move towards it. Thank you.
Great talk. Some of the disadvantages which you mentioned, they exist in other systems also. So for example, complete head block. I mean, any sheath can damage the right bundle for that matter. So, but excellent talk. Thank you.
Yeah. Thank you, sir.
Dr. Tan, I think what he was concluding was to replicate a system which we are familiar with, and that is Stylet driven and continuously monitorable system, which is as deflectable, as pre-shapeable, as I think Agilis His Pro is kind of a role model here. It is just that I would be very sad, these abort people will just fall on to take a retro step and then, I mean, it's like a copycat of, copycats can never succeed. It is just that, I really wish they take this forward, because this is absolutely the tool what we are looking forward to. I mean, the way he shaped, and it retained the shape. It retained the shape, for example, I took almost 3 times the time what he had taken, but at the end of it, the primary curve, it retained. It retained.
So Avinash, you said at one point that your ideal lead will be Stylet driven and isodiametric fixed screw.
Yeah.
So Boston have one such fine line lead,
Fine line lead.
So have you used that?
Yes, sir. I have just used in 2 cases, but I must say that I used it mix and match. So with a Biotronic sheath and because at that time Boston Scientific didn't have SPSS in India when I used that.
Should be good. You cannot pace through that lead because when you
and the
put
anode is
Stylet
too
in that,
far. Anode is like way outside.
And then when you place a Stylet, like you are pacing from the Stylet, you cannot pace in that lead because that's a insulated.
Yeah, there's another problem. The screw pitch is too dense.
No, it should be fine. You see, the thing is that you know that unipolar leads have the best safety record for the long term because they are single coil design and they are more flexible. So their longevity, it's not in question. In fact, this coaxial design is actually not very suitable for multiple flexions, but the single coil design is better for that longevity.
I think we all agree here that the conduction system pacing tools need a significant evolution in the technology. But if you are a TAN, you give him whatever the tool, he will shape and then push it. You see, you go back to the days, we have inserted several of the ICD leads. I repeat, the ICD leads with shaping, and then we have the data, about 5 or 6 patients, desperate. It actually worked as a CSP for a very wide QRS, abnormal QRS, and it's a dual chamber ICD working like a CRTD. So where are we? I mean, excuse me? Yeah, but then we went to adopt that Biotronic technology. Okay, it's a single lead. Single lead, you are at the, I mean, there we are, as long as ultimately the leadless technology will overwhelm us, this technology should come up. And ultimately, I'm sure, there's going to be small chips injected here. Done.
Is actually bringing another lead which has a fixed screw, non-retractable, and a Stylet. That is what I was talking about. So that is still not in the market. Boston.
That is in the
No, that has an extendable retractable screw. This
Fine line is a
lead has
mannitol
been
tipped
in
lead.
Mannitol tip. It's a sugar coated or mannitol whatever tipped. When you insert it, you have to wait for 5 minutes. The mannitol dissolves and the screw gets exposed. It's a fixed screw, and that lead has been used for a long time. They had to stop selling it, but again, we bring it back.
Ladies and gentlemen, now I'm presenting the brightest star of Triplum family, Mr. Mohammed Akram, the lead supporter, the sheath supporter, the helix supporter, and the most importantly, the generator supporter of conduction system pacing program of our institute. The moderating of his session will be his student, his master, and our favorite Dr. Ullas M. Pandurangi, Triplum. We invite Mr. Mohammed Akram, a cardiac technologist of Triplum.
So, good evening, everyone. So, I am Mohammed Akram, a cardiac technologist from the Arrhythmia Heart Failure Academy, the Madras Medical Mission, Department of Cardiac EP and Pacing. So, first of all, I'd like to thank my mentor, Dr. Ullas M. Pandurangi, for his support and making me to stand here. So, today's my presentation is Stylet-driven leads, prevention of septal perforation and helix retraction. So we all know that conduction system pacing is the most physiological way of pacing. And there are there is his bundle pacing. And we all know his bundle pacing achieves a narrow QRS, but his bundle pacing prone to high capture thresholds and has sensing issues and lead stability issues. So there we had an alternative to his bundle pacing, that is left bundle branch area pacing, where it overcomes the limitations of his bundle pacing and also has a lower capture thresholds. So when we do left bundle area pacing, one of the most possible complications of left bundle area pacing is septal perforation. And also if you are using Stylet-driven lead, the helix retraction is a possibility here. So when it comes to septal perforation, it is essentially during the implant, we have to be very careful to recognize this perforation to avoid long-term thromboembolic complications, and has to be immediately managed by repositioning the lead at a different site. So this is one of the paper which studies the perforation and also has some predictors of septal perforation during left bundle area pacing from Dr. Shanmugasundaram, where we can see it shows there is like this unfiltered unipolar electrograms showing a positive current of injury when it is within the myocardium, where it is like there we can see there is a complete perforation into the LV cavity, where we can see this type 1, that is QS pattern, and there is a partial type of perforation, that is where we can have this RS pattern, and where we can the predictors of septal perforation are the unipolar pacing impedance like less than 450 ohms and sudden drop in amplitude of current of injury. And when it comes to the unfiltered unipolar electrograms, where we have to look for there is no current of injury, or there is two types, that is type 1, there is a QS pattern or an RS pattern. And also during unipolar pacing, there is a loss of capture during the unipolar pacing and also sudden drop in R waves. So these are the things we have to be looking during the implant to look for the perforation. And when it comes to the thing that the tip of the lead is connected to the negative part of the amplifier, where we can they had done it is the positive part, the amplifier is connected to the Wilson central terminal. So this is our experience of Stylet-driven leads, where we had like the vendors from Abbott and Biotronic, and also we had recently done several cases of Boston, where we done left bundle area pacing of 40 patients. There we had perforations of 3 number of patients, so the percentage is 7.6%, and also in the literature where we can able to see there is less than 1% to 14% which is reported in the literature. So I'll just go to the our examples. This is like case 1 of a 68-year-old male, diabetes mellitus, systemic hypertension, symptomatic degenerative high-grade AV block, with a narrow QRS escape rhythm, good biventricular function, EF of 65%. So this is the basal ECG, basal during the implant, where we can see the patient is like 1:1 with a long PR, where the documented evidence of Holter showing evidence of an AV block during the Holter. So this is during the screwing, where we can see a change in morphology, where we can able to see a kind of a small RSR to a monophasic R, where we can see in the lead V1. And here, where we can see there is kind of this monophasic R shown in V1, where we were able to see the current of injury. Here, from this, there is a sudden drop in the current of injury where we can able to appreciate it. So there is a drop in current of injury. Ideally, the unipolar tip current of injury should be higher than the ring current of injury. A current of injury higher at the ring suggests that the lead tip has entered the LV cavity. So where we can able to appreciate here, where this side where we have a ring showing a higher current of injury than the tip on the right side of the screen. So this is when the lead has entered into the LV cavity. So there is no current of injury seen in my unfiltered electrogram, and then when it is like retracted back to the septum, there is the reappearance of current of injury is noted. So where we can able to appreciate it. So this is an ideal positioning of the lead, where we can able to demonstrate in the ring to tip, the ring shows a W pattern, where the tip shows a QR pattern in V1. So this is like after lead repositioning, and this is our final result. So this is our another case. The first case we had with Biotronics Solia 60 lead with a Selectra sheath. So this is a Boston lead, Ingevity lead with a SSPC3 sheath, where we had done a Boston conduction system pacing. This is a case of a diabetes mellitus, systemic hypertension, recurrent episodes of syncope, symptomatic 6 sinus disease, mild LV systolic dysfunction. So this is the basal ECG, and the Holter shows a pause of a sinus pause of 3 seconds noted. This is the pre-screw, and then during screw, where we can able to appreciate, like with pre-screw, there is a continuous change or increase in the current of injury, and then there is a loss of capture, and where there is noted to be no injury, or there is no injury documented there. So this leads to a perforation, and then where we can able to see the tip injury and the ring injury of pacing, where we can able to demonstrate there is the tip injury shows a lower current of injury than the ring injury. So this is, and again we had to reposition the lead here, and then this is an optimal site where we can able to see there is a pre-screw and also continuous pacing and unipolar pacing characteristics, and LVAT is possible with the Stylet driven leads. There we can able to see there is a continuous measurement of impedance. There is a pre-screw shows a W pattern to a QR pattern. So this is our final ECG. So conclusion, when it comes to perforation, LV subendocardium acts as a fibrous and elastic barrier when the lead moves from the right side to the left side of the septum. So when the protection is breached by excessive rotations, so there occurs a perforation into the LV cavity. So where we have a septal perforation less in our experience, because it is likely because our slow rotations during the implant. So the complete penetration of the helix into the cavity can be identified by a loss of capture an absent current of injury or no current of injury, and there is a drop in unipolar pacing impedance. There is a partial perforation and complete perforation. A partial perforation type 2 pattern in their study suspected in patients with RS unipolar electrogram pattern with a low amplitude current of injury. When there is a current of injury, there is noted that the predictors of septal perforation, if noted during the implant, we have to change the position, reposition it at a different site, thus leading to the success of the procedure. And once again, I'd like to thank my mentor here for this opportunity to be able to present it in front of the stalwarts here. Thank you. Late perforation, sir? We haven't had, sir.
Any cases like that?
So when it comes to the conduction system pacing, our protocol is like the patient after the implant, we do complete ECG guided programming, like before the patient goes home. And also there is this complete protocol where we document an unipolar and bipolar, both configurations higher to higher output to the lower output. And also where we can able to demonstrate there is a kind of a change in morphology where there is like selective or non-selective capture. So we do like take the intrinsic, and also we do a complete ECG guided programming before the patient goes home. And also it applies to the same whenever the patient comes back to the device clinic, where it comes to like, we usually call the patient like 1 month afterwards, like after the implant, then we do the same protocol, our conduction system pacing protocol in the device clinic to ensure that everything is safe, sir.
So how frequently do you do this? Do you do this in every single visit? If
Yes, sir.
For all, every time they come, every 6 monthly to.
Yes, sir. We usually call the. Yes.
Wow, that's impressive. That's a lot of work.
But then that's how we produce jumps like this. It's not only the patient care. It is to create jumps like this.
So what happens when you have a perforation like what you demonstrated? I mean, you said you pull the lead back. I assume, do you use the same position, or you just?
We just demonstrated. We didn't lodge it there after pulling it. We just pull it out.
Out and then get to another position.
It's just a demonstration.
Yeah. Because typically once you perf, you don't want to keep that position anymore. It almost certainly will dislodge. Yeah, you have to come back. The track is no good. Get another track. Yeah, don't leave it. Sometimes what I do, because of the Agilisys Pro, it stays in that position although you have pulled the lead back. Sometimes what I do is actually I just inject a little bit of contrast. I actually got a video of that. And you can actually see the whole track going through into the LV. And you can actually see how thick is your septum. So the next time you actually drill, you know how deep you can go, because you can actually highlight the thickness of your septum. So even when you perf, all is not lost. Get as much information as you can.
Yes.
Because usually it's a little anxiety, you know, and as you perforate it, that quickly you come out, you know, that. But you focus and take an injection there, you find the septum much better.
Yeah.
The next time you do not do the same mistake.
Exactly. Learn from a mistake. It's not wrong to make a mistake, but learn from it, so you don't make it again.
Hi. Did you anytime have any vascular injuries when you screw into the septum?
No, thank God.
Coronary
not had one.
septal or venous system, or you inject contrast and it goes into the venous system,
No.
or any arterial
So
septal
far,
injury?
I've not had one. I think I'm quite lucky, you know. I've not had one. I do septogram repeatedly. Okay, so I know, but I've not had one. Yeah, well, it's been reported before, so never say never, but I've not had one, thank God for that. Yeah, I've been asked that question many times. With the tendril leads, it's actually below 500, but above 400. So I find the decrement with regards to impedance from initial screwing in, drop of 100, 150 ohms is where you are going to count. So it depends on when you initially screw in, you pace. If your impedance is 600 ohms, like what we started, chances are you'll be at 450, 500. So if you go in at 550, you know you're probably going to hit about 450 by the time you're in that position. So don't panic, because your starting impedance is already 550 ohms. Often what you see is that the impedance may go up a little bit, then it starts to come down. But I look for the 100, 150 ohms drop. Part of the problem, I think, is because the tendril lead is actually a lot bigger. I'm not too sure about the Boston Scientific and Biotronic. So the impedance is slightly different from the impedance with a tiny little 1.4 millimeter lead, like the 3830. So I think the impedance is quite different. But by and large, our average impedance is slightly below 500. It's more about the 450, 400, 450 mark. Yeah.
Thank you, sir. Thank you.
Thank you so much, Mr. Akram. Now I invite Dr. Sanjay PV, Senior Consultant Cardiologist and Electrophysiologist, SIMS Hospital, and the moderator for this interesting case presentation, Dr. K. Chandrasekhar, Senior Consultant Cardiologist, Department of Cardiology, Prashant Hospital.
Thank you, Ullas, sir, for having me here. And Ullas, sir, has been the inspiration for all of us for conduction system pacing. And particularly with regard to the Abbott lead and the Agilis Pro, my inspiration has been Dr. Tan, because after watching a webinar, we had the courage to go forward with this. So I'll go with my case. So this was a gentleman with who had mitral valve replacement, mechanical aortic valve, and he had a tricuspid annuloplasty. He had mild LV dysfunction. He had disabling palpitation and breathlessness. He was given a very low dose of beta blocker, and 3 days later he had a blackout, and this was the ECG. So the diagnosis was a case of symptomatic tachybrady syndrome, and he was planned for left middle branch area pacing with a St. Jude system. So the steps, I think Dr. Tan and sir had wonderfully illustrated. Probably the most important step is this. I think sir has always reiterated in his talk. So the secondary curve which we should give. So I've done around 5 cases, and thankfully all were successful. And the most important point is that we give a robust curve, and you spend some time doing that. And in fact, I remove and you give the curve with the dilator in, and thereafter you remove the dilator out. You visually assess for your particular RA anatomy or the RV anatomy, is the primary curve sufficient. And in some cases, you can increase the curve or give it again. And this curve is retained maybe for around 15 minutes or so. If required, you can give it again. And the next is to abut the Agilis sheath to the RV septum, and you introduce the tendril lead to the tip of the sheath, and you assess the location of the proximal RV anterior septum by tip unipolar pacing. The standard, you have a positive R wave in lead 2, an RS in lead 3, and AVR, avial discordance. And you introduce the stylet to the tip and expose the helix by rotation as in an active fixation lead. So once in this position, the stylet is almost at the tip of the lead, and then you extend the helix. And then you withdraw the stylet to the RA, and then you give whole body lead turns under fluoroscopy. I give the whole body lead turns as I have been giving for the Medtronic 3830, and it does the job. And probably the most important factor is that withdrawing the stylet up to the RA, because once the stylet is put in very close to the lead tip, I think what happens is the Agilis sheath itself gives you such amount of support that when you make the lead itself stiffer by putting it to the tip, that support is lost. You don't get the torque transmission to the RV septum. So always pull back the stylet to the RA and then go ahead. So as the lead penetrates the septum, very often we see that the tip helix gets retracted, and you assess for left bundle branch capture at this point. Thereafter, I introduce the stylet back to the tip and expose the helix again by rotation of the lead tip with screw. At this point, again, I assess for left bundle branch capture with the standard definitions. If the LVAT is less than 90 millisecond or the unipolar impedance is above 500, I go back to the lead, the 6th point. So you withdraw the stylet back to RA and you start the sequence again. So this particular case, he had a very thick septum. It was post-aortic valve surgery. So the septum was almost 20 millimeters. So I used the baseline catheters, the quadripolar and the HIS, and the temporary in the RV apex. So Agilis sheath, I think compared to our Medtronic 3030, Dr. Avinash had beautifully illustrated that the 315 HIS sheath is very flimsy. So you don't have a problem pushing it into the RV. And I would always advise us to make sure you have the wire inside the RV, you have the dilator, and carefully introduce the sheath into the RV through the annulus. In this case, he had an annuloplasty, so I had to give some maneuvering through to get the sheath in the septum. And finally, after you are in the location, this was actually the lead was deep into the septum. In fact, compared to the Medtronic lead, so from the tip of the lead, from the tip of the helix to the anode, radiopaque part, it's 14.6 millimeter compared to the 11.8 with the Medtronic. So I think this lead was almost 17 or 18 millimeter in. And slitting, another important point, as I demonstrated you, one useful trick is to undo the deflection, make sure your sheath is absolutely straight, and thereafter you start the slitting. And these were the final fluoroscopic views for this particular patient. So this was the electrograms during the procedure, unipolar 5 volt and 1 volt. There was a change from non-selective to selective capture, and these were the ECGs taken at unipolar 5 volt on the left and 1 volt unipolar, which shows some degree of selective capture. And bipolar, again, you can see the change from selective to non-selective. And this was again at bipolar 5 volts, you have more of capture of the RV septum, and bipolar 1 volt, you had a typical RSR. And in this patient, the RV septum was in fact very thick and fibrous, but thankfully I was able to get the lead through. It was more of a distal septal location. And another point which I have commonly seen compared to using the 315 sheath is if you are just giving the septal curve to the sheath and you're getting into the RV, invariably you come to the mid RV septum, not the proximal RV septum. If you want to take it to the proximal RV septum, probably you have to give an extra curve to the primary curve also. And I've done 5 cases inspired by SAR, and thankfully all the cases were successful. I did not have any issues. And the thresholds were stable, and the longest follow-up is just 5 months. So thank you, sir. In this case, I was not able to, sir. I was not able to. Previous cases, one case I was, sir. I was able to get it was a sick sinus syndrome patient, so I was able to demonstrate the potential. Another question I have to sir. So, so the point which we, I think Dr. Tan was asked, so the unipolar impedance where we stop giving additional turns is 500 ohms even for the tendrils, sir? Yeah.
It's not the absolute value. It is the judgment. More than 100, I should caution.
Okay.
Because the beginning itself is about 600. 500 is okay. But in the beginning, when the helix is completely out, and if it is 800 to 900, and then if it is 500, you can be certain that something is into the cavity.
Okay.
Another thing, don't
Okay, sir.
Just look at what was the initial value.
Okay. Okay.
We
Sir.
have a
Thing was that this oblique placement, it causes problems of interpretation of deep impedance also.
Mm-hmm.
Because many times when it goes oblique in the septum, considerable distance,
then we see the thresholds, then we see the impedance rising to the tune of 700, 800. It can go quite high because it's just going parallel to the septum.
Okay.
If it is too oblique. So like for example, if you, in your LAO view, when you take septogram and you think that 18 mm lead is inside, but the septum itself is just 10 or 11 mm thick, then in RAU you please check that how oblique the lead has gone. I don't know, we don't have data of too oblique position, but number one, where you start from the septum, you will not end, or at the opposite side, you will end way forward, so that's not where you intended to go. It's just by chance and you're not repositioning it. So if it's too oblique, I would say that you reposition it.
And then, try not to be too oblique, yeah? Be straighter.
Be straight. Sir, and one more thing.
I mean,
sir.
like it applies to the general rule of life also.
Sir, have you ever used a 3830 lead in the Agilis His Pro and tried screwing it in, sir?
No, that will never work.
It will be too flimsy.
Yeah, absolutely. You know what? You have so much of a room inside the hose pipe. Yeah? This is not catheter. Hello, listening? No, they are not listening. Thank you. So,
Thank you, sir.
This is a hose pipe. Yeah? What? Yeah, 2.5. Yeah, so, yeah. So I'm going to be announcing that, right?
It's ready there. So video will be transmitted here.
No, shall we? So you know what? Actually, we are going to be having a party. Okay. How are you, two girls? You think people are happy about the lead performance? Sheet performance? Where is your Thakur? Is there? Anyway, I think it's just a demonstration. Dr. Tan is going to demonstrate further. You know what? I think this is a great tool. What do you people say? What do you people say? Absolutely. It is just that, on public demand, they may just, take it off, which will again sentimentally will hit me definitely, and, many of the people who have adopted this technology. I hope this technology, survives, and then some modifications will come. Now, what is let's stay back here for another 15-20 minutes for another nice show, which Dr. Tan is very well known for. Actually, he's going to be demonstrating in it's called in vitro, no? Outside the body is in vitro. Yeah, when is it in vivo, no? Yeah, that's okay, whatever. So the wet lab is going to be demonstrating, how actually is the mechanism of the perforation, drilling into this and all that. I think it's a fun thing to watch. So Dr. No, is it audio connected then? No. It's audio connected? Yeah. Dr. Chan, can you hear us?
Yes, I can.
Okay, great. You know what? We are going to be watching the performance on the in vitro material also. We're all excited.
Okay.
Yes. Okay.
I'm just trying to get into the ventricle here. I mean, it's easier if you can come and just do this. Anybody can come. All I'm just trying to do is get to the septum and hopefully demonstrate how well the system can actually septum drill. I don't think I got the septum correct here, unfortunately. This is the porcine part. Okay, I think I cut somewhere in the middle of the septum here. There's blood in there. Dry blood.
Yeah, Akram, I would like to see everything what he is doing, okay?
Oh, okay.
Maybe you can. What about this? Do you want to do the film? We'll get the
So this way.
Then the camera can move all the way here, so you can see everything.
Get that abdominal sheet.
The camera has to focus on what Dr. Tan sees.
You're getting a
Okay. So, இப்படி பண்ணலாம்.
Can you give me a light that works?
இங்க இருந்து காட்ட முடியுமா? அவங்க உள்ள போய்ட்டா? நீங்க உள்ள போயிடுங்க. உள்ள போயிட்டு அவர் என்ன பார்க்கறாரோ ஒரு க்ளோஸ் அப் மட்டும் தான். அந்த க்ளோஸ் அப். அவர் வேண்டாம். அவர் கையில இருந்து அவர் வேண்டாம். அவர் கையில இருந்து மேல இருந்து கீழே க்ளோஸ்.
Well, I'm just cutting it down into the septum. Anyway, I don't think I'm directly at the septum, but I think the point here is not so much the septum or the myocardium, it's to demonstrate that it can actually drill. This was something. Sorry.
You hold the camera, I think, you know, they are not understanding.
Let's set the camera.
No. The camera should be here.
So your camera looks this way. Camera here. You want camera here.
Camera come here and then look straight down.
சரி நீங்க அங்க வாங்க.
Oh, it's 58 cm Stylet. Do you have a
65 centimeters. So basically what we're just going to do is actually to shape the...
Just switch off the...
Dr. Jai, just a question. Have you done some of the studies in the live animal?
No, we started off without live animal. We didn't get the opportunity to do it on the live animal. But when we started this was about a year and a half, coming to 2 years now, that when we introduced with the HIS Pro, there were so many unanswered questions how to deploy, how to shape. We went through that in my talk already. One of the problems, as I said, was actually the deployment of that lead, transmission of torque, and how well can this lead actually punch through that septum. I wasn't even confident that it was going to do that because it's just huge, this lead. It felt huge going through the septum. In fact, all of your training till date, till that point in time, as we go through the septum, we were trained not to go through septums, we were trained just to deploy the helix out, tag it to the septum, conventional pacing. It was never ever to go through the septum. Now we have to go through the septum. Not only do I have to go through the septum, I have to drill through at least 1.5 centimeters. So it wasn't something that we were used to doing. So again, this kind of brings back a lot of memories because I went through a lot of pig's heart, put it that way. We tried pig's heart, we lamb, anything we could get our hands on, we were just having a go at it and seeing how well this leads perform. Now, one of the reasons why, and we can go through how we shape it in the first place, and since we've got a HIS Pro here. So that usually what I do is give you that curve first, so I know that plane, keep that plane flat. This has been shaped a little bit. Give your initial curve. So once you get the initial curve, now like your mons, if you put it against the patient, this has to go down towards your septum. And how I actually do that is that you can make that curve a little bit better, so you know this is the plane, this is the flat plane. You flex it down and move it forward. And really that's all I do. And it really just takes me that long to keep my curve. That's it. So if you go from the left side of the heart, you can see that it's going to point towards the septum. Now we've got actually a perspect model to actually deploy this, and that was used during APHRS to show you how we can actually deploy it. So one of the problems, you have a bypass too. Yep. Bypass too. So one of the ways to do that was actually getting the lead in and testing it to see how well we can actually rotate and send torque from one end to the other end. And a lot of the problems when you start to do something like that is that you can't visualize that torque. It wasn't easy to visualize the torque. How much torque is being built? How much torque are you transmitting from this end to that end? I couldn't see it. You couldn't see it on fluoroscopy. You kind of wish that you can see it on fluoroscopy. In fact, the only thing that you can see on fluoroscopy that torque is being transmitted is when the helix is retracted. That's about the only time you're going to see anything, really. So we have to have some way to actually see that torque being transmitted and how it was being done. It was still not easy. The only way that I could see that was make a little flag. You probably saw me using sellotape, taping it down at the tip, and then rotating and transmitting the torque to see whether that little flag moves and how well it moves. So one way to do that is, I think I showed Dr. Uhas that, is to get the lead in, use the bypass tool. Often with the bypass tool in, you can get the lead up to the end. And once you get towards the end, and you probably saw what we were doing, sorry, this is a bit stiff because it's not flushed through yet. When we deploy, when I introduce that lead into that sheath, the helix is actually withdrawn. I don't do it with the helix extended. Once you come towards the tip, you can deploy it the usual way, which is basically, you can focus this if you want, which is basically making sure that it's contacting against the myocardium before extending that helix. But if you look at this, remember I said that lead is stiff. Now this has a stylet all the way in, and it's making that at least at 3 centimeters before it's stiff. If I pull this all the way back, you can see it's actually more flexible, but even then it won't flex. This is as far as it goes. It won't flex. This entire piece, the housing itself from the tip to the ring, is actually stiff. You got that 1 centimeter that you just cannot bend. Trust me, I tried. Okay, it's not gonna bend. Okay, no matter how much you try. In other words, I don't have to have this lead all the way in. I can still give a lot of backing if I'm just about 1 centimeter away from the center, or even like this, because if you look at it, it's actually very stiff. It doesn't move. This is probably something you cannot do with the 3830 because it's such a thin lead anyway, or for the Solia or the Ingevity lead to start off with, because it's got that little insulation and conductor in between, about the 7mm mark. So that tip is going to be a bit more flexible than your tendril lead. So once you get the tendril lead in order to see how it could actually perform, was actually, I'll probably need a hand here. If you could just hold, come over this up. So you could just hold that sheath. You don't need to just hold the sheath here against the septum. That's it, like what we used to do. Yeah. Just basically, I just need somebody to hold it against the septum because I don't need to do much. And if you hold against the septum, we can actually deploy the helix. And often when I deploy the helix, I put the stylet all the way in. I'm going to deploy the helix, what I would do normally. Anyway, okay, just deploy normally. I can't see it because you use fluoroscopy to see it, but we just deploy that helix to make sure that it's actually in position. Now, in this situation, you don't even necessarily need for it to be completely in position. Can you hold it like that so that I can see? And you can actually see, the reason why I'm pulling back a little bit is that so that we can actually see it coming and rotating and how well we can drill it. And I've not tried this thing, how we can drill, but I'm going to try it. I'm going to pull the stylet back, bypass tool in, and that's all I'm going to do. I'm just going to start to rotate.
You can zero down the camera on the tip of the lead.
Yeah, you can see it's transmitting the torque, and it is drilling through now. Can you see that? It is drilling through very nicely. I probably have to extend the helix a bit there. And it's almost at least 0.5 centimeter through already. Now, in this situation, you probably be fluoroing as well to see to make sure that the helix is not retracted. Yeah. But you can see it's transmitting the torque and it's drilling through that, and it's going through, and that's it. You're already there already. It's 1 centimeter, and the whole thing is through. Okay, and it's actually that straightforward.
Now can you pull and show the biopsy?
Yeah, we can do we can do something like that. You want a big chunk or you want a small chunk? I can do it either way. You want a big chunk, I just yank right now and I get a big chunk. You can still do it. You can do it a few ways.
Imagine you're repositioning.
So if it's repositioning, I don't do anything else. I just hold that lead and I counter. That's all I'm going to do. Can you hold it in position? Make sure you can zoom out. Yeah. So all I'm going to do is just to counter my lead. I don't do anything else.
Zoom in.
Okay, you can see it's countering now. I don't protract that. And that's it.
And show the piece.
Okay. So typically when I do something like that, you don't get a piece there at all.
Okay.
You don't. I can extend that helix out for you.
Yeah.
And you see there's nothing that is clean. But I can make a piece happen if you want. Could you put it back in the same position? Okay, I'm just going to quickly extend it and drill again. Okay, closer to it.
Yeah.
Yeah, just closer to the
And what it demonstrated that the ocean hearts are more forgiving than the human hearts.
Yeah, in a way, but I'm just going to drill it a little bit. Okay, so it's going in now, so it's that easy to go through. Okay, I'm in right now. If I'm in right now and I want to create, so I'm going to extend my helix to make sure that it's all extended when I do that. I can do one or two ways. One way is, if you want to pull a piece out, just yank back. That's not a good idea generally. Typically what we do, and you'll be tempted to do this, is that, and that's true enough, is to try and retract your helix first. Now, I don't know whether this is going to happen, but we can try. So what I'm going to do is I'm going to just retract my helix. I'm not going to rotate the body. I'm just going to start retracting my helix, and then just keep retracting. Now, if you saw that video, if I start to retract, the tip is going to start to rotate, the helix is going to pull back, it's going to suck back myocardium, and that's it. I'm just going to start to retract, and I don't care after I retract. I think it's all in on fluoro, and I'm just going to pull, and I can feel resistance already when I pull out. In this situation, you can't see much of a muscle there. It didn't. Thank God. But I think I destroyed that helix already because it's not even sticking out anymore. Yeah. It's not coming out.
Now. It's out now. It's sprung out. There's muscle.
There's a little bit of muscle at the end of it already, and it doesn't come out.
It's at the very last.
There's a piece of muscle in there. It's not very big, but depending on how you do it, typically there's a little bit of muscle there already. And the video I've shown you is actually as you retract that helix, muscle is being pulled back into it, and as you continue to retract, it actually biopsy a piece out. Just be careful, don't cut yourself. There's a blade there, I believe. Yeah, there's this blade.
So when you clean this, you have to only clean the screw, no? You don't have to clean things in the housing.
Yeah. So if you look at it, if you look at the housing very closely, right, it does retract the helix into the housing itself. Typically, there will be a bit of muscle inside, but you can split the muscle out by re-extending your helix. But keep something in mind. Sometimes with the piece of muscle inside, depending on how big is it, you don't have to just put it on a glove and show it. Depending on how big that muscle, I'm sure you have that experience. The bigger that piece of muscle, you may not be able to retract or extend your helix anymore. You could just clog up everything basically, and the thing is just completely stuck. Often when you see something like that, you can try and remove the muscle, but inevitably that lead is done. You need another lead. It's not going to work anymore. Okay, just forget it. But often when we do this, that means when I retract that lead, I do not retract the helix first. If I do not retract the helix and I just retract the body, you saw how I did it the first time. The helix stays completely extended and the entire lead will just fall back into the sheath, and you just remove the lead that way. And since we've been doing that, we have not had any entrapment or anything like that at all. It just comes out very easily, no matter how deep I go. Okay, and the other thing I would say also is that I mentioned this as well. If you start to get resistance, and if that helix keeps being retracted and you cannot talk anymore, don't try to fight this. Get to another place. If there's fibrous tissue, no matter how hard or how many times you try, it's just not going to get through. I think Dr. Ulhas had that problem earlier on at his position. If you try and you cannot, just go somewhere else. There's no point trying something that's never going to work in the first place because there's too much fibrous tissue. Go somewhere else, try. If you're in the correct position and you can drill, it goes through very, very easily. You really don't have to do much for it, and it just punches right through.
Dr. Tyler, if you apply some force to the sheath, it probably only dents, right? It doesn't go in and injure them. Can you show that how much, with different force, how much can you injure the muscle versus just dent the muscle? Does your sheath...
I see. So the answer is that it definitely can injure the muscle because that tip is actually quite stiff. You can feel that. It can, but how much force depends on how much counter force that I'm putting. Probably maxed out like that. Anything beyond that, it's probably like that. I don't know whether you can biopsy, but you can certainly see a print on the muscle there. You can definitely see that.
Yes.
So I think as far as the muscle is concerned, if you fluoro and make sure you're in the septum, I don't think I have not had anything, no matter how much force I've applied, that it has actually gone through the septum itself with just the sheath. You can cut the septum but I've never had anybody gone beyond maybe 2-3 millimeter, nothing beyond that really. But if you end up in the free wall, for some crazy reason it's on the free wall of the RV and you flex and you put force on it, can it perforate? Almost certainly.
Yeah.
If you stick this into the CS and you flex it and you push it forward, can it tear your CS? Oh, definitely. We did that before. Trust me.
Yes.
When we first started to use this, we weren't aware. We didn't connect the HIS Pro first. We weren't aware that actually the tip was in the CS already. Flex it, push it forward, you just dissect. So if you go into a vascular tissue, to just be very, very careful with this. This thing is big. This thing is stiff. It's got quite sharp at the end of it. Make sure it's in the septum. I fluoro. I use the EGM to guide me. Okay, just be very careful, treat it with respect, don't be rough with it. Okay? Yeah, I don't know, anybody could come here and have a go at it if you want. Okay, it's easy, it's quite a fresh heart actually. It's quite nice. Okay, if you've not used it before, how easy it is to use one of these leads to actually go through the septum. Okay, you look at it, it doesn't take a lot of effort at all. The first time I did it, I thought I could go through the septum, go through the LV free wall, and probably go into the lung if I have to, and this thing would just keep going really. It didn't need much effort at all. Okay? Yeah. Good. Yeah. Thank you.
Thank you. So, Dr. Chan, wonderful. And your final, some comments from the about guy here.
Oh, sure.
Yeah, so thank you, esteemed faculty and attendees, Dr. Ulas. So I think, I'm sure that it has been a good, a learning experience for all of you, as it is for us also. As you are all are learning, we also are kind of, maturing in this particular the hardware and better results for the patients. So I'm sure that you all will kind of go back. Of course, we have tomorrow's day as well. But I'm sure that this learning and all the experience shared by Dr. Tan was informative and will be useful in your practice as well. So with that, thank you so much for us being a part of this journey as well with you all. So we can head to Hotel Feathers, where the dinner symposium is organized, and the arrangements have already been made by so we can all proceed there as well. Yeah. Thank you so much.
Anybody want to play? I drilled a lot of hearts, trust me. A lot of hearts. There are all sorts of ways to do it. But I didn't show you, you could take this away and just rotate. It's not moving at all. I'm crippling.
But you always pull back while you're...
That's right. You see, this is without hemostasis valves out. Right? I don't have my bypass too. And you can see what's happening already as I rotate. It's crinkling already, it's not transmitting top towards the end. Because this thing is holding it in a position.